Friends, welcome you all to the historic World Conference on COVID and Critical Care. This morning, 22nd October, IST 8 a.m., we initiate our scientific proceedings with morning plenary session. I invite chairpersons for the same. Dr. Ranveer Tyagi, Head of Critical Care Department, Synergy Plus Hospital, Agra. Dr. Lalit Singh, Professor, HOD, SRMS Hospital, Bareilly. Dr. Mahir El Behrani, he is the Senior Consultant, Department of Anesthesia and Critical Care, the Royal Hospital, Muscat, Oman. Dr. K.K. Parikh, Senior Consultant in Medicine and Director, KK Hospital and SN Parikh Hospital, Multispeciality. Dr. Banamba Ray, HOD Critical Care with some Ultimate Medicare, Bhubaneswar. With this, I request the chairperson, Dr. Ranveer Tyagi, to carry on the proceedings.
Good morning to all. Thank you, Dr. Deepti, for your kind introduction. Now I invite our first speaker of this World Conference, Professor Mitch Levy. Professor Mitch Levy, no need to introduction, just designation is the Chief in Division of Critical Care and Pulmonary and Sleep Medicine, Department of Medicine, and Professor, the Warren Alpert Medical School of Brown University. He is also Medical Director of Medical Intensive Care Unit at Rhode Island Hospital, Providence, Rhode Island. Now, Professor Mitch Levy will speak on COVID yesterday, today, and tomorrow, a professional thought. Now I hand over mic to Professor Mitch Levy, please.
It is my great pleasure to be part of this plenary in particular, and in part of the World Conference on COVID and Critical Care in general. I'd like to talk to you over the next 25 minutes on some thoughts that I have on COVID yesterday, today, and tomorrow. I don't have any disclosures for the purposes of this talk. So let's look at this. I want to talk a little bit about COVID yesterday. What have we learned? I'd like to talk about where are we now in terms of today. And finally, in terms of tomorrow, I'd like to talk a little bit about how do we apply what we have learned. So let's start with what have we learned? Well, I think there's a number of things we've learned, and yet there are also still a number of things we've yet to learn. We know that SARS-CoV-2, COVID-19 is a very different ARDS than we've experienced before. Most of us believe that initially there is a pulmonary vascular injury. Certainly, especially in the latter phases, there's immune activation, and much of the organ failure that we see in COVID-19 is mediated through immune activation. We've learned about our experience as providers, and certainly also as patients, about the helplessness in the face of the new disease. We've seen the rush to publication of some interventions that later turn out to be not the case and not efficacious, and we'll talk about that a little bit more in a bit. We've also seen all of us as providers accept therapies too quickly. We'll also talk about that a little bit more. So let's talk a little bit about what we know and what we don't know about critical illness in COVID-19 patients. So what we know, as I said already, this is not the ARDS that we usually treat. We also know, and all of us have had this experience, that these patients are extremely difficult to sedate. There's a high degree that we've seen of renal failure and the need for dialysis in critically ill patients. We've seen a fair amount of refractory shock, not always associated with secondary bacterial infections, but just simply through immune activation. So we've seen refractory shock. Clearly, there's an associated clotting disorder, and we'll talk about that a little bit more in a minute. And finally, that the duration of respiratory failure and the need for mechanical ventilation is much longer than we're used to in more traditional ARDS. So what we still don't know is a very long list. Even after almost 18 months in this pandemic, we still probably don't know more than we actually know. That is the consistent approach for ventilated patients, and I'll say some more about that. How to sedate these patients properly, when to extubate them, when to use antibiotics. Do we prone patients, whether it's awake proning or on mechanical ventilation or both? Can we prevent severe COVID? And finally, there's a whole host of other unknowns that we really still have yet to learn about in terms of COVID-19. We do know that there's late clinical deterioration. We know that initially, the entry of the SARS-CoV-2 virus is through the upper respiratory endothelium, and then about 2 weeks through the ACE2 receptors, by the way, and then about 2 weeks after the initial infection, in some patients who go on to develop severe COVID-19, there's late clinical deterioration where additional organs that also have ACE2 receptors are targeted. And the ACE2 receptors exist in the brain, which accounts for a lot of the neurotropism and difficulty to sedate these folks that we see. In the heart, which accounts for some of the myocarditis that we see in late COVID-19. The renal failure, the ACE2 receptors are on the kidneys, in the GI tract, and on the distal vasculature. So the late worsening is not only due to direct viral damage, but it's also immune-mediated as well. We also know that there's significant hypercoagulability in COVID-19. We know that all patients, the patients with COVID-19 are all hypercoagulable. There's very high heparin resistance. There's high levels of factor VIII, which is von Willebrand's factor, in the 400 to 600% range. And we also know that von Willebrand's factor has a heparin binding site, so these patients can become extremely heparin resistant. There are also very high fibrinogen levels. And finally, we also know that there's remarkable endothelial disruption and dysfunction. There's denuded endothelium, which then activates tissue factor pathway and contributes, liberates tissue factor and contributes to the hypercoagulability seen in COVID-19. In addition, IL-6 is a major factor in the promoter region for fibrinogen, and we know that IL-6 levels are high in COVID-19 as well. The ACE2 receptor on the endothelial cells causing disruption and exposure of tissue factor and platelet degranulation. And finally, we also know that ACE2 is present on endothelial cells. Much of what I'm going to talk about are from the COVID-19 National Institute of Health treatment guidelines from the United States. I'm on a panel of 30 members, half of whom are critical care and half of whom are infectious disease. And we were appointed by Dr. Anthony Fauci to create these guidelines. We've been doing this now for over 18 months, and they're available on the website that you see at the bottom of your screen here. And I would encourage you, all of you to look for the treatment guidelines. We update these treatment guidelines on a very regular basis, at least monthly. So what have we learned? Well, there are certain things that we know work. Most importantly, masking, the use of surgical masks and/or N95s, social distancing, cultural shutdowns. We've seen through a number of published studies, in fact, the impact of cultural shutdowns. And I know that you've gone through one in India. We've gone through them in various states in the United States. We've seen them in Germany, France, in many, many cultures across the globe. And we see the impact in controlling various surges through the use of cultural shutdowns, social distancing, and masking. In addition, we're also aware of the personal protective equipment and the ability to prevent a spread to healthcare providers in either on the wards or in intensive care units. And obviously what we also know works is the power of vaccines, various vaccines, Pfizer, Moderna, and J&J. We also know and have learned that we've accepted too many interventions too quickly. Probably the foremost amongst those are hydroxychloroquine and the use of azithromycin, in addition to hydroxychloroquine or chloroquine, and honestly, the use of convalescent plasma, and I'm going to talk about that again in a moment. Again, the treatment guidelines. So hydroxychloroquine and azithromycin is a great example of a recommendation that we used too quickly. Some of the early literature, and that was based on mainly assumptions of the efficacy of hydroxychloroquine and azithromycin in combination. And in fact, once the randomized controlled trials became available, it became clear that in fact, there was no efficacy for hydroxychloroquine or azithromycin. And in fact, there have been multiple reports of deleterious side effects associated with both hydroxychloroquine and chloroquine. And so therefore, our current recommendations in our panel guidelines recommends against the use of hydroxychloroquine or chloroquine and or azithromycin for the treatment of COVID-19 in hospitalized patients. And that's an A1. So A1 is the strongest recommendation that we make, and it's based on multiple well-done randomized controlled trials. In addition, even in non-hospitalized patients, there have been several well-done randomized controlled trials, and that's an A2 recommendation. So clearly good evidence demonstrating the lack of efficacy of hydroxychloroquine and azithromycin. Convalescent plasma is another one that initially there was some observational data, primarily from the Mayo Clinic in the United States, that led, certainly in the United States, an emergency use authorization of convalescent plasma. And then there have been subsequently multiple well-done randomized controlled trials, in particular, the recovery trial, which was published and peer-reviewed, the Concor 1 published and peer-reviewed, and the REMAP CAP COVID trial, all of which demonstrated a lack of efficacy in hospitalized patients in whom convalescent plasma has been used. So therefore, currently, our recommendations are against the use of COVID-19 convalescent plasma for the treatment of COVID-19 in hospitalized patients who do not have impaired immunity and require supplemental oxygen. And even in patients with impaired immunity, we think that there's insufficient evidence currently in the literature to recommend either for or against the use of convalescent plasma in patients with impaired immunity. So overwhelmingly, the data are against the use of convalescent plasma in these patients. I think what's also important to say is out of helplessness, we overgeneralize therapies. That's in particularly true with the use of dexamethasone. Clearly, we all would agree, and there has been excellent data from recovery that demonstrated the power of dexamethasone and other systemic glucocorticoids in hospitalized patients, especially those receiving supplemental oxygen. However, there has been also the beginning of a use of dexamethasone for outpatients. And we recommend against generalizing the use of dexamethasone for outpatients in the absence of another indication. And that's an A3 recommendation. So in summary, there are no data to support the use of dexamethasone in outpatient data, in outpatients with COVID-19. Ivermectin is another agent that causes, I don't know what the word would be, emotional fervor, perhaps, emotional outrage, and yet there are no data in COVID-19 to support the use of ivermectin. There are simply, and this is a recommendation again from the NIH panel in the United States, we believe that there are insufficient data for the panel to recommend either for or against the use of ivermectin for the treatment of COVID-19. More recently, we have also, we think that there are the results from adequately powered, well-designed and well-conducted trials are needed and really absent. There was recently a release of the recovery trial, which was a well-done randomized controlled trial that evaluated the use of ivermectin versus placebo in COVID-19 patients. And that trial was completely negative. Now that's still yet to be peer reviewed and has not yet been published and is not yet available as a preprint. So you're hearing it first, but there was recovery, as we know, who also did the dexamethasone trial and several other trials. It's a UK-based randomized controlled trial network that in this case looked at ivermectin and was the first well-done randomized controlled trial to clearly demonstrate no benefit for ivermectin. So I believe that we will, as a NIH panel, be changing our recommendation against ivermectin. And there have been numerous reports of deleterious effects in patients who actually wind up using animal ivermectin, especially in the United States. So although there's a lot of emotion around ivermectin, there are simply no data to support the use of ivermectin. And now, because of the recovery trial, there's a well-done randomized controlled trial that failed to demonstrate any benefit of the use of ivermectin. So let's talk about where we are now, my thoughts about today. I think this is really important. If you look at the therapies that have been demonstrated to be efficacious for COVID-19, it's really the primary push, I would say, is to prevent progression to serious illness and hospitalization. That's really important. We have very limited successful interventions for both hospitalized patients, apart from remdesivir and dexamethasone. Really, the point is to use the monoclonal antibodies for outpatients to prevent hospitalization. That's really been demonstrated to be the most efficacious. And there are even fewer successful interventions for critically ill patients. Again, I mentioned, other than remdesivir and dexamethasone, there really are no good therapies for either hospitalized or critically ill patients. So it does seem like primarily in terms of where we are today, it's to prevent the evolution of serious illness and critical illness in patients by using monoclonal antibodies early. Of course, we have tocilizumab and baricitinib, which we will add in patients who rapidly deteriorate either on the medical wards or in the intensive care unit. But both toci and baricitinib are in short supply in many countries and in the United States. And so we really still are left with remdesivir and dexamethasone as the agents in hospitalized patients. BAM and EDDI, as I mentioned already, for mild to moderate COVID, non-hospitalized patients, to me is the mainstay of therapy in COVID-19 right now. Getting to outpatients early with monoclonal antibodies is probably the one thing, and preventing serious illness, that is probably the most important thing currently available in the treatment of COVID-19. I wanted to say one thing about colchicine. Our recommendation is that there are insufficient data for COVID-19 treatment guidelines treatment to recommend either for or against the use of colchicine for the treatment of non-hospitalized patients. We actively recommend against the use of colchicine in hospitalized patients, except in a clinical trial, and that's a strong A3 recommendation. So in summary, although there are people using colchicine, there are currently no data either in outpatients or in inpatients to support the use of colchicine in COVID-19 for COVID-19. Tocilizumab is a very interesting story, and it's interesting because there now are several well-done randomized controlled trials from the Recovery UK in the network in the United Kingdom and from Remap Cap COVID in the United States that demonstrated the efficacy of 8 milligrams per kilogram in combination with dexamethasone of tocilizumab. Now, this is very important. As we know, tocilizumab is an IL-6 blocker. And what's interesting is that all of the trials with IL-6 blockers prior to the era of routine use of dexamethasone were negative. And so that's why we recommend that you always use toci in combination with dexamethasone in hospitalized patients who are exhibiting rapid respiratory decompensation due to COVID-19. And this is interesting because the initial trials, as I said already, prior to the use of dexamethasone were all negative. In addition, what's interesting about toci is that IL-6 levels don't predict response to toci. And so there's some confusion around toci, although there are two well-done, as I said, RCTs that demonstrated efficacy of tocilizumab. It is tough to understand why, number one, IL-6 levels are lower than in most common septic patients, and number two, that actual IL-6 levels don't predict response to toci. Adds a little bit of confusion. Having said that, if available, the panel and I use tocilizumab in patients, especially on the wards or in the intensive care unit, who rapidly deteriorate. Again, this is who should receive tocilizumab. This is how we recommend in the panel. People who are recently hospitalized within the first 3 days of admission, or who have been admitted to the intensive care unit within the prior 24 hours. The patients admitted to the intensive care unit within 24 hours and who require invasive mechanical ventilation was the entry criteria for the Remap Cap COVID trial that demonstrated a positive survival benefit of tocilizumab. So that's who we recommend currently in the panel of who should receive tocilizumab. We do recommend sarilumab as an alternative to toci. Unfortunately, both of these agents, both of which are IL-6 blockers, are hard to come by right now, certainly in the United States. And so although they've been demonstrated to have a survival benefit, they are not always widely available. I did want to say something, as I mentioned earlier, about awake proning. You'll see here, I think many of you know this trial. This was published just recently at the end of the summer by Lancet Respiratory Medicine. This was a multi-center, multinational trial on awake proning for COVID-19 patients who were not mechanically ventilated. What's interesting and really needs to be noted here is, although there seemed to be a survival benefit for awake proning, and there are, by the way, multiple ongoing randomized controlled trials for awake proning, the average duration of awake proning, 40% of patients did not tolerate awake, 60% did not tolerate awake proning, only 40% tolerated. And that's my experience, that the patients who tolerate awake proning are unfortunately a minority of patients. In addition, the benefit was primarily demonstrated in the Mexican cohort and was not demonstrated in the other cohorts, the other national country trials, including Canada and the United States. Importantly, the duration of proning was initially intended to be 8 to 9 hours, and yet the median duration of proning was only about 2.5 hours. So I would say, and that's why we recommend that we do recommend a trial of awake proning in patients who are receiving either high flow nasal cannula or BiPAP and non-invasive ventilation. And we do think it's worth trying to have people self-prone. And unfortunately, most people don't tolerate self-proning, but I do think it's worth a try. So let's end with how do we apply what's coming tomorrow, and how do we apply what we've learned? Well, I think that's the most important thing that I want to say to you, which is trust evidence-based medicine. Although I've said to you already that this is a different ARDS, I think the truth is, and I'm in another talk going to address the high versus low compliance phenotypes, but whether or not you believe in the high versus low phenotypes, the truth is that most patients eventually, especially those who receive mechanical ventilation, develop a much more traditional ARDS. So I think it's really important to practice evidence-based medicine, even though this is a different kind of ARDS. And it's just as important to individualize patient therapy. That is, if a patient doesn't tolerate awake proning, high PEEP, or spontaneous ventilation, then don't use it. It seems almost self-evident, and yet everybody wants to argue, oh, I believe in a high compliance state. I believe in the type L phenotype. I think we should not use high PEEP. Honestly, if you go to the bedside of a person who's been mechanically intubated and is now on mechanical ventilation, and when you apply a higher PEEP, they don't tolerate it and they desaturate, then don't use it. And that's often what we do, especially in patients early on in mechanical ventilation. When we find that they don't tolerate high PEEP, we don't use it. The same thing's true with spontaneous ventilation. Whether or not you believe in P-Cili, if you have a patient who's clearly in distress on pressure support and generating very wide intrathoracic swings and high work of breathing, then don't do it. Paralyze them and use a traditional 6 cc's per kilogram. And the same thing as I've already said for awake proning. If a patient doesn't tolerate awake proning, you have no choice but to simply not use it. So what else? I think it's important in terms of trusting evidence-based medicine that we apply what we already understand about ARDS. Let's not be distracted by COVID-19. Yes, COVID-19, as I've said already, is a more procoagulant state, that clearly these patients, especially non-mechanically ventilated patients, benefit, as we've demonstrated in the United States, from anticoagulation, but not patients who are already mechanically ventilated. But let's not be distracted. Use low tidal volume. Use high PEEP when it works. Proning, we prone patients repeatedly, and I've already been on a panel earlier that will come later in this conference, where many of us have had the experience of proning mechanically ventilated patients 3, 4, 5, 6 times. In fact, in my intensive care unit, we write on the glass window, on the glass doors, when the last time the patient was proned, because we do it so frequently just to keep track. So low tidal volume, PEEP when it works, and I would continue to prone until it's essentially a dose response curve. Once proning stops working, that's when I stop proning patients. And then finally, we use ECMO as a last resort. I will say that our ECMO runs are lasting a very long time, whereas traditionally our ECMO runs with more traditional ARDS may only be for about 7 or 10 days. These patients are staying on ECMO for 4, 5, 6 weeks, often before we see recovery. So ECMO is a very large resource investment, and unfortunately, we're not seeing the survival in ECMO that we saw in more traditional ARDS. So finally, in conclusion, I would say, please consider using monoclonal antibodies for mild disease. I think preventing serious illness is the key to proper treatment in COVID-19. Avoid steroids for mild disease. We should use routinely, standard of care should be dexamethasone for hospitalized patients. I do think if it's available, we should use tocilizumab or the alternative. Hopefully I've made the case to not use ivermectin. And finally, get the vaccine. And I would end by saying, I know we all feel we are tired of this pandemic. And I know I speak for all of us when I say we're hoping that this is not with us and that we can all be in person next year and enjoy each other's company. So with that, I'll say how much I appreciate being able to be part of the opening plenary. And I look forward to being able to answer questions in the live session. Thank you very much and goodbye.
Thank you, Dr. Mitch Levy, for your excellent deliberation. A lot of things you have covered, sir. I think everything overview almost you have covered. Many months ago, you yourself were saying that tocilizumab is not something that we should think about. Today, you said that tocilizumab you should give along with dexamethasone. What is your comment? What has happened in the intervening many months that you have now recommended?
Yeah, that's a very good question. And I think the reason that we've now the NIH panel in the United States is recommending tocilizumab is because of the two important trials that came out, well done randomized controlled trials, one of them being the REMAP CAP COVID trial and the other being the recovery trial in the United Kingdom. And I think the important thing to note there, as I said in my video, is that all the prior RCTs with tocilizumab prior to the use of steroids were negative. And for some reason, in the two large RCTs that were done when steroids were standard of care, were both positive and showed a survival benefit. So it's hard to quite understand why IL-6 blocker would benefit from being given with steroids, but nonetheless, these are two well-done randomized controlled trials, which is why we recommend it.
Would you like to exclude that there is no infection before you decide to give tocilizumab, even during the first 48 hours of the deterioration?
Well, as you know, it's almost impossible to exclude a secondary bacterial infection in these patients. So we use tocilizumab. We go ahead and use it. It's when someone rapidly deteriorates or is admitted to the intensive care unit within 24 hours. I will also say that tocilizumab is in short supply in many states in the United States, so it's not that easy to find.
What is your opinion about the monoclonal antibody mixture in the earlier stage of the disease, particularly in the first week?
As I said in the video, I think it's important, and I think it's important for a number of reasons. One, it does seem to prevent serious illness and hospitalization, and I really think that's the key right now in surviving COVID, which is staying out of the hospital. Not that the hospital, of course, is bad, but that we don't really have very good effective therapies for hospitalized patients, and certainly not in critically ill patients, apart from remdesivir and dexamethasone. So I think the combination of BAM-EDI monoclonal antibodies is effective in preventing hospitalization, which is really important in treating COVID.
You would recommend this to be given to the patient when he is hospitalized, or you can just give it and send him back home?
Well, we administer to outpatients, outpatients who are not doing well, but not outpatients who require any supplemental oxygen. So prior to hospitalization is when we administer the monoclonals.
Thank you, sir, very much. I think it has been an excellent deliberation and all of us have benefited from your lecture. Thanks
My
a
pleasure.
lot,
Thank you.
Dr. Mitch Levy, as always. Now we go on to the next lecture.
Good morning to all. Next speaker of this plenary session is Dr. Dhruv Chaudhary. He is a senior physician and head of the Department of Respiratory and Critical Care at PGIMS Rohtak. He is a past president of Indian Society of Critical Care Medicine. He recently received FAMS. Now I request Dr. Dhruv Chaudhary to continue his talk.
Good morning, my dear friends. I'm extremely grateful to Dr. Rungta for giving me an opportunity to talk about and discuss about COVID ARDS. In particular, last 1.5 years, all of us in the critical care community have faced the brunt of this disease, where we started from early ventilation, then went up to no ventilation, avoiding ventilation, and then taking a full circle and following the basic principles of management of ARDS. That's the nutshell, is the story with which what we have learned over the last 18 months or so. Nevertheless, it has been a very encouraging for us that over a period of time from nihilism in ventilation, we have gone back to what we have been practicing. Therefore, over the next 20-25 minutes, I shall primarily be discussing what we have learned, what we have to do extra, in particularly besides ventilatory care or oxygen therapy, which is primarily the supportive therapy, how we can go ahead and improve the outcomes by good use of definitive therapies, which we learned over the last 18 months or so. And Henry Ford said, anyone who keeps learning stays young. I will say that anyone who kept learning was able to handle the COVID patients better. And it brought out another important concept that less is more. And also at the same time, it let us know that it's always good practicing quite to stick to the basics. But in our exuberance or in our order to do something extraordinary, we sometimes create situations which can be difficult to handle, and that's what COVID has shown us. As I said, stick to the basics. It is important to understand the COVID-19 disease timeline. We all know that there is an initial phase of incubation, which is roughly 4 to 5 days. Then you have an onset of symptoms when the persons are most infected. Then nearly it takes 7 to 10 days when persons start having symptoms of breathlessness, recurrence of fever or high-grade fever. And along with it, over next 1 week period, either people recover or they go into what we call, because of immune dysregulation, macrophage activation, endothelitis, and thrombopathy, into a syndrome, what is acute respiratory distress syndrome, or they may go into multi-organ dysfunction syndrome. And to a very large extent, we consider it to be because of viremia leading on to excessive cytokine. In simple words, the early phase dominantly is a viremic phase, and late phase tends to be immunopathy, where you see dysregulation, along with it involvement of endothelium. Not only endothelium involvement is there, but it also predisposes to thrombopathy. And today we know that when we talk in terms of pathogenesis of COVID-associated lung injury, I would start with that. And ARDS is an extreme of that spectrum. So what we see is a multiple components, and that has led to a concept of phenotypes and differential management strategies. Besides a consequence physiological of it is of hypoxemia, which we need to do it. And some of the people did talk about happy hypoxemia, etc., etc. Primarily, if you see it, the incidence, let's look at first at the incidence of ARDS and what are the outcomes. This is the studies published early in Critical Care 2020, and this is not too much of a difference what we saw last year in the first wave, and it's no different. Second wave has been no different, except that we had a deluge of cases and our systems got overwhelmed, leading on to oxygen outages, leading on to ventilator outages, ICU outages, hospital bed outages. Nearly 5% of the total patients will require intensive care unit who are infected with the COVID, and out of them, 1/3 are nearly going to develop ARDS. And by and large, looking at it, what they found in China, that 1 in 4 were transferred to an intensive care unit and majority were managed in high dependency unit. Out of them, nearly 16% received invasive mechanical ventilation and 16% died. However, the patients who were transferred to an ICU, nearly 2/3 received intensive invasive mechanical ventilation, and 75% of those who received invasive mechanical ventilation had ARDS. Mortality of the intensive care units, what we found out was nearly 40%, and who received invasive mechanical ventilation was approximately 60%. The mortality rate later on, when these people start getting a little more information, knowledge, or experience about it, was around about 45%. And the non-survivor primarily mode of death was, or the cause of death was, acute respiratory distress syndrome. In fact, that's why a lot of people who went on ventilator didn't recover, that inhalism had come into picture. Therefore, it led to a concern that can we identify people who have ARDS a little early, and we put our guns and resources. These were the early days in the last February. We saw those horrifying pictures from Wuhan, later on other countries and from Italy. And also we faced same sort of a trouble in the month of April and May this year. What we had realized early was that the people who are elderly, people who have been resident in nursing homes or long-term care facilities who were frail, had a poor immunity, persons who had an immunocompromised disease and primarily had a chronic lung disease like COPD, asthma, where they have 2.5 to 4.5-fold high incidence of developing severe disease. People who had a cardiovascular disease, cancer, or hypertension had a high incidence. But what was very astonishing was we all has been talking about obesity. But our clinical experience is now telling us is that overweight itself, or the so-called metabolic syndrome, where people had an apple-shaped obesity, along with it, they had associated hypertension, blood pressure, diabetes, or they had other related issues. They were at a far more higher risk. And when the two things were together, nearly 4.5 times or more of developing ARDS and complications. Hematological disorders and pregnancy, initially was thought is not a challenge, but later on one realized that pregnancy itself being an immunosuppressed state was also contributing, like influenza, to an excess mortality. This was published in Nature Scientific Reports in 2021 itself. And they've again found out that the age of the people who are having median age of patients who had ARDS was 56.1, that they were the non-ARDS people. And the difference between from the non-COVID ARDS was more than 7.5. Again, male and female patients having more than BMI 25, that's what I said, overweight or the so-called metabolic syndrome, people had far more higher features. Clinically, obviously, as expected, majority had cough, and they had a panting respiration called sometimes a fast breathing called as polyapnea, which also had been a significant factor for causing barotrauma in these patients. And also radiologically and clinically also we found lung consolidation, secondary bacterial infection and fungal infections were seen in 1/3 and nearly 24% or 1/4 of these cases. Also, people have significant abnormal indicators, especially when we looked at it, creatine kinase, a predominantly nuclear neutrophilic lymphocytic ratio. When we saw from the first week and when people went into second week, who had skewed neutrophilic lymphocytic ratio more than 3.5 or at a far higher risk of developing ARDS. So that way it was possible for us to see and look at it, who are the people likely to go into it and what were observations. Machine learning and AI has also collaborated the same. And CRP was also found to be very strongly correlated, which was some sort of a surrogate, which we took it up for inflammation. When we started looking at the autopsy studies, which they started coming up, they showed, like a normal ARDS, presence of thrombosis and microangiopathy in the vessels. and capillaries in the lungs, and it had both post-capillary and pre-capillary component, but dominantly post-capillary component. There was a significant diffuse alveolar damage, including hyaline membrane formation, which was also not unusual. That's what we see in patients of ARDS, because type 2 alveolocytes, which are having an abundance of ACE2 receptors along with TMPSS2, which is there, transmembrane seroproteinases 2, which are combination, which is much more there, were infected. And also important to realize is that ACE2 was ubiquitous not only in the lung, and lung also had a large area. That was the first area which got infected by it, and also at other places. And particularly involvement of carotid body was associated with the so-called happy hypoxia, where people were not aware about it, that they were breathlessness and they didn't have as much tachypnea at that point of time. We also had a cardiac involvement. But what is very important, what did it show us? It showed us when the electron microscopy was done, that continued to be presence of viral particles within that. In simple words, it was the presence of the virus particles in the alveolo-capillary membrane, which was deriving the inflammation, and that inflammation itself was causing damage. Therefore, a timeline came up, and we started knowing what is happening is subacute lung injury and going with the vascular damage, airway damage, and a pleural inflammation. Small airways did involve in it, but larger airways by and large were not involved, but they do have a tracheobronchitis. So because they again had an abundance of AC2 in it, we are primarily lifting our cell. Therefore, if you see what we saw was the diffuse alveolar damage, we saw thrombopathy, and along with it, we also saw the formation of hyaline membrane disease. And these type 2 are extremely important because surfactants are produced by them. And we found that there was an area of a peripheral involvement. And along with it, the thrombosis, I said earlier, that post-capillary thrombosis was much commoner in these cases. And what we found out a concept, which is called as a netosis, where what we find neutrophilic entrapment, which was happening. And no wonder we were finding in these patients a lot of neutrophilia, and there is a marked lymphopenia. That itself was an indicator of poor prognosis. This is a famous photograph or a cartoon from New England Journal of Medicine, where we found out and it is the neutrophilic oxidative damage along with microthrombosis, which leads to ARDS. Now, ARDS as a syndrome is not a disease. So irrespective of the cause, we find out that there is an extensive involvement of alveolus with a leaking capillary syndrome or non-cardiogenic pulmonary edema. And the definition over time was oxygen-resistant hypoxemia, and that's what we found out. And obviously, we need to find that there's no cardiac abnormality in these cases. The same holds true also for the COVID. And that is what we found out, that initial after phase of incubation, there was an early phase, infectivity was with the onset of clinical symptom. By 10th day, this had gone away, and this is the viral threshold, which is coming up, which you can detect it. And by 8 to 10, then nearly 90% reduction in that had taken place, and by and large, they cleared off in majority. But once they did not clear off, the inflammatory phase started up, and we are seeing it going aberrant, it going totally haywire, causing extensive damage, and the collateral damage took place, responsible for ARDS like any other virus. But initially, we had defined different phenotypes, which was Gattinoni came up, and they looked at it, that some of the people may not have as extensive the lung disease, but they had a very significant hypoxemia, the so-called the L and the H type. I will come to that a little later. Signs, symptoms, I've already talked about it, but most important to remember is the starting of a cough for 7th to 10th day was a harbinger of lung involvement. Fever, which had disappeared, recurrence of it or high-grade fever from the low-grade was again telling us that something is going wrong, which was because of excess cytokine in the body. And people started feeling breathlessness because of exudation of fluid. And obviously, there was a significant VQ mismatch. It also led to significant tachycardia. It was later on that we found labored breathing, cyanosis, hypoxemia. Obviously, because of the fast rate, we had a respiratory alkalosis. When we intubated, we did find a lot of frothy spurums. Breath sounds have been abnormal, bilateral crackles, consolidation, and later on altered sensorium. Severity was defined on the pattern of the Berlin, and we looked at it on the basis of it, whether it's a mild, moderate, or severe ARDS. And though we are talking in terms of PEEP or CPAP, we modified it when we critically using it, what is called as the Kigali equation, which was done for the low middle income countries to begin with in the ARDS, where you will see SpO2 FiO2 ratio. There we see anything which was less than 315 was taken up as an acute lung injury, which is defined up to 205 or 10. If we take it as a mild, then obviously the moderate. And the severe one we have been taking up practically less than 150. So that way, from the clinically without doing a blood gases, we were in a position to pick it up. And what is important again is that we looked all four components, the timing, the imaging, and the origin of edema and oxygenation. That means there was no cardiac edema per se in these cases, or fluid overload was there. So that was very important to exclude hydrostatic component. This is again, a difference has been published in the Blue Journal in this late last year, and they try to compare of demographic, physiological parameters, and inflammatory biomarkers and outcome between COVID and non-COVID ARDS. You will find it out. There was a significant hypoxemia, but bacterial were the worst. And along with it, we also find out that the minimum minute ventilation was also in these patients are relatively lesser than the other causes of hypoxemia, which takes place for the ARDS, which occurs whether because of other viruses, bacterial culture. And what was another interesting component was relativity compliance was better to begin with. So there was a lot of heterogeneity which had come up in these cases, but later on as the disease progressed from N and H type, that means the better compliance, we went on to develop poor compliance. So it is important for us to understand this pathophysiology as differential. And what did we find? We also find that cytokine profiling was much lesser in these patients like IL-6, which became probably a common word in the jargon of physicians and as well as the common people. We found out that probably COVID ARDS had a significant elevated IL-6, but they were far lesser than the bacterial and other infections. But nevertheless, we realized that there was a significant cytokine release along with CRP and IL-6, which were telling us, yes, this patient is getting a cytokine syndrome. But important to remember is that definitely they had a significant hypoxemia. But if you see the shades which we saw, and only 1.5 to 2% of the total group of patients out of 100 had severe ARDS. When we talk in terms of phenotype, they were defined on the basis of the clinical as well as radiological parameters and also physiological parameters. When you have three major types have been defined, that's what we have learned, that phenotype 1, phenotype 2, and phenotype 3. It is important for us to realize that probably as the blood is, as the lung is extremely rich in vasculature, practically whole body as cardiac output, which the whole cardiac output comes into the lungs. There's no other organ which receives the whole cardiac output. So like kidney, we need to look into it, that whether there are different components of it, like you have an alveolar capillary membrane, you have a glomerular basement membrane. So here you will see some will be subepithelial, some will be subendothelial, some will be involving inflammation. So when you see this, the peripheral lesion, here we find in the phenotype, there were multiple focal possibility of over-pursued ground glass opacities was seen. And what we found, lung compliance was normal or maybe higher sometimes, but people have severe hypoxemia. And it was primarily considered to be because of VQ shunting, which was there, and also loss of capillary tones, and probably an incidence of a post capillary thrombosis responsible for it. If hypoxemia remains unimproved, people did consider invasive INO, that is the inhaled nitrous oxide. We have no experience, but that is what has been there. And we must need to look at thromboembolic. There is another group of people where we found large amount of D-dimers, which led to a theory of everybody being put onto low molecular weight happening with this. Another one, the phenotype 2, which is not unusual. And we have been all seeing with the, we are seeing it much more with the use of CT scans, and especially dual refraction CTs have been telling us, dual energy CT scans have been very good at it, picking up peripheral thrombosis as well as these peripheral variation which have been there. And what we found out here was the inhomogeneously distributed atelectasis, and there was significant peribronchial opacity. Here, Again, atelectasis was a significant component, and hence that means recruitment was possible. And these are the people who did very well with the proning. And we required moderate to high PEEP. And when you looked at it, you prone the people and you were able to recruit non-aerated lung. And this inhomogeneity is one of the interesting aspects, where we found some people were breathless when they were sitting, some people were breathless when they were lying, or they were lying right to left. So we saw all components of positional breathlessness in these cases, depending upon the area of the lung which was involved. And obviously it remained and improved. We looked at recruitment manuals and later entered a prone positioning. And that was the place where we were also using awake proning also in this particular group of patients. Similarly, we had a phenotype 3 where we had a patchy ARDS like pattern and hair alveolar edema and low compliance and ventilatory settings. We looked at it. So you will see it from the phenotype 1 with the high compliance. Gradually, we graduated to phenotype 3 from minimal, either people recovered here, those who did not recover, they went into a classical ARDS-like pattern. And it is this group of people where we find a lot of interstitial shadowing. We also find what was defined as an acute fibrinous with the organizing pneumonias, which did respond to corticoids. This was the group of people who are the most challenging for us to manage up. And in spite of following all the principles of ARDS, a small number of them did not respond. And there we need to use ECMO and other considerations. And also, when they had a sudden spurt of D-dimers, one had to actually find and look at the presence of your microthrombosis in the post-capillary wall. So these distinct treatments are required, and they will. And it was important to identify early because the treatment strategy was different for all of them. And when we started looking at it, we realized early that there was a lot of alteration and a lot of neutrophilic activity has been involved. And people have been trying to use various drug treatments, etc. But what is very important for the diagnosis was RT-PCR positivity, Berlin criteria defined the severity, and the similar management principles we applied, which included negative fluid balance, intubation, ventilation, prone positioning, ECMO, and a secondary infection suspected, antibiotics. So it was very important was that neutrophilic inflammation, how to take care. People did try a lot of drugs, but had not been very successful. But what was the game changer in this when the report came from the recovery trial of the use of steroids, which they used 6 milligram dexamethasone, the landmark group. And consistent, this meta-analysis published in JAMA in 21 showed that it reduced the mortality significantly up to nearly 1/3 of these patients. So the game changer for us was the corticoids and not even the remdesivir or the drugs. Later on, baricitinib has been there, and therefore administration of corticoid, which was started from 10 days, but now we are using for a longer time in certain group of people. People did try to use high dose corticoids, particularly pulse therapy. But remember one thing, minimum dose safety, which has proven test of the time, is 8 milligrams of dexamethasone and or equivalent amount of other corticoids, which will be 32 milligram methylprednisolone and 40 milligram of prednisone. But somewhere where acute inflammatory phase was there and there was a rapid course, we did try methylprednisolone pulses, but that was not more than 250 milligram in a trial setting, knowing exactly what we are doing. And that is what we learned it, that sometimes you need to have a patience and you need to individualize the treatment, but first you need to prove those results with the standard which have been proven to us. Antibody cocktail came at the end of it, again, the recovery trial was, and they found that the people with the seriousness of the disease who were seronegative at that given point of time, they had a significant improvement and outcome and remarkably reduced mortality. That was additional 20%. That is all used along with corticoids and also with the steroids. And now what has happened is again a forest plot, which is showing that those who are negative, they have the lesser mechanical ventilatory days and also death from the use of monoclonal cocktail of casirivimab and imidimumab. And that now has been approved by WHO on 24th of September 21 for the use in patients with severe COVID with ARDS who are seronegative. Now the challenge will be us, now coming up days will be that a large number of population now today, we had hundreds of 100 crore people getting vaccinated. Those who are vaccinated, what to do. But by and large, we follow the same principle. It's a breakthrough infection. So probably we may have to come up with a new trial data, but nevertheless, it has been shown in this subgroup where there was a negative against that particular strain. The antibodies were there. It was found to be useful. That's what I'm saying. ARD is critical one. It has been found to be useful. And I have a personal experience of now using in a severe patients of respiratory distress, which were moderate ARDS, recovering with it of 3 cases. We have now the experience. Ventilatory management, again, critical component, which was there. We looked at the severe disease. We defined, as I said earlier, with the 150. And what we found out, we went straight with the lung protective. Initially, we went early. We had a poor outcomes. Therefore, because one of the major reasons I am now realizing back is the one, we were not aware about the disease. We were not aware of the pathophysiology. And along with it, what was equally important was that intense staffing was not there, which was needed and required for this patient because of personal protection equipment, which was there. Rest all are the principles of ECMO had to be found. It also brings in the jugglery of the jargon of the people, the word high flow nasal cannulas. And we looked at the ROX index for the initially people were trying, initially we were doing to do it early, later on we trying to take longer time. And now we are realizing that the optimal timing is to give adequate time of oxygenation of 48 to 72 hours. If person responds, cardiorespiratory response, you may wait. But if it is not there, as we are doing for other ARDs, conventional ARDs, intubate and ventilate, rather than a person has a good lung compliance, at that point of time, you can wait and watch. I think that's what we look at it. And we are using it a combination of HFNOC and NIV in these patients via lung protective ventilatory strategy. Advantage has been of the HFNC has been the warm air, humidified, minimal oxygen, but the challenge has been the oxygen when deficiency was there or when we had announced oxygen outages. We had a huge challenge. So please check it, your system of oxygen delivery and availability. It guzzles like anything. So try the principles of that we give both flow as well as oxygen. So be careful. Again, it has been clearly shown that when we had used ROX more than 4.94, prognosis outcomes have been there. If your ROX has been less than 4.94, it is a time to say thank you very much to SFNC and switch over to invasive mechanical ventilation. If you are ventilating too late, your outcomes will be poor. So this has stood us now a test as a scrutiny, and we have been following the same principles with us. Invasive ventilation, as I've already talked about to you, this is a comprehensive graph of it. And here we had, like initial approach in summary, there has been adequate use of protection equipment. We started with the supplemental oxygen. Then we went with the supplemental SpO2 to go no higher than 96%. And later on, because of oxygen outages, we kept it around 90%. So we learned that permissive hypoxemia will not kill. So it is important to learn that. And in L type, it is important is that prone positioning is the one which had helped us a lot. Similarly, in the high elastance also, where we have gone, it has been grateful to us that we follow the same principle, we try to recruit it. But for us, later on, of the part of it, any person was not responding to peak of 10 and FiO2 of 60%, we straightaway went for proning. And once we started that strategy, our outcome have been excellent. Prone positions, all of you know it, it is a refractory hypoxemia, but when we find worker breathing is much more, it's better to think in terms of do it quickly and early. Another thing which came in the jargon is the awake proning. It is nothing other than the same thing. What proning does, it creates more homogeneity. And with the more homogeneity, what you find it out that the lung stress index also reduces significantly, and there is a significant improvement. But remember one thing, it can cause hypertension. So person should be having an adequate fluid because the fluid starts staying in front of the abdomen, and therefore the people who are little hypotensive, it may not be a good choice. So first stabilize cardiovascular and then do the awake proning. But nevertheless, when you're using HFNC and NIV, again, it has stood the test of the time. And we have used, all of us have used awake proning constitutionally. And this data, again, which has been published in Lancet, again is showing that in the red one, that those people where we did awake ventilation, awake proning, we found that the number of probability of worsening was much lesser and outcomes were also better, and your outcomes were better and mortality was reduced. This is the simple graph. We started with the nasal cannula, going up to HFNC, invasive ventilation, proning, and then ECMO. Again, complication we saw very commonly this time was with the barotrauma. And rest of the other ones are expected also. And this is the paper published from Sir Gangaram Hospital about the 15 patients we have also seen and sent a publication for 40 cases experience to one of the journals. What we are finding is that there was an increased alveolar pressure. You see these patients breathing very fast and hard. So what did we find? We found there was an increased alveolar pressure, increased negative pressure wherever in the pleural cavity was there. It was leading on to significant surges, and there was inhomogeneity or their differential compliance, which led to increased biomechanical as well as barotrauma and volume trauma. And these changes in lung structure obviously led to alterations in compliance as well as the elasticity. This is the PCLE without positive pressure ventilation. This is the people coming with spontaneous injuries we were seeing in second or third week, much more than we had seen any time in the past. It shows how the lung was battered, where drive was high. People, because of carotid involvement, body's involvement, were not able to feel that much. And the net result was the most important one, which we found which contributed to it, was the respiratory rate. So one of the ways for us to reduce it, the transalveolar or transpulmonary pressure thrust or pleural thrust, has been to reduce the respiratory rate, and hence in invasive ventilation, we realized that longer duration of sedation and paralysis was required. And therefore, some amount of sedation has been found to be useful. Similarly, we found it to be a higher incidence of barotrauma. This is a consequence of that what we discussed just now. Similarly, now another one, people ECMO, there has been a lot of things. This has been published in Respiratory Medicine last year. What this data from a very highly experienced center from France showed us that there was no difference between this. This is another bit which has been published in Lancet last year. What the conclusion has been that patients who received ECMO in more than 200 hospitals in 36 countries up to Europe and North America, there was no difference. And it was as good or as bad looking at ECMO giving it in non-ARDS patient. Therefore, what is the key is the right selection of a patient with an experienced center where people had refractory hypoxemia. It was a good choice. We had an experience with one of our sister center where they had intubated, ventilated, especially people relatively early, like pregnancies, 2 pregnancies, I still remember, they all came up well. But the patient selection is the key. Secondary infections of bacteria are not common, but fungus was seen both kappa and gamma. We have seen it later on also because of the quackery in the management and also the use of immunosuppressant the way it was. The secondary bacterial infections are not as common as was in the other infections. Post-COVID lung fibrosis and post-COVID lung has been a big challenge for us. And there are a large number of people who just passed on that with fibrotic lung. And some of them, in India, there have been very few reports, 1 or 2 case reports. Abroad, people did go under lung transplantation, but outcome, except for the few cases, has not been very good. And management has been challenges evolving. And here, depending on the CT and inflammatory ones, we are using immunosuppression. So, my dear friends, what have we learned ventilating COVID-19 patients? This is an editorial written by Slutsky and team. And they say, after almost a year of treating ARDS caused by COVID-19, everything and nothing has changed. Very prophetic statement. So when you compare between the cards versus non-cards, you need to look at underlying pathophysiology, heterogeneity, whether it is cards or ARDS falls within the classical pattern. Try to individualize the care rather than one-size-fits-all approach. Criteria for intubation in COVID-associated ARDS should be the same. Lung protective ventilation should be the rule. Prone all patients who do not improve. And if their requirement, the threshold should be actually lower. And ECMO also has a nearly similar outcome. Therefore, if you have an experienced center, go for it early than late. So my takeaway, friends, is it's a highly communicable disease with the propensity to develop high-blown ARDS, those with risk factor. Identify risk factor, pick it early, and work on it and prevent it from developing it by awake proning or use of corticoids, or now we say with the use of cocktail antibodies. It can have a mild range of signs and symptoms. Again, as And also, as I said, there's an emerging role of antibody cocktail and ECMO only in advanced centers with refractory. Nobody should not try it. Thank you very much and try to help others. And my big salute to all the COVID warriors who have put their life at the risk, but that's what we have been trained for. Thank you very much.
Thank you, Dr. Dhruv. Dr. Dhruv is a eminent speaker of the Indian fraternity. My question to Dr. Dhruv.
Good morning, Lalit.
Yeah, good morning, sir. You have nicely covered all the aspects of COVID ARDS as always. It's a question from the perception that is there any difference of ventilation strategy if you are talking about the individualized ventilation strategy in different phenotype L or H? What is your, once the patient is hemodynamically unstable, proning, what is your suggestion?
You see, as I said, proning, obviously you need to be sure that person is hemodynamically stable. Today we have enough data on proning that there occurs a pooling of blood in the abdomen. Therefore, first stabilize and then go for it. Otherwise, you will end up in a problem. That is part one. Secondly, I said the last slide, which was there, which the editorial written by Slutsky group, very clearly that everything has changed and nothing has changed. I think that is very important. Is the strategy principles remains the same, and we need to follow that too. Third, which is equally important for us to realize, is that we have been, people have tried to make case of too early an intubation or too late. What we have been seeing too late an intubation, and by that time, already a significant time has been lost. In the early phase, people had an early intubation. What is extremely important is that we need to give a little extra time in terms of tissues to heal. But if you're finding like an HFNC, if your ROC index is less than 4.9, it's better if it is not improving. Like there we are talking about 4 to 6 hours. Probably we are extending here 12 to 24 hours because of various logistic reasons, but from the scientific rationale, it remains the same. So the answer to your question is, technically there is no difference in terms of management of ARDS in COVID as far as the ARDS because of other causes.
Thank you, sir. Now, the next question
Sir,
is...
there is one point. I am Dr. Sharma from Jaipur. Let me congratulate for a beautiful insight. That the point is this, key, the phenotypes in management of CT. Some of the people regress, some of the progress. So how to identify? Because the $1 million question is, at the end of 4 months or 6 months, some of the people are in a very bad shape. And most of the people, they have regressed very well. And here the nintedanib molecule, whether to be given or not, we have not that much of the data. That is very true, because the disease is new and the molecule was just came in 2015 only. So to whom to give, whom not to give, number one. What is a proactive approach with the nintedanib? And there's another thought, if you even don't give a nintedanib, many of the people, most of the people regress very well at the end of 4 months. But I have seen my 4 patients, they are progressing and they are not recovering. They have a progressive IPF. So what to do? Had we been given nintedanib right at the 0 time, at the discharge of the patient, even at the time of the mechanical ventilation, patients could have been given by NG tube nintedanib. Could that have made a difference? Yes or no, sir? How do you comment, sir?
Sir, we are not using the nintedanib in these cases. There have been case reports, in particular, if you see from the Armed Forces Medical College. They looked at it, they ruled out everything, and then they went ahead. Some people have went in for selective therapeutic anticoagulation. Some have also given an nintedanib when they exclude everything. In fact, they have also used pirfenidone. But the data is not convincing. Trials are going on. Therefore, I will not across the board will recommend, because this is a very common practice, which people are looking at it. We looked at our data, the people who have come, we are not finding any difference in terms of outcome. As far as the progression is concerned, small cases, what we are realizing today is the understanding the pathophysiology of the disease. We are finding that large number of these patients, especially who have been ventilated, who have been otherwise also lung involvement, have not been ventilated. We are finding continuation of immune progression in these cases. Now data shows that a fair number of them have a type 3 immune responses. So one of the drugs which continues to be helpful even in the post-COVID phase or immediate post-acute COVID phase have been the corticoid. The only question is how you want to use it. That is the important issue. We are not using nintedanib, we have used very minimal. Another group of drug where we are doing a trial, we have sent again for the publication of our data, is the role of JAK1, JAK2 inhibitors in the post-COVID inflammatory syndrome type of a picture which is coming up. These are evolving areas across the board, no recommendations can be made. And because of the cost of nintedanib and pirfenidone has come down, so people are using right, left, and center. As such, if you see now the natural history of the disease, majority of the people whosoever have the damage, it's a non-progressive fibrosis. So that's why, and the effect of the nintedanib takes minimum 3 to 6 months before we can comment upon it. Therefore, individual experiences, whether it is a nature which has done it, whether it's a drug, I think it's a matter of conjecture right now. I will not recommend antifibrotic upfront unless and until we are doing it in a trial setting. But I know in our country, practically from all the private sector hospitals, they are using it. Already PJ Chandigarh, ourselves, AIIMS and AIIMS Bhopal are looking at it, the role of small dose corticoids versus or with nintedanib in these patients. So I think we need to wait before the final results they come up. But nevertheless, across the board, there is no recommendation. I know we are facing a frustrated position where people are hypoxemia persistent, and during the acute phase, we have not used it at all.
Truly said, there was a Lancet study just came in 2019. They have followed a 15 years follow-up, the SARS-1 patient and MERS patients also with a fibrotic lung disease. And they have the patient, they did not recover well. Still, the DLC was not good, but most of the patients have hip fracture because of long-term use of steroids. That could be one of the complications of the steroids also.
You see, sir, steroids will have their own challenges. The question is, it's like a knife, how you use it. You can use it to cut vegetables, you can use to stab someone else. I think the steroids, what is very important for us to remember is how we are using, we should know where we are getting it. Unfortunately, because people think that steroids are available, they can use the way they wish like. I think it's important. A lot of people are getting like avascular necrosis you're talking about, and they have an AVN, no doubt about it. And the normal duration of AVN recommendation usually 5 to 6 months. After that, you see, what we are seeing is AVN within 2 months. Therefore, something more has to go with the microvascular, which has been going on. And that's exactly has happened in the ARDS also. People try to use, if you see that particular slide, inhaled nitrous oxide was recommended for the high compliant type variety where you had the low elastance, not for the other purpose. I have no experience with the use of INO, but nevertheless, majority of the people who did come to us, we always looked at it, and we all, wherever there is a discrepancy between the radiological finding versus your findings of hypoxemia, please rule out pulmonary thromboembolism. That has stood us with the time. So we have been looking pulmonary vasculature far more carefully in those group of patients where we are finding that they have a hypoxemia disproportionate, which actually fits with the L type of the cases. Rest everywhere, the management practically remains the same. And the additional game changer, which I am seeing now, is in terms of cocktail antibody weight, that itself tells that there is a requirement of antiviral drug in severe COVID. Unfortunately, we did not, till date, we had not anything. But this data from the recovery trial again shows the only question will be the dose, because the dose which they have used is 8 grams, but now the WHO says you can use up to 2,100 milligrams, so 2,100 grams. So that turns out to be 1,200 milligrams of both. So it is important for us to remember that we need to attack both virus plus inflammation. And optimal utilization, the third thing which will be coming up over a period of time, is how much steroid is the one size fits everyone or not. I think these things needs answer. There are no clear-cut answer right now.
Thank
So,
you. I think we need to stop here. I would like to thank Prof. Chaudhary for the excellent lecture and for the discussion. We enlightened us a lot about the management of ARDS and the pathophysiology. I think we need to move forward. It is Greetings from Oman. I'm Dr. Maher Al-Bahrani. It is my great pleasure to introduce Professor Rupin Arya. He is a professor of thrombosis and hemostasis at King's College London. He's the director, King's Thrombosis Center, and he's the lead for thrombosis and hemostasis at King's College Hospital. Prof. Arya, he's the clinical lead for National VTE Prevention Program at NHS England, and he's the director of National VTE Exemplar Center Network. And I believe this is the first center in England at King's College Hospital. He's the clinical lead and deputy clinical director, hematological medicine at King's College Hospital, and he's the honorary clinical director of thrombosis at NHS London. Prof. Arya, the microphone is yours.
Hello, this is Professor Rupin Arya. I'm professor of thrombosis and hemostasis and consultant hematologist at King's College Hospital in London. Thank you to the organizers for the kind invitation to join you today to talk about the very important topic of thrombosis in COVID-19 disease, which despite all the advances in the past year, 18 months, still in many ways remains an enigma. Very early on in the pandemic, we realized that COVID-19 is quite commonly complicated by coagulopathy and that there's a very high risk of thrombosis. So I'd like to share with you some of the lessons of the past year. I think at the outset, there was very little high quality evidence and many decisions were made based on observational data as well as expert consensus. So it's very important that we stick with the evidence and also don't trust everything you read, even in the highest impact journals, because there were many thousands of papers and nearly 3,000 clinical trials relating to COVID-19. What we have realized, however, is that research can be accelerated through collaboration and that the adaptive platform studies have allowed us to respond very swiftly to the changing knowledge. And of course, webinars have now transformed the sharing of knowledge and are here to stay. There have been many treatments and many false dawns, whether it was the hydroxychloroquine story, whether it was ivermectin. So really stick with the evidence. During this time, there have been many large randomized controlled trials that have provided useful data. And out of this work has emerged, for example, the use of dexamethasone from the recovery trial, then the inclusion of tocilizumab and remdesivir, which have been routinely incorporated into patient care. But similarly, there have been many treatments like azithromycin or convalescent plasma, which have during this time fallen by the wayside. There have been over 60 trials investigating the role of heparin and other trials looking at other antithrombotics in COVID-19. I will go on to discuss some of the headline results later on in my presentation. Very early on, we became aware of COVID-associated coagulopathy. Nearly half of the hospitalized patients with COVID-19 disease has associated coagulopathy. There are, of course, very high levels of acute phase proteins as well, and a correlation with inflammatory markers like CRP and IL-6. It is not a typically consumptive coagulopathy. The platelets and fibrinogen are not very low. There's also a very high rate of lupus anticoagulant positivity as part of the reactive process. And there's an awareness that some of these markers, like D-dimers, correlated with a higher odds of critical illness as well as possibly mortality. So the activation of the host defense results in inflammation and subsequent activation of the blood clotting and thrombin generation. This phenomenon has been termed thromboinflammation, which comprises a combination of COVID-associated coagulopathy as well as endothelial dysfunction. Clotting is activated by the marked inflammatory surge through several pathways, whether it's contact pathway, whether it's complement, whether it's netosis, and the surge in cytokines, all resulting in endothelial injury, as well as the microvascular thrombosis, which has been widely noted in post-mortem studies. Again, the studies coming out of China back in March 2020 showed evidence of coagulopathy and suggested that coagulopathy might predict a worse outcome, as well as indicated that there might be a role for anticoagulation in reducing venous thromboembolism in this setting and possibly improving outcomes. So this early study, there were concerns about selection bias because only about a quarter of the patients were treated with prophylactic low liquid heparin. There was also observational data coming out of New York that suggested that anticoagulation might have a positive impact on survival. So in this study, there seemed to be no difference between those on prophylactic and therapeutic doses of anticoagulation. Here are very typical appearances in severely affected patients with COVID-19 disease. On the left, you can see the very, very typical COVID-19 pneumonia, and you can see the straggly airways indicative of fibrosis being laid down. And on the right, you can see the typical kind of Polemint sign and the evidence of pulmonary emboli in the same patient. It truly is an extraordinary burden of thrombosis, which affects both the large and the small vessels. About 80–85% of instances, this is venous thromboembolism, whether it's pulmonary embolism, whether it's deep vein thrombosis, as well as cerebral venous sinus thrombosis, which seems more common in COVID than ordinarily. 10–15% of the cases comprise arterial thrombosis. Then again, particularly with the first wave of the pandemic, we saw a lot of blocked renal circuits. We have seen a lot of line-related thrombosis and also microvascular thrombosis. In the photograph on the right, you can see one of our patients with Palmer digital vein thrombosis. Again, we became aware very early on that thrombosis was particularly a problem in critically ill patients, where we were seeing 2 or 3 times the expected rates of venous thromboembolism, despite the use of standard thromboprophylaxis. And this awakened an interest at the time in escalating the doses of low liquid heparin. Many centers decided to use intermediate dose of low liquid heparin in response to these very high VT rates, despite everything that we were doing, and particularly in severely affected patients on critical care. So there have been many published guidelines, but a very limited evidence base. I think it is safe to say that all hospitalized patients are at high thrombotic risk. So unless there's a significant bleeding risk, they should receive thromboprophylaxis with low liquid heparin. And if patients are on alternative anticoagulants on admission, particularly vitamin K antagonists, they should be switched to low liquid heparin while hospitalized. Again, most of the guidelines have suggested the use of low liquid heparin at standard doses, and some guidelines and expert consensus indicated that there might be a role for intermediate dose low liquid heparin. Most of the guidelines at the time did not recommend the routine use of post-discharge prophylaxis. Again, the anticoagulant with fewest drug-drug interactions and with the best absorption and pharmacokinetics in these unwell patients is low liquid heparin, where really most of the evidence for thromboprophylaxis historically has been in favor of low liquid heparin in medically ill hospitalized patients. And there are possible antiviral and anti-inflammatory effects which are under investigation. So there have been many studies looking at thrombosis in COVID-19 patients. Again, King's, where I'm based, one of the earliest studies, when we had nearly 1,500 patients admitted to King's after the first wave, we found that overall about 5% of our admitted patients had evidence of pulmonary embolism, and 16% of our critically ill patients, despite the use of standard prophylaxis. Interestingly, about half the cases were limited to the smaller vessels, and nearly half the cases were diagnosed on, within 48 hours of hospital admission, suggesting that there's a substantial burden of venous thromboembolism in the community. Again, a very controversial area has been that of the use of post-discharge thromboprophylaxis. So we did a study looking at post-discharge hospital-associated venous thromboembolism, and we compared it with our previous data. And we found that post-discharge venous thromboembolism was not significantly increased in patients hospitalized with COVID-19, which really does not support a case for routine use of thromboprophylaxis in these patients. That is not to say that in some particularly high-risk patients, especially with a previous history of venous thromboembolism or a history of cancer, or who remain very immobile on discharge to hospital, that there might be a selected case for thromboprophylaxis in such patients for a few weeks. Again, this very much aligns with the existing evidence for, or the lack of it, for the role of extended thromboprophylaxis in medically ill patients, where the number needed to treat is about 1 in 180, whereas the number needed to harm is of the order of 60. So these pre-COVID RCTs do not provide a convincing case for extended thromboprophylaxis in medical patients. So our current hospital guidance is to offer anticoagulant prophylaxis to inpatients. If there's high bleeding risk, use effective mechanical measures. If patients are on oral anticoagulants, then review the possibility of switching them to low molecular heparin, and we don't routinely use extended thromboprophylaxis. Again, it has become evidence during this time that the standard one-size-fits-all approach to thromboprophylaxis might be inadequate to tackle the immunothrombosis in COVID-19 patients, and that the timing of the use of antithrombotics is important, and that there might be less effective in later stages of the disease. So the thrombosis risk and the bleeding risk alters during the course of the patient pathway. And there might be a need to adjust the intensity of the anticoagulation during the course of the patient journey. Again, the multi-platform studies have contributed significantly to this debate, and they have addressed the issue of whether therapeutic anticoagulation might be indicated in ward patients as well as critically ill patients. So these were the REMAP-CAP, ATTACK, and ACTIVE-4 studies. And the primary outcome, interestingly enough, was not thrombosis, but organ support free days, which again makes an interesting topic for discussion. So again, as has been the case with a lot of the studies during these COVID times, the results are either released in social media or published in the media, sometimes many months in advance of the actual papers being published. So the interim results of these multi-platform studies suggested that amongst critically ill COVID-19 patients requiring ICU support, that therapeutic anticoagulation might potentially cause harm. In January, we had the reverse result in the ward patients where full dose anticoagulants seemed to decrease the need for organ support. So in fact, the actual publications were only published in New England Journal in the month of August. And these show the superiority of the therapeutic dose in moderately ill patients and evidence of utility and harm in severely ill patients. So again, unsurprisingly, there was a reduction in thrombosis in those receiving the higher doses and more bleeding, but these alterations were not significant. And the main outcome of this thromboprophylaxis study was not thrombosis, but organ support free days. So again, there remains controversy. There was 4.5% adjusted absolute improvement in survival and need for organ support in moderately ill patients with the use of full dose anticoagulation, with a number needed to treat of 25 to reduce organ support and over 100 to help improve survival. So there remains some controversy about the balance between thrombosis and increasing the bleeding. And to add to this, we saw in June the publication of the ACTION study, in which the treatment of hospitalized patients with COVID-19 with elevated D-dimer with either rivaroxaban or enoxaparin, then followed by rivaroxaban to day 30, did not improve the clinical outcomes and in fact increased bleeding compared with prophylactic anticoagulation. So is this because there's a difference in the study populations? And again, in the multi-platform studies, the standard thromboprophylaxis arm was left to the discretion of caring physicians. So In the critical care patients, for example, 22% of the patients did not actually receive therapeutic anticoagulation in the therapeutic arm, and 50% in the standard care arm were actually on intermediate dose low liquid heparin. And again, we have a lack of insight into the potential mechanisms of benefit of giving the therapeutic dose anticoagulation to moderately ill patients, because the benefit is not a reduction in thrombosis per se. So I think many would say that the jury is still out. We have also seen the publication of the inspiration study, which suggests that intermediate dose anticoagulation is not of benefit, but many have argued that this study was underpowered and included less severely ill, critically ill patients with low VT event rates compared to some of the other studies, including the multi-platform studies. So that you could argue that we are reaching a point where we should be sticking with the ASH guidelines and just using prophylactic dose of low liquid heparin, whether the patients are moderately ill or critically ill. So most of the international guidelines now recommend standard dose thromboprophylaxis for inpatients. Again, there has been some discussion about the role of antiplatelet therapy, but the recent publication from the recovery group suggested that aspirin does not improve survival for patients hospitalized with COVID-19 disease. Again, there has been a lot in the media about vaccine-induced thrombosis and thrombocytopenia, but clearly, I think a mass vaccination program is the only way out of this pandemic. And we can see that in the UK, tens of millions of doses of AstraZeneca vaccine have been given. And we have during this time had about 400 patients with vaccine-induced thrombosis, thrombocytopenia syndrome. So that's about 1 in 50,000 of the younger patients receiving the vaccine and 1 in 100,000 of the patients above 50. So I think in the majority of patients, the benefit of having the vaccine far exceeds the small risk of vaccine-induced thrombosis, thrombocytopenia. And again, it's a very typical syndrome. In nearly half the patients, it presents as a very severe cerebral sinus thrombosis with thrombocytopenia and often very hemorrhagic manifestation. And clinically, it's treated very much like heparin-induced thrombocytopenia, and that you would use alternative anticoagulants to heparin, and you would avoid giving platelets unless absolutely necessary, and use intravenous immunoglobulin and steroids to dampen the hyperimmune process. So to end with, what are the lessons from the COVID-19 pandemic? Clearly, I think there's an extraordinary burden of thrombosis, and prevention of VT remains a top priority. And anticoagulants are effective in preventing thrombosis, but can also make you bleed. So the right choice of anticoagulant in most patients will be low liquid heparin. The right dose is important, and I think in most of the cases, it's going to be a standard dose of low liquid heparin. The case for extended prophylaxis is not compelling. At the moment, it does not look as if antiplatelets have a role, but clearly anticoagulation is only part of the jigsaw. And the use of multiple strategies, whether it's antivirals such as remdesivir and even some of the newer treatments, the very exciting results of which, molnupiravir, that have just been published, the use of steroids and tocilizumab as immunomodulating agents. And ultimately, I think there's little doubt that prevention remains the best strategy, whether via the behaviors, whether through the use of PPE and masking in enclosed spaces, and really a mass vaccination program is absolutely key. So thank you very much for your attention. I will stop at that point. Thank you.
Thank you very much, Prof. Arya. That was really excellent. I think you covered most of the topics. I'm sorry I'm not able to start my video, regarding the differences, sorry, now I should be able. Regarding the differences between VT and immunothrombosis, any novel immunothrombosis strategy or targeted intervention that you are aware is coming?
So I think it's not online.
Okay. In this case, I think we'll move to the next speaker. I'll hand the microphone to my colleague, Professor Parikh. Otherwise, Professor Parikh, are you with us?
No, sir, you can please continue.
Okay. It's my, again, great pleasure to introduce my friend, Professor John Marshall. He's a professor of surgery at the University of Toronto. He's a critical care physician at St. Michael's Hospital and senior investigator in the Keenan Research Center for Biomedical Science. And he is the founding chair of the International Forum of Acute Clinical Trials, in fact, a global network of 37 investigator-led critical care clinical research groups. Professor Marshall, he will talk on how will COVID influence and change critical care. Professor Marshall, the floor is yours.
Good morning. It is a pleasure to be joining you today, even if it is only virtually and from my home in Toronto, Canada. Thank you very much for the invitation to be part of your meeting. Pandemics have been a recurring part of human history. There are records going back 5,000 years of mass graves in China that give voice to the impact that infectious diseases have had upon populations. As you may know, during the Middle Ages, somewhere in the vicinity of a quarter of the population of Europe was wiped out by the bubonic plague. And then in the last century, we were faced with a pandemic that killed somewhere in the vicinity of 40 to 50 million people, the influenza pandemic of 1918-1919. Pandemics, though, have also given rise to advances in medicine and particularly spurred the emergence of intensive care units some 60 years ago. It was Bjorn Ibsen, who was an anesthesiologist in Copenhagen, who during a polio outbreak in 1952 established what is generally recognized as the first intensive care unit in the world. He showed that when you had medical students manually bagging patients who could not breathe because of their poliomyelitis, you could save lives. In doing so, he fundamentally changed the world, and he gave birth to the specialty that we all share. The 21st century, of course, has seen its share of pandemics, even though we're only 2 decades into it. In the early 21st century, there was the SARS pandemic that impacted China, but also affected my home city of Toronto. In 2009, we had the H1N1 influenza pandemic, again, a more international pandemic. We had Zika outbreaks, we had Ebola outbreaks in the last 5 to 10 years. And then, of course, we're now in the middle of a COVID pandemic caused by SARS-CoV-2, a coronavirus. It started really quite innocuously. Reports emerged in late 2019 of an unknown viral infection that had been seen in Wuhan in China. But at the time, it sounded like it was something exotic, something contained, and something that was going to be of more academic interest. That was really until early February when it became apparent that not only was China being really quite severely impacted by COVID-19, but it had the potential to become a global pandemic. And it was this natural experiment that really underlined, I think, for many of us, what the threat we were facing. This was the Diamond Princess, a cruise boat that houses approximately 2,700, 2,800 people who are traveling in close proximity to each other and isolated from the rest of the world. A passenger got onto the Diamond Princess in Hong Kong and was sick at the time with what later proved to be COVID-19. He was the only person at the time who had COVID-19, but the ship was quarantined, and by the time the disease on the ship had run its course, a quarter of the staff and vacationers on the Diamond Princess had been infected with COVID-19. 2% of them had died. And so this told us a couple of very important things. We were dealing with an outbreak of a disease that was highly infectious and also substantially lethal. The situation has continued to expand, and it's not going to come as a surprise to you that we're still in the midst of the COVID-19 pandemic. Depending on where you live on the planet, you're either in the third or fourth wave of the outbreak. But here you see the latest data from the WHO showing the course of the pandemic. As of today, roughly 250 million people around the world have been infected by it, and 5 million people have died. These numbers are probably underestimates for the true burden of the pandemic. You'll appreciate that data from Africa is really quite limited, although the population of the continent is 1 billion people. But the disease has certainly had a profound impact, not just on health, but on virtually every aspect of our daily lives. So it's hard in the middle of a pandemic to realize how fundamentally the occurrence of this infection is changing the world within which we live and work. And what I'd like to focus on this morning is some thoughts about how COVID-19 is changing critical care from 3 broad perspectives: critical care research, the provision of clinical care, and the opening of new avenues to global collaboration. In the 2009 H1N1 pandemic, there were approximately 300 clinical trials registered on clinicaltrials.gov. As of today, there are close to 7,000 studies of COVID-19 that have been registered on that website. More than 100 countries, including many low and middle income countries in Southeast Asia and Africa, are included in the list of sites that are doing studies. And there are close to 200,000 citations in PubMed. We have truly embraced the concept that part of the effective response to a global catastrophe such as COVID-19 is to study it and to generate knowledge as quickly as we possibly can do. And so we've seen large-scale and very effective trials emerge during the pandemic. The recovery trial in the United Kingdom has recruited over 44,000 patients to a randomized controlled trial of multiple different interventions in hospitalized patients with COVID-19. They've shown, for example, benefit for corticosteroids. They've shown that antiviral agents are ineffective. They're currently studying a number of additional agents, including baricitinib, dimethylfumarate, the optimal dose of corticosteroids, and empaglifloxacin. This was the initial report from the recovery trial. It's important to recognize that the protocol was drafted in early March. Writing began around the 9th of March and was concluded by the middle of the month. The first patient was recruited at the end of March, and these data were presented at a WHO meeting on the 16th of June. So a interval of only 3 months to go from an idea to the first data showing effective therapies for COVID-19. And so what recovery reported was that corticosteroids actually reduced mortality, and particularly for those patients who were the sickest, those patients receiving mechanical ventilation in an ICU. 4 months before this, as the pandemic was just emerging, there were multiple opinions about the value of corticosteroids, but it's probably fair to say that the bulk of the opinion was that these were likely to be harmful. And this just underlines how important it is that we study a pandemic, difficult as it is evolving. I want to say a few words about the REMAP-CAP trial, which I'm involved with. This is a trial that is studying critically ill patients who would be admitted to an intensive care unit. It's being run in multiple countries and multiple continents around the world. It is focusing on the sickest patients, those who would be managed in an ICU under ideal circumstances. It has recruited close to 8,400 patients with COVID-19 and randomized patients to over 15,000 different randomizations. We're studying in total 50 different interventions on the REMAP-CAP platform and have begun to generate data on optimal treatment of COVID-19. REMAP-CAP is different from other clinical trials in that it is a platform trial. A platform trial is a trial that studies a disease rather than a single intervention. What that means is that the trial can actually study multiple interventions simultaneously or sequentially. And that's the reason that we're able to study up to 50 different interventions at the same time, all within the context of the same statistical model. We use a Bayesian approach rather than a frequentist approach, and that has some implications for how we draw conclusions, which you'll see in the next few slides. It also impacts the way we randomize patients to the trial. We use a technique called response adaptive randomization, and what this entails is that as the trial learns, it changes the randomization percentages. So patients are more likely to be randomized to those interventions that are doing better at that point in the trial. This both makes the trial more effective, but equally importantly, it means that patients who are recruited to the trial are likely to benefit as a result of their enrollment in it. A platform trial also has the potential to be a perpetual trial. Typically, it's funded by multiple different funders, but as one intervention is studied and a conclusion is reached, other interventions can be studied, and the results can be immediately applied to other patients who are in the trial. This just shows schematically how a platform trial works. You start with a cohort of patients with a disease. In our case, this is patients with COVID-19 who have organ dysfunction, either respiratory or cardiovascular. They can be randomized at the choice of the clinician and the patient and family to a number of different domains, and within those domains, to interventions that are under study. So you can see in this hypothetical example, we're starting with a single domain that has 3 different interventions in it. Patients are being randomized 1-to-1 at the start of the trial, but as the trial learns, the number of patients who are randomized to the better performing interventions increases. Once you've reached a conclusion, as has happened here in the case of intervention C, we can add another intervention, in this case, intervention E. But equally, and this is one of the real strengths of a platform design during a pandemic, is that as more is learned about the disease that you're studying, you can add new interventions that you may not have considered at the time the trial was originally launched. So here are some of the data that REMAP-CAP has generated. Our first report was last year when we reported on the efficacy of hydrocortisone in patients with severe COVID-19. And our results replicated those of the Solidarity trial in a smaller number of patients. We showed that patients who were receiving hydrocortisone, either for the duration of shock or for a fixed dose, did better than patients who received no hydrocortisone. In these heat maps that you'll see in subsequent slides, red is bad, blue is good. Our endpoint is the number of days alive and free of organ support over 21. So if you have a lot of blue, you have more days alive and free of organ support. If you die, you get -1 and are shown in dark red on the graph. So we're looking for less red, more blue, and we can analyze those statistically. We can also show these as a kind of survival curve, and in this case, it is the lower bar that is the one that is doing better. We've also reported on tocilizumab and sarilumab, which are two antagonists to the interleukin-6 receptor. Our data showed that either agent improves survival and shortens the duration of organ support in patients with severe COVID-19. Here you see pooled data for interleukin-6 receptor antagonists versus control, and these data were reported earlier this year in the New England Journal of Medicine. We've also looked at antiviral agents in the sickest of patients, and our data essentially mirror what's been seen in less severely ill patients. Patients who are doing best here are those patients who are actually randomized to the control arm. They are the ones that seem to have the largest amount of flu, although patients who are receiving lopinavir, ritonavir alone also are roughly the same. Patients receiving hydroxychloroquine do worse, and the combination of hydroxychloroquine and lopinavir, ritonavir is associated with a result which is significantly worse than not receiving any antiviral therapy. So I think we were able to demonstrate that although at the beginning of the pandemic, there was a clamor to put patients on hydroxychloroquine and lopinavir, ritonavir, this was a bad idea, and these particular agents actually worsened outcome rather than helped patients. We've studied convalescent plasma. These data were just published about a week ago in JAMA, and we found no signal of benefit for treatment with convalescent plasma in patients with severe COVID-19. We studied therapeutic anticoagulation, and this was an addition to the platform as it became apparent that thrombosis was a common complication in this viral infection. And here we found divergent results. Patients who were not critically ill with COVID-19 actually benefited from full dose therapeutic anticoagulation, whereas patients who were critically ill in an intensive care unit showed no signal for benefit. So far, REMAP-CAP has studied, completed, and reported a number of different interventions. I've described our findings for antiviral agents, for hydrocortisone, for IL-6 receptor antagonism. We've also looked at anakinra, the interleukin-1 receptor antagonist, and found no evidence of benefit for that. We've shown benefit for heparin in the moderate state, but not in the severe state. No effect for convalescent plasma. And coming out very shortly are our results on aspirin and P2Y12 inhibitors, which show no significant effect for the overall endpoint of the trial, but some intriguing subgroup analyses. Now, it's not just randomized clinical trials that have exploded during the COVID-19 pandemic. Observational research has benefited from very large studies of patients hospitalized with COVID-19. The poster child for this is led by ISARIC in the United Kingdom. They have recorded data on more than 400,000 patients who are hospitalized with COVID-19. The reports are only beginning to emerge, and this will be a rich source of understanding of critical illness and viral infections in hospitalized patients. But even at this stage, you can see global patterns of practice. Antibacterial agents being quite widely used, up to about 2/3 of patients receiving them. Corticosteroids being used in about half of patients. Antiviral agents, not so much. And other agents that might be used to treat COVID-19 being less frequently employed. There's also been some spectacular basic science work that has been proceeding at a remarkable pace, thanks to integration between clinical databases and large-scale basic science biobanks that have been able to collect specimens from patients with COVID-19. This was a beautiful paper that just appeared in the last week or two in Science, which is looking at the role of interferons in COVID-19, and in particular, identifying a single nucleotide polymorphism in a gene called OAS1 that is protective in patients with COVID-19. So this is establishing a very strong biological basis for additional specific therapy for COVID-19. How are we doing? Well, this may be a little bit simplistic, but if this is a nice graphic representation of what's happened in research over the last 18 months of COVID-19. It took us over 3 millennia to eradicate smallpox, same length of time for polio, cholera, 2.5 millennia, measles, 1.5, even contemporary diseases such as HIV, AIDS, and Ebola, effective therapies have really only emerged in a time frame that's measured in years. COVID-19, we had data from human trials within 3 to 4 months of the onset of the pandemic. We're still continuing to gather these, and there's going to be a very rich legacy of new science emerging from the pandemic. COVID-19 has also changed clinical care. It has shown us what is possible, and it has really brought the ICU to the forefront of the public health response to a pandemic infection. In China, when the outbreak exploded in Wuhan, a whole new hospital was built in a matter of 10 days, and basically all of the hospital was dedicated to COVID-19 patients and critically ill COVID-19 patients. The tent shown in the upper right-hand corner is from a Canadian hospital that outfitted tents that could manage ventilators in the parking lots in preparation for an onslaught of patients. We've all learned how to do much more with relatively limited resources, even though these resources have been challenged and sometimes to the breaking point. But we've also learned the limits of what we can do, and there's a growing feeling that we need to rethink the ease with which we have implemented interventions such as intubation and mechanical ventilation. A shortage of ventilators is a big factor behind looking at alternatives to mechanical ventilation, such as helmet ventilation or such as prone ventilation, which can be provided to a spontaneously breathing patient. So again, it's early days, but I think one of the legacies of the COVID-19 pandemic will be a very different perspective on the benefits and harms associated with mechanical ventilation. We've also learned a lot about the potential of old drugs that we've used for anti-inflammatory activity or used in other diseases to treat an infectious disease. And the promise here for future treatment of sepsis patients, I think, is substantial. We've learned, for example, that corticosteroids and heparin can be efficacious. There are ongoing studies to determine the utility of ACE inhibitors or angiotensin receptor blockers, aspirin, P2Y12 inhibitors such as clopidogrel, and statins. We will have answers on those within the next several months, and it will be interesting to see if we can add these inexpensive agents to the armamentarium of treatments for COVID-19. We've also learned that there's a substantial amount to be learned from other specialties. Rheumatoid arthritis in particular, therapies that are widely used in patients with arthritis, such as the IL-6 receptor antagonists or inhibitors of Janus kinases, such as baricitinib, are showing efficacy in the treatment of COVID-19. And this opens the door to new therapies for critically ill patients. I do think that one of the key messages that is coming from what we're learning so far is that the benefit in treating the disease is not in specifically targeting the virus with antiviral therapies, but in targeting the maladaptive consequences of the host response with a variety of biologic response modifiers, which may be anticoagulants, may be anti-inflammatory drugs, or maybe agents whose function we don't fully understand. Clinical care is also changing in that governments and decision makers are understanding the importance of research, planning, and central organization in the provision of healthcare. The model for this has been the NIHR in the United Kingdom, where in the past, hospitals have been funded to do research, and the research can be coordinated centrally. Targets are established for recruitment to trials in exchange for funding for research coordinators and the necessary infrastructure to conduct clinical trials. What this meant in the COVID-19 pandemic was that at the start of the pandemic, priorities were established. certain trials were targeted as trials that should be recruited to for patients with COVID-19, and that included the recovery trial, principal trial for patients pre-hospital, and REMAP-CAP for those patients in the intensive care unit. Different agents in different phases of the disease were prioritized. And as a result of that, the United Kingdom has really been at the forefront of identifying effective therapies for COVID-19. You can see here some of the differing interventions that have been or are being studied in the United Kingdom right now. But even there, I think there's been an awareness that although this is a substantial step forward beyond what most of the rest of the world has been able to supply, there's still a long way to go. Only about 7% of all patients admitted to hospital for COVID-19 were recruited to clinical trials, and about 20% of all patients admitted to intensive care units. Just for comparison, in Canada, we've only been able to recruit about 2.5% to 3% of patients admitted to intensive care units to REMAP-CAP in Canada. So we have a much, much longer way to go here. Finally, COVID-19 is really changing the way we think about research, the way we think about collaboration, and is underlining the fact that we are all intimately interconnected on this small and vulnerable planet. Here you see recruitment from REMAP-CAP. We are recruiting from multiple sites around the world, and at present, most of our cases are coming from Australia, New Zealand, and the United Kingdom. But we're also getting cases from Southeast Asia, from Pakistan, India, and Nepal. We have recruitments from Canada and the European Union. We've just recently opened sites in Japan and South America, and we anticipate very shortly opening our first site in Africa, in South Africa. The WHO Solidarity Trial, launched at the start of the pandemic, similarly is recruiting broadly around the world. It has 52 different countries that are providing patients to the trial, 600 hospitals. It is a study across the spectrum of severity of disease, but with a greater emphasis on less severe disease. They're now up over 15,000 patients. They have been studying more the efficacy of antiviral agents and showed that hydroxychloroquine and lopinavir, ritonavir were not effective, but they're currently studying biological response modifiers, particularly imatinib and infliximab. So a consequence of the COVID-19 pandemic has been a recognition that we have to respond at scale to a global pandemic. And large research consortia, such as REMAP-CAP, such as the Solidarity Trial, such as the Active-2 initiative in the United States, are becoming the norm. They're using differing designs. Most of them are some variant on a platform trial design, whether it's done using a Bayesian approach or a frequentist approach. But we're clearly seeing the benefits for integrating research into clinical care using the platform trial model. We're also seeing collaboration amongst platform trials. The data from REMAP-CAP that I showed you on heparin in moderate disease is actually a collaboration between 3 separate platform trials: ATTACK, REMAP-CAP, and the Active-4 trial that's led by the NIH. This enabled the recruitment of 3,000 patients in the space of less than half a year, and the demonstration of a very important effect that anticoagulation is beneficial in patients who have moderate disease. The World Health Organization has played an important role in coordinating and promoting new models of research. I have to declare that I am the co-chair of a committee of the World Health Organization, but our committee has been given quite a free rein in developing new models of research collaboration. And one of the things that we have developed is a model called a prospective meta-analysis. The idea behind this is that during a pandemic, Many people are studying similar interventions in the same disease, and we want to get answers as rapidly as possible. Therefore, there's an argument for sharing data even before any individual trial has reached its full conclusion. And so we've been doing this. We reported a prospective meta-analysis of interventions for corticosteroids in September of last year that pooled data from recovery. REMAP-CAP was published in that same issue of JAMA, also showed benefit for corticosteroids. But the beauty of this prospective meta-analysis model is several things. First of all, we have a much more international picture of the efficacy of corticosteroids, not simply the United Kingdom. We have trials here from Brazil, from Europe, and really from around the world with REMAP-CAP. Secondly, we're able to show that the effect of corticosteroids is a class effect and not a specific effect of dexamethasone. You can see that dexamethasone is efficacious, but the same magnitude of signal, although there are a fewer number of patients, is seen when patients received hydrocortisone. And this is important in a setting where there may be millions or tens of millions of people who need treatment and drug shortages are threatened. These are data from our recent meta-analysis looking at IL-6 receptor antagonism. We were able to convince investigators from trials that recruited something like 85% of all patients randomized to IL-6 therapies, about 11,000 patients in total. And this prospective meta-analysis showed that either tocilizumab or sarilumab were superior to usual care in patients with COVID-19. This also shows another strength of the prospective meta-analysis. The data showing benefit derived from recovery and REMAP-CAP primarily. These are the largest of the trials that were included. And in fact, early in the pandemic, several small trials with very imprecise estimates were actually stopped for futility. So the capacity to pool data at a large scale, tens of thousands of patients, meant that we're able to identify a striking treatment effect for a drug that is available, and further to show that this is a class effect and not the effect of any one particular IL-6 receptor antagonist. Another innovation that has really gained traction during the pandemic has been the preprint server, the publishing of results before they've undergone peer review. Despite the potential for misinterpretation of trials and the possibility that either fraudulent or poorly done trials may be posted, I think this has been a significant step forward, and it's emblematic of the willingness of the world to share information at the time of global need. So just to conclude, the COVID-19 pandemic has fundamentally changed our lives, but it's also changing our professional lives. It is opening us up to new trial designs, and particularly platform trials and adaptive designs. It is underlying the extraordinary power associated with international collaboration, but also the willingness of a global community to collaborate. Critical care is emerging as one of the key elements of a public health response. And at the WHO level, intensivists make up a substantial part of those who are responding to COVID-19. And finally, I think we are increasingly seeing something that we have intuitively known for some time, which is that the best clinical care comes when research is embedded into the provision of that clinical care. So it's hard to know where we'll be 6 months from now, a year from now, even 2 months from now. But I think it's fair to say that COVID-19 is opening a door to us that is going to continue to yield some really transformative insights in the months, years, and even decades ahead of us. Thanks again for your attention this morning and for the invitation to be a part of your meeting.
Thank you very much, John. That was really excellent and very much interesting topic that you have covered different aspects of the changes that COVID made in our lives. I know we are running out of time, but one question, John. Regarding the REMAP cap and the international collaboration, we've seen probably, I don't know if this is probably the first time that we have different platforms coming together and with joint collaboration, especially internationally. How do you see that coming for future ICU research?
I think this is the future of critical care research. Obviously, there has been an extraordinary need, and that need's been met by responsiveness on the part of people. To give up the prospect of becoming the leader of a particular trial in the interest of being part of a much, much bigger collaboration. But I think as we become more comfortable with the notion that we share things more than we compete with each other, this is going to become a model. It's vastly more effective than the models of research we've had in the past. And I think not only large-scale collaboration, but also integrating research into the way that we provide care, which is something that a platform trial really allows, is also going to become the norm. And once we can do that, the sky's the limit.
Thank you, John. And I think it's time to,
Thanks to all the chairpersons and all the speakers of the plenary session for an exemplary session. With this, we move on, and I request Dr. Vandana.
Good morning, everyone. It was a very wonderful and informative plenary lectures. Now we're going to start with the brainstorming round table discussions. And the moderator is Dr. Deepak Govil. He is the Director, Critical Care, Medanta, the Medicity Gurgaon. And the panelists are Dr. Rajesh Chawla is the Senior Consultant, Department of Respiratory and Critical Care, Sleep Medicine, Apollo Hospital, Delhi. Dr. Praveen Amin, Intensivist, Breach Candy Hospital, Mumbai. Dr. Ram Rajgopalan, Senior Consultant, Critical Care Medicine, Sri Ram Chandra Medical Center, Chennai. Dr. Mitch Levy is the Chief, Division of Critical Care, Pulmonary and Sleep Medicine, Department of Medicine, and Professor, the Warren Alpert University, Medical School of Brown University, USA. Dr. Daniel D. Baker, Professor, Intensive Care Department, Erasmus University Hospital, Brussels, Belgium. And Dr. Khalid Shukri, Chair, Critical Care Society, MENA Chapter, President, Transcontinental Elite Alliance for Intensive Care Excellence, Saudi Arabia. Over to Deepak Goyal, sir.
Transcontinental Elite Alliance for Intensive Care Excellence, Saudi Arabia. He is yet to join. So can we start with the first question? First, I would like to start with Dr. Chawla. I'll ask him about the role of non-invasive ventilation in COVID patients.
Thank you, Deepak, for invitation. You see, there are few conditions where I would use non-invasive ventilation without any thinking, like a COPD patient, cardiogenic pulmonary edema, obesity, hypoventilation, obstructive sleep apnea. In these conditions, if the patient has COVID-19, the non-invasive ventilation would be my first choice. In all other patients, most of the times I would use high flow nasal cannula or HFNAC in these patients. And the problem occurred during the epidemic, the pandemic, that we did not have that many HFNAC machines, and we did not want to intubate these patients. So we ended up using non-invasive ventilation in a very large number of patients. So we would use in all these patients who are hypoxemic and the requirement of oxygen goes beyond 7-8 liters. This is the time when we will start using the non-invasive ventilatory strategies. If HFNAC is not there, then non-invasive ventilation I would use in these patients. So that's how we have used the non-invasive ventilation in COVID-19.
Yes, sir. Very well said. Professor Levy, is the same practice is there in US also? Do you agree with what Dr. Chawla is saying, or there is some difference of practice there?
No, I agree with Dr. Chawla. I would do the same. We would, even in someone with COVID, we would consider using non-invasive ventilation if they had COPD or non-cardiogenic pulmonary edema. But for the most part, we use high-flow nasal cannula for patients with COVID pneumonia.
No, I agree. Everybody was using high-flow nasal cannula, but as Dr. Chawla said, the availability of high-flow nasal cannula machines was limited. And then when we have already consumed them, then we have to go on to NIV.
Yeah, we have not struggled with the availability of high-flow nasal cannula, but I agree that if I didn't have high-flow nasal cannula, I would use non-invasive. The one thing that's important to note is as long as we're not using non-invasive to delay intubation, and there are some data that came initially out of Wuhan that suggested that the use of non-invasive as a method to delay intubation was associated with higher mortality. So that's where I would be careful about the use of non-invasive ventilation.
I'll come to this point in next question, next 2 or 3 questions about the timing of intubation. I would like to ask Dr. Amin that what initial setting he would prefer in non-invasive ventilation. Like traditionally in COPD patients, we use the EPAP and IPAP or PEEP and pressure support. So what is his choice? How much?
Well, we would look at conventional early mild ARDS where we would use non-invasive. It would be generally about 6 to 8 EPAP and about 10 to 12 IPAP. Initially, we'd go with 100% FiO2 and then come down based on the gases, come down and see how quickly you can come down on the FiO2. So the variability depends on how tachypnic the patient is. The settings can vary depending upon how tachypnic the patient is and how the patient responds to your current setting. So it's a dynamic process. I wouldn't, there's no rule of the thumb for these particular patients. It's variable, and you look at the response, what your ventilator says, and make your adjustments likewise.
Let me share my experience, sir. In few patients, when we applied NIV through ventilator with the pressure support of maybe 5, 6, with the PEEP of 8 to 10 or little less 6 to 8, they were generating tidal volume to 700, 600, and that was like we thought that it might cause the self-inflicted lung injury. In those patients, we reduced the IPAP to almost 0 just to minimize the tidal volume. Professor Divekar, what is your take on this finding?
Well, I agree that the non-invasive ventilation covers a lot of different things, and that we are perhaps not exactly on the same page to begin with. I'm totally in line with Mitch Levy. High-flow oxygen therapy is really, I think, the first line in many of these patients. Then the question is to provide some additional PEEP or not. And then the real question at some point is, when these fail, do you also add some inspiratory pressure, as you mentioned, the IPAP? For this, I'm really less confident because, as you mentioned, one of the issues is the self-inflicted lung injury. And already just with the high flow or the PEEP, we sometimes see patients with a really very deep breath. The volume is probably quite large in many of these. The diaphragmatic pressure is probably an effort, is probably very large. The problem is that we have difficulties to measure it in non-intubated patients. And this is where we begin to have issues in prolonging or not the non-invasive mechanical ventilation. For most of the techniques, we have to admit that we can delay the time for intubation or even prevent or at least prevent probably in some, but delay in most. And we have minimal impact on mortality. If you look at the recent data in the Lancet Respiratory Disease on high flow, well, it was very effective in preventing intubation, but no impact on mortality. This means that mortality is probably better when you do not intubate the patient. But when you have to intubate the patient randomized to high flow, then this means that the mortality was probably higher in these patients, perhaps in some patients because of the delay and or the self-inflicted lung injury. So it's a very difficult art, and I have to admit that we do not have the proper tools who will be failing and who will be responding. We just have to follow the patient, but that's not the best way.
Dr. Ram Rajgopalan, what is your take on about this controversy? I would say it's a controversy because some say early intubation, some say late intubation, some say avoid intubation, some say delay intubation. To me, we should intubate at the right time, at the right moment. There is no early, there is no late, or there is no delay. What is your take on, sir, on this?
Very difficult to make the decision about what is the right time. Again, a lot of it was dictated by the practicality of the situation. It usually was the availability of a ventilator, the availability of non-invasive support, and the availability of high flow that frankly dictated the way in which we made these choices. As much as we respect and understand the issues related to spontaneous induced lung injury, yes, we did see a lot of these patients when they put on non-invasive ventilation, they do generate very large tidal volumes, and even with very little inspiratory positive airway pressure, you seem to have those volumes still going on. I think the focus was always on, when we were using the non-invasive, we did two things. We did focus a lot on the end expiratory pressure, particularly in terms of improving the oxygenation. And the other option is, when we had a choice of non-invasive machines, our preference was to use the ICU ventilators rather than any freestanding ventilators, though like that again was a very severe shortage. So there were a lot of times when we compromised on the care, and much of our decision making was either based on opinions, strong or weak, and on the practicality of the situation. Honestly, we were able to acquire a large number of high-flow nasal cannulas, but still it was nothing to meet our requirements. My preference again was always towards using a lot more of the high-flow nasal cannula in the hypoxic patients. The kind of patients that Rajesh basically decided, I mean, on acute pulmonary edema, which you saw occasionally cardiogenic pulmonary edema, and occasionally when you saw somebody with an exacerbation of COPD, we had a tendency to be a little lenient towards using non-invasive. But on the average, in a frank COVID pneumonia, our focus was on using high-flow nasal cannula initially. And one of my students again looked at the value of making a decision when you're on the high-flow nasal cannula about transitioning to ventilation. I think there is some bit of data related to high-flow nasal cannula and the use of the ROX index. Very similar in terms, the variability was a little different in our population, but basically a relatively low ROX index, around 4.5 to 5 was approximately when we always started putting these patients back on the ventilator. This again is derived from very small observational studies, not from our own data at all.
So one thing is very clear with this first round of question, that as per all of you, the NIV was should not be the first choice, or was never the first choice. So it was a compromise when we were not having enough HFNC machines and patients' number were high. That time we made a compromise and put these patients on NIV support. And is it okay? Can we make this a statement clearly? So the next question comes in, as Professor Mitch Levy and Professor Devekar said, and as Dr. Ram Rajgopal has said, when to intubate. What I have seen in practice, as Professor Mitch Levy has already mentioned, many times when we put patient on NIV with 100% oxygen and with high oxygen, many times like they keep on lingering on NIV, and people were little afraid or hesitant to put them on invasive ventilation, despite of going into self-inflicted lung injury or other barotrauma type thing. So, Dr. Chawla, when you think the patient should put on intubated and put on ventilator?
See, Dr. Deepak, see, all these patients, it was a pandemic time, our strategies were different. Now we are entering into an era, I hope, that it will be an endemic disease. And we should handle them like any other hypoxemic respiratory failure. We should intervene early like we used to do in any hypoxemic respiratory failure. You know, in COVID, there are patients who deteriorate very rapidly. They don't give you time. You put them on HFNSE and by evening they are intubated, whatever you do. So these patients, you should intubate as soon as they fulfill the criteria. The other patients, like what I have done during the pandemic is that if a person requires less than 0.6 FiO2 and he's not in distress, he's not using his accessory muscles, he's appearing comfortable. When you disconnect, he doesn't desaturate to 70s. He requires around 4 or 5 liters of oxygen, he's comfortable. Then you can continue NIV. But if a person is getting distressed at any time, his FiO2 requirement is going beyond 0.6. If you disconnect the non-invasive, he desaturate to 70, he gets distressed, you should intervene. I think these, which we've been following for any other hypoxemic respiratory failure, we should now intubate these patients early. Now there is a lot of data that for hypoxemic respiratory failure as well as for COVID, that delay in intubation, delay in starting the invasive ventilation increases mortality. So we should intervene. We should give a trial, of course, but if it is not succeeding, we should intervene early and intubate these patients.
So what I gathered from Dr. Chawla is that the failure of NIV, prediction of failure of NIV should be done as we do in any other hypoxemic respiratory failure. We should not continue the NIV specifically to avoid intubation or to hesitate in intubation. Dr. Amin, sir, what is your take on?
Well, we've had a problem because, you know, the ICMR and all, and quite a lot of even the Maharashtra COVID team, not necessarily run by intensivists, kept on saying that you should delay intubation. And I think a lot of patients were unnecessarily delayed because of the initial statement saying that, you know, you should try and continue on non-invasive methods, especially HFNC and NIV. And most often than not, when you intubate late, then you realize that these patients end up on mechanical ventilator for a prolonged period of time, because then when you intubate them, they really are very hypoxic. And even if you prone them and things like that, at that point of time, they are quite hypoxic. So I would, you know, in the initial part of the pandemic, we were a little restrictive because of the directives that were given to us to say that, look, it's probably better to try and prolong the intubation. But I think over the time, we've realized that it's better to intubate early and you treat it like any other ARDS. Please do not wait for too long. Of course, you know, the number of barotraumas that we have seen, you know, at the time of intubation and at the initial part, those are things that you need to be really aware of, especially when you know, when these patients are very tachypneic and when you try and intubate these patients, they get very hypoxic for that interim period when you try and intubate. So I think, you know, we are a little bit more proactive in terms of intubating patients much earlier now as compared to the initial part of the pandemic.
Professor Levy, sir, what is your take on? Is it similar or slightly different, or what is your take on?
Yeah, I very strongly agree with Drs. Amin and Chawla. I think that the key is not delaying intubation. Honestly, I really think that it's just as Dr. Chawla said, there's no protocol for determining when to intubate somebody. It's really how much FiO2 are they on? How long have they been on high flow nasal cannula? Are they struggling to breathe? Do they look uncomfortable? I honestly feel like a lot of it is the look test. And if someone you feel it's of course it could be the induction of Cili perhaps, but it's really if somebody's been struggling and continues to struggle, and every time they drop their nasal cannula or they move, they desaturate, that patient needs to be intubated. I do think that because of some of the early reports, just as Dr. Amin said, we got a little nervous about intubating people, because there was this question of, was mechanical ventilation in and of itself deleterious? But there's clearly no evidence for that. And I think intubating someone, not prolonging how long they are uncomfortable, is the way to go in COVID.
Professor DeBaker, sir. Actually, what happened in initial stages, the lot of news came from Italy that people were intubated and they died. So there was a fear, a hesitation developed in everybody's mind that if you intubate your patient, will not be able to save. That probably that was the reason why people started delaying it. Professor DeBaker, sir, what is your take on?
Well, I think that we need to be cautious when looking at the evidence. It's clear that when you are intubated, you are often more severe. And that's as a marker of severity in the initial report. Of course, the intubation came out, and then the mortality of patients intubated is often higher than the other one. And it's clear that many of the patients were not dying before at least being tested for trial for intubation. So at the end, all the patients dying were intubated, even though this was not the intubation was not the cause of the death, of course. So especially when you are in a surge, while you try to maintain people very, very, very long under several devices that try and to prevent intubation, including prone positioning and so on and so on. Once you intubate a patient, this means that the patient is really very, very severe because this patient failed all the other therapies. And then, of course, mortality will be higher there. But when we say will be higher there, it still is affordable when you look at the mortality from other diseases. And it depends really the possibility you have to escalate with different salvage techniques on one hand, and also the availability of beds. That means that you have also the time to wait for improvement, because as somebody mentioned, the time on ventilator will be longer for these patients compared to classical RDS patients. If you have a patient with flu and the same severity, you know that you intubate the patient, and 1 week after, the patient will be extubated and probably already on the ward. For a COVID patient, you know that you're going for 2, 3, 4 weeks of intubation. And many of the series show that indeed 1 month of intubation is really very common. When you look at the inventory-free days in many of the trials, it's close to 0. So, and nevertheless, the mortality is not that high. Often mortality at the end will be 30%, 35% or whatever. So yes, we have this patient. We should not prevent intubation. As mentioned by everybody, we should intubate on the right time. But then we know that we do not make injury just by intubation. We're just dealing with more severe patients, but all the principle beyond that point will be indeed to minimize again ventilatory induced injury. That is very important, of course.
Dr. Ram,
could I just make a little different kind of an approach? Maybe it's a little subtly different, probably not very strongly. I do agree that ultimately when the patient does deteriorate, despite the non-invasive support, that he needs to be considered for invasive ventilation. But unfortunately, when you're looking at all the data, and I'm not very sure, maybe I've been a little under-reading as far as this data is concerned, or being overwhelmed by the amount of material that is available. But my reading was a little different. In the early stages, with a strong opinion from people like Professor Gattinoni, we were very aggressive about the early intubation of our patients. And in the Indian circumstance, you do understand that we are not in the best kind of ICUs. We certainly have a major complaint and a problem with nosocomial infection. And certainly what we were doing is when we were early intubating a lot of our patients, our biggest risk was the development of secondary infections, and the outcomes were very clearly affected by that. Subsequently, when I've been looking at the literature, at least the 1 or 2, they are not prospective comparative trials, but at least they are good prospective observational cohorts that I've seen, seem to imply, there is one I think called the Outcomes Era, which is a large prospective observational series with an attempt at trying to adjust for the severity of illness and ultimately trying to get you outcomes on the basis of that. Seems to imply at least that early non-invasive support does minimize the number of patients who probably will go on to ventilatory support. And when they do go on to ventilatory support, even on a delayed basis, their outcomes are not significantly, in a propensity adjusted kind of a model, not significantly different from the patients who are initially intubated, seeming to imply that really, as much as everybody else is saying that there is an increased mortality with delayed intubations, I'm not very sure that this particular kind of study shows us that kind of a direction. So it is my tendency, again, after my initial enthusiasm for using a lot of early invasive ventilation, I've been going around with a lot of high flow nasal cannula as my initial support. As long as the patient is reasonably comfortable and has got a reasonably low FiO2, that is usually the dictation. Very often you'll see somebody on 100% FiO2 saying that they're perfectly comfortable under their circumstances, but there I'm a little cautious. I'm not going to go and leave them on that. So under those kinds of conditions, I may have a tendency to intubate them a little on the earlier side, but my tendency to try non-invasive and not non-invasive ventilation, but dominantly high flow nasal cannula has been something that has been quite steady through the later parts of the pandemic. So a little different in terms of my approach, I guess.
So can I summarize in this way that we have to tailor-made the patient's need and the requirement? What is his demand? If his demand is too high and patient is visibly too distressed, then probably we should not delay it, intubate the patient. I have seen many patients who were on NIV. Somebody took out the NIV mask just to give them some feeding or give them a sip of water. And during that time, their saturation crashed and they become unresponsive and get intubated. So in back of my mind, I thought that probably we have delayed intubation in those patients. They were the candidate for intubation little early. I don't know. Only time will tell what is right and wrong. So coming to the intubation, Professor Mitch-Levy, there was so much hype about these two types of ARDS. The Professor Gattinoni's paper came into the limelight where he has put it two types of ARDS, the L type and S type, where the compliance was good and compliance was bad. What is your take on?
So there's a couple of things. I think more than even regular ARDS, COVID ARDS, whether we believe there are two phenotypes or not, I think certainly we think that the initial injury is a pulmonary vascular injury. But more importantly, to me, what we found at the bedside is individualizing the approach for mechanical ventilation for each patient. So there are certain patients, you could say it's the high compliance phenotype, they don't tolerate high PEEP. We routinely use high PEEP, but in these patients, when we go to the bedside and we start to increase their PEEP much above 10, their oxygen saturation deteriorates. Is that truly a different phenotype? I'm not really sure. I do think that we just have to individualize therapy in that some patients don't tolerate higher PEEP, so we just don't try to use it. I still try to keep the tidal volume readily low. On the other hand, I do think that self-induced lung injury is a reality. And so I don't let patients have wild swings in intrathoracic pressure by leaving them on pressure support when they have high compliance. So I think I'm giving you kind of a mixed answer. I don't really know if there are truly two separate phenotypes, but there are clearly some patients who do not tolerate higher PEEP, and I don't force those patients to have higher PEEP, and I don't let patients have large tidal volumes and spontaneous respiration.
Dr. Chawla, sir, what is your take on?
Initially I thought what Dr. Gattinoni also said, and people started differentiating between L type and H type. Over the years, a lot of data also, a lot of people feel that this is a process initially these patients are L type and then they become H type. So what now we follow most of the time, we follow the low tidal volume lung protective strategy in most of the patients. Like Mitchell-Levy said that if the patient does not tolerate high PEEP, they can, so that individualized little bit to the patient. But by and large, we follow the simple ARDS protocol, which we have been doing for all these patients. That is the conclusion now we have come to. I mean, that's what we are following in all our patients. And we do paralyze these patients. And now I think the new sepsis guideline also says that give boluses. We were already giving boluses rather than giving continuous infusion after 48 hours, because many of these patients are so sick, their FiO2, even in prone position, will not come down. You have to paralyze them beyond 48 hours because ECMO is not available everywhere and every patient cannot be put on ECMO because of the cost reasons, because of the availability and other things. So this was the usual pattern we followed. And as they got better, then of course, we were trying every day and we withdrew the neuromuscular agents and then kept them the minimum RAS, whichever the patient was comfortable, -1 to -2, or if they were requiring more, then we were going to the deeper sedation. That was the usual we followed in the later part, and we had a good results. So that's what my impression and what I gathered about the ventilation in these patients.
Dr. Ram, sir, what is your take on?
Again, I'm not very clear. In the beginning, I was a very strong believer in what Professor Gattinoni was saying, the belief that the early phases, if you can catch them with a high elastance, high elastance lung, that you can get away with larger tidal volumes and less PEEP under those circumstances. But again, I think the kind of mix that we see at the time of presentation itself seems to be quite variable. Just going back and looking at the lung safe data that shows that these kinds of patterns are even common in the pre-COVID era in ARDS lungs, where roughly about a quarter of the patients had this high compliance kind of features, the low elastance kind of features too. So it's not necessarily very different as we see here. But again, as Mitch Levy clearly says, I think we need to clearly individualize our management. It clearly depends on the given patient. The one thing that I strongly recommend to most of our fellows, again, is not to use pressure control or pressure support and leave it at that, primarily because it does camouflage the amount of diaphragmatic effort that the patient may put in and may give you false impressions of very high compliance too. So I would probably use something like a volume control, primarily to get a reasonable idea of the amount of patient effort that goes on at the same time. We don't have esophageal balloons in most of our patients, so we have to have some kind of a secondary guess of how much diaphragmatic effort is going in. And as long as we're doing that, and then we use the standard low tidal volume basic ARDS protocols in terms of managing these patients. But otherwise, I don't think there's a distinction between these two phases. I think we need to be very clear that there is quite a good mix of the variety, and we need to be individualizing the care to each of these.
So how much PEEP were you using in majority of the patient? I know it has to be individualized, as Professor Mitch Levy has said.
Again, I think we were a little conservative after finding a large amount of our lungs where the barotrauma was occurring either on the ventilated patients or even on unventilated patients. And that sort of put in a little bit of fear in us in terms of liberally using our PEEP. I would say an average PEEP that we would use is between 12 and 14, not much higher than that, which would be the level of comfort that we would have. But again, as you say, individualize it. Occasionally, we have needed to use much higher PEEPs too.
Dr. DeBaker, sir, what is your take on?
Well, I agree with the concept that we should individualize the ventilatory settings as well as we individualize a lot of things there. And I'm not so sure there are two patterns. I think there are multiple patterns and that we need to adapt to the specific pattern of the patient. And so it is ridiculous to put a PEEP of 20 when the patient would be okay with a PEEP of 10. So it's is really basically adapting to the patient. And indeed, the average PEEP is somewhere between 12 and 14. And some people had 16 or sometimes slightly higher, but and sometimes it's only 10 for others. So it's really making measurements. We used a lot pressure volume curves to try to identify best PEEP, and it was very variable according to the different patients we had.
Dr. Amin, sir, what is your take on about the setting of PEEP?
I agree with most of the participants that the PEEP we tend to be keeping lower than conventional ARDS. And, you must remember that the last year and a half, we've probably treated more ARDSs than the last 20 years that we have come together. If you look at the number of ARDSs that we have treated in the last 1.5 years, it's probably much more than 20 years. And there is something different about this ARDS. Clearly, the amount of barotrauma that we see, I don't think I've seen so much barotrauma in terms of this thing. And these are patients, you're not getting very high, your driving pressures may not be necessarily high, your PEEPs and your plateau may not be high, and you still end up seeing, when you do the CT scan, a lot of pneumomediastinum, a lot of pneumothorax, and multiple, sometimes you need to put in multiple drains. So, it is not like a regular ARDS, no question about it. And I used to be pretty liberal with my PEEP, with conventional ARDS, but I am a little more restrictive with my application of PEEP. And I'm not so enthusiastic about doing recruitment maneuvers in these patients, which I used to do quite often because of the number of barotraumas that we have seen. And that's something which is quite different as compared to any other. And what we have also learned is that most of these patients, we tend to be proning them earlier and for a longer duration of time, much longer than that we would see. And that's a form of a recruitment maneuver. So conventional 40-40 maneuver and all that, we restrict ourselves from doing those maneuvers. So these are some of our concerns.
Sir, with your due permission, whatever little experience I am also having, I'd like to share here that in many patients after the barotrauma happened, we also became little conservative with the PEEP. And we came down to standard PEEP 5, 6, maximum 8 in those patients. In few patients, we tried this spirodynamics and FRC calculation to find out the optimal PEEP. And it was I was surprised to see that going beyond a certain PEEP in few patients, even from 4 to 6 PEEP, it causes the reduction in FRC rather than increasing the FRC. So I agree with everybody that we have to individualize the PEEP in these patients. A single thumb rule cannot go on. Professor De Baker, yes, sir.
I have to admit that I'm a little bit surprised by hearing all of you telling barotrauma, drains, and stuff like this. I mean, in our experience, and we had quite a big number of patients these last months, we had only one patient with pneumothorax requiring drainage at some point, even though we do regular CT and so on in these patients. So honestly, maybe one of the differences is that we always put our patients prone immediately without any exception. And indeed, as mentioned, we put this patient prone for a very prolonged period of time. I mean, 2 or 3 weeks of proning was not unusual. And I think that this is perhaps a way to minimize this barotrauma. The other way to minimize barotrauma is also not to push too long on non-invasive ventilation prior intubation, which is perhaps also something that may lead to this barotrauma. But otherwise, for most of our patients, we never had an increase in barotrauma. This is really very seldom.
Dr. Chawla, sir, what is your?
Just in continuation of the same thing, we saw barotrauma. Most of the patients, they were on low tidal volume. Their plateau pressure was less. They never had a high pressure. They were not on a high peak. Most of these patients who developed barotrauma, they were in that category. And probably this could be related to the different population, because we had seen all across India, a lot of barotrauma, a lot of people with pneumothorax. And this is the experience from various parts of the world also, that they had seen more barotrauma as compared to what we used to see normally in patients of ARDS.
Professor Mitch Levy, what is your take on about the barotrauma thing?
Interesting. My experience is a lot like Dr. Divakar's. We certainly seen barotrauma, and we see primarily mediastinal air rather than frank pneumothoraces. And we tend not to drain them. But I have to admit, it's not a common concomitant. I've read about it and I've heard about it, but I just have not seen, like all of us, we've seen so many COVID ARDS, and I would not say that pneumomediastinum and pneumothoraces is that much more common than with usual COVID in our experience.
Is this something to do with Caucasians? That they don't get so much barotrauma? Because in Asians and in the Asian population, there seems to be a little bit higher as compared to some of my other colleagues.
And is that true in simple ARDS, in usual ARDS, Praveen?
No, I don't think so. I'm just talking about the nature of this particular beast.
Yeah, sure, could be.
No,
Dr. Ram, would you like to say something?
I don't know. Again, I don't know whether my point of view would be biased by the frequency with which we are seeing such severe ARDS in this cluster. Over the last several years, I've been doing prone ventilation and ARDS ventilation probably from the late 90s, okay, so 1995 or so. And in that period of time, with early tendency to put them prone, to use careful tidal volumes, the frequency of barotrauma had always been very low. But what we are seeing right now is a huge cluster. And it's very difficult for me to say that it is not a higher frequency. The reason I'm being a little hesitant is the fact that I don't have the numbers to precisely say that. It's maybe just that I'm ventilating a lot more sicker ARDS patients right now, and I'm seeing that. And as Dr. Levy also said, much of this is not frank pneumothoraces as much as gas in the mediastinum that is detected on the X-ray or on the CT scan. And generally something that we have not needed to intervene on. But there have also been a small excess risk of patients requiring chest tube placements for significant lung loss again. So I think both, I'm a little confused about it. I think we need to look at our data a little bit carefully before we jump to that conclusion.
Dr. Amin, sir.
Yeah, so we've had about quite a number of bronchopleural fistulas which lasted for a prolonged period of time. In fact, they were so sick that we finally had to actually intrabronchially put in spigots into these and block them off. So we're successful in 50% of those cases to block them with intrabronchial spigots. But, the ones who didn't succeed, who went in for thoracoscopy, it was a big mess. The kind of the nature of the lung and things like that, generally, you can do nothing for those kind of bronchopleural fistulas. If you cannot block it off intrabronchially, they invariably end up the patients end up dying.
Dr. Chawla, sir.
The mortality in these patients, whatever literature is available, most of the studies are retrospective. They have found the mortality people developing barotrauma is much higher, almost 60% as compared to the patients below 50% in the other severe ARDS patients. So these patients, the mortality is also high if a person on COVID-19 developed barotrauma on invasive ventilation.
So my next question is, these patients require multiple time of prolonged proning. I remember giving them maybe even 15, 20 session of proning. What I have understood, whether, I don't know, we have done this, whether it was right or wrong. What is your take on, Dr. Ram, on this prolonged proning and multiple proning? I have seen many people who after 3-4 sessions, they just gave up. Okay, there is no fun in proning again and again.
No, I completely feel the same way, that the long proning and repeated proning is extremely common on most of these patients. Again, my experience with proning has always been towards a longer period. Even when the initial trials on proning were saying 6 hours on and 6 hours off, purely from a management perspective, it was easier for us to leave a patient prone for overnight. So 16 to 18 hours was a very traditional kind of way in which we proned our patients. So when we came on to this COVID series also, we were very comfortable with 24-hour longer durations of proning. But here again, we noticed that if we stuck to the same rules and say at 48 hours, when the patient is showing you a reasonable reduction in their FiO2 requirements, if you put them, supinate them, they tend to deteriorate and they need to be repeated many, many times. Yeah, as I agree, I've seen patients going on for months in a prone, not showing an improvement for a very long period of time. So this is something, but they do improve in terms of the oxygenation when they're left in a prone position. So we have a tendency to be very liberal about the use of proning and repeating it as often as possible.
And there were few patients where even proning didn't work. So what should, what was your practice, to continue with proning supine, prone supine, or just?
We would do it as much as we can, primarily because of affordability and practicality in terms of getting ECMO organized. Okay, both, even when we offer ECMO to a patient, on the majority of our patients would probably say the cost was too high for them and they couldn't afford it. So we were being very practical about that. So the tendency to offer ECMO was a little late. So we had a tendency to continue to keep trying the proning as long as possible. Always not very successful. Obviously, sooner or later, a nosocomial infection catches up and ends in a negative kind of a way. But ultimately, that was the approach that we took.
Dr. Chawla, sir.
Another thing which I don't know what is the experience of others, that many of these patients were late responders. After 6-7 hours, they will start responding. Like normally we see in ARDS, they would respond immediately, put them in 1 hour's time, then you will find the response. These patients many of them were late responder, and many of the patients I can remember came out also eventually out of this.
Dr. Amin, sir, what is your take on about multiple session of proning and prolonged?
Yeah, we have proned people for 3-4 days sometimes when they have gone, and we have done it numerous times. There have been patients who have been in our ICU for months, and they've been proned at least 5 or 6 times, or even more in some situations. So repeated proning, prolonged proning is something, because the moment you turn them around, their saturation would drop down to the 80s. So, they would be quickly turned back again. So these are things that we have probably, like I said, this is a different type of ARDS. Though whatever you say, it is an ARDS, it is a different type of ARDS. And I think it's probably just not the airway resistance that is, you don't see the plateau pressure going up, but they're still very hypoxic. So I think there is a clearly micro circulation, which Mitch mentioned, about some pulmonary microcirculation, which is also affected. And clearly, I think because these patients have astronomically high D dimers in the 9,000, 10,000 range, and they're the ones who are quite hypoxic when they have this severe form of ARDS. So there is probably, and when you invariably you look at, when you do their PICOs and when you look at their echoes, you will also see that they get a pulmonary hypertension pretty early. And some of them, we actually have done pulmonary, because the echo shows quite significant pulmonary hypertension. We have even done pulmonary angiogram and not found any major embolism there. But the echo showing severe pulmonary hypertension. So these are some of the, as I said, this is a different kind of beast that we are actually treating.
Professor Mitch Levy, sir, what is your take on?
Well, we have glass doors in our ICU, and we would write when people were proned, and sometimes they would go to the floor because we would prone them, put them back on their back, and prone them again. And for us, we would do it almost like a dose response. When people would stop responding to proning, then we would stop. And we didn't have the experience of late responders that I think Ram said, but it was.
Dear friends, I welcome you all to the inaugural ceremony of this historic World Conference on COVID and Critical Care. I invite dignitaries to the virtual dais. First and foremost, our chief guest, Honorable Shri Om Birla Ji, Speaker of Parliament of India. Dr. George Hidalgo, President-elect, World Federation of Intensive Care Society. Dr. Deepak Govil, President, Indian Society of Critical Care Medicine. Dr. Praveen Amin, the senior most past president of Indian Society of Critical Care Medicine. Dr. Narendra Rungta, Chief Organizing Secretary. Dr. Ranveer Singh Tyagi, Organizing Secretary. Dr. Lalit Singh, Chief Coordinator. Dr. Rakesh Kumar Tyagi, Coordinator. And I am here, Dr. Deeptimala Agrawal, the Scientific Secretary, as your anchor of ceremony today. I invite Dr. Narendra Rungta for the welcome and introduction. Dr. Rungta is the Chairman and Managing Trustee of Critical Care Foundation. He is the past President of ISCCM and Founder past President of Association of SARC Critical Care Societies. Over to Dr. Rungta.
Thank you, Dr. Deepti. Good morning, everybody. Manya Shri Om Birla Ji, Speaker, Parliament of India. Dr. George Hidalgo, President-elect, World Federation of Intensive Care Societies. Dr. Deepak Govil, President, Indian Society of Critical Care Medicine. Dr. Praveen Amin, past President of Indian Society of Critical Care Medicine, one of those the group who founded ISCCM. My colleagues from the organizing committee, Dr. Ranveer Singh Tyagi, Dr. Lalit Singh, Dr. Deeptimala, Dr. Rakesh Tyagi, members of the faculty from all around the world, delegates, members of media, ladies and gentlemen. मुझे आप सबका स्वागत करते हुए अपार हर्ष की अनुभूति हो रही है। माननीय स्पीकर महोदय, आपने हमारा आग्रह स्वीकार कर आप इस कॉन्फ्रेंस में पधारे, हमें आशीर्वाद प्रदान किया। हम आपके हृदय से आभारी हैं। इससे हमारा मन बढ़ेगा, डेलीगेट्स मोटिवेट होंगे। फ्रेंड्स, जब हिंदुस्तान ही नहीं पूरी दुनिया कोविड के तांडव से जूझ रही थी, चारों तरफ भय और अनिश्चितता का माहौल था, सोशल मीडिया में अफवाहों का जाल और विज्ञान निरुत्तर था, तब क्रिटिकल केयर फाउंडेशन और इंडियन सोसाइटी ऑफ क्रिटिकल केयर मेडिसिन ने मिलकर सोचा कि अब उचित समय है कि हम निर्णय लें और दुनिया के समस्त देशों के वैज्ञानिकों के, चिकित्सा वैज्ञानिकों को एक छत के नीचे लाके ब्रेनस्टॉर्मिंग करें। क्या हो रहा है, क्या हुआ है, क्या होना चाहिए, इस पे विस्तृत विचार विमर्श हो। क्या सही है, क्या होना चाहिए, क्या नहीं होना चाहिए, इसके दिशा निर्देश तैयार किए जाएं और आम जनता को प्रेषित हों। इस भावना से इस कॉन्फ्रेंस का जन्म हुआ और आज हम यहाँ हैं 1500 डेलीगेट, 300 से ज्यादा 40 देशों के फैकल्टी एक्सपर्ट्स, 300 से ज्यादा प्रेजेंटेशंस, 8 वर्कशॉप्स यहां अगले 3 दिनों में होगी। इसके अंदर पीपीई किट से लेके वेंटिलेटर तक, छोटी सी छोटी बातों से रोकथाम से लेके निवारण तक, ऑक्सीजन से लेके एंटीबायोटिक तक, और नर्सों से लेके डॉक्टरों को क्या करना चाहिए क्या नहीं करना चाहिए, इस पे विचार विमर्श होगा। पिछले दिनों जब हम लोग जूझ रहे थे तब देखा गया कि नर्सों की भारी कमी हुई, उनकी ट्रेनिंग का भी अभाव हम सबको खला। इसलिए इस कॉन्फ्रेंस में उनकी नॉलेज और स्किल बढ़ाने के ऊपर खास प्रयास किया जा रहा है। फ्रेंड्स, एक 680 पेजेस की अपडेट ऑन ई कोविड क्रिटिकल केयर तैयार किया गया है। इसके एडिटर्स डॉक्टर बनाम्बर रे, डॉक्टर बाजन, डॉक्टर प्रशांत नासा, डॉक्टर केदार तोरस्कर और डॉक्टर अभिषेक, इन्होंने मिलके अथक प्रयास करके दुनिया में जितना भी लिटरेचर कोविड के बारे में उपलब्ध है उनको एक जगह संकलित करके हमारे लिए तैयार किया गया है, और ये बुक माननीय स्पीकर महोदय अभी हम सब के लिए रिलीज करेंगे। इसी प्रकार नर्सेज के लिए भी एक विशेष प्रकार का मैनुअल तैयार किया गया है, जिसमें उनको सिखाए जाने की कोशिश की गई है कि किस तरह वो इस तरह के मरीजों की देखभाल अच्छी तरह से और अच्छे रिजल्ट्स के लिए कर सकें। उनके लिए एक 1.5 दिन का वर्कशॉप भी पूरा आयोजित किया जा रहा है, जिसमें लगभग 500 नर्सेज ने रजिस्ट्रेशन किया है। महोदय, मेरा ये मानना है कि ये हमारी कॉन्फ्रेंस भी इस डायरेक्शन में एक अनूठा प्रयास है। पूरी दुनिया में हमारी समझ में पहली बार ऐसा प्रयास हुआ है कि दुनिया भर के हर कोने से, चाहे वो नॉर्थ अमेरिका हो, चाहे साउथ अमेरिका हो, चाहे यूरोप हो, इंग्लैंड हो, ऑस्ट्रेलिया, न्यूजीलैंड हो, चाहे फार ईस्ट हो, या इंडियन सब कॉन्टिनेंट का कोई भी देश हो, उनके एक्सपर्ट्स यहाँ पे जुटे हैं और अपनी बात बताएंगे, हम सब के साथ शेयर करेंगे, जिसको हम आगे बढ़ाने की कोशिश करेंगे। ये एक शुभ संयोग है कि आज जब यहाँ आप पधारे हैं, उसके एक दिन पहले ही माननीय प्रधानमंत्री ने 100 करोड़ टीके लगने का शुभ समाचार इस देश को दिया, और जिस प्रकार से भारत सरकार ने भारतीयों को सुरक्षा कवच प्रदान किया है, वो पूरे विश्व के लिए मिसाल बना है। भारत का चिकित्सा जगत भी इससे बहुत प्रभावित हुआ है और मोटिवेटेड है। मेरा विश्वास है कि इस फैकल्टी से हमें बहुत कुछ सीखने को मिलेगा। हम उनसे बहुत डिमांडिंग रहे हैं और उन्होंने हमारी सारी डिमांड पूरी भी की है। इस थोड़े से अल्प समय में 3 से 4 महीने में जो भी हम भारतीय चिकित्सा जगत के लिए कोविड के बारे में जानकारी एकत्रित कर सके हैं, वो हम अगले 3 दिनों में पेश करेंगे। एक बार फिर पुनः हम आपका स्वागत करते हैं, आपको धन्यवाद देते हैं, और हमारे डेलीगेट्स, हमारी नर्सेस, हमारे नौजवान डॉक्टर्स, उनसे आग्रह करते हैं कि ऐसे मौकों का पूरा फायदा उठाएं और कोविड या कोई भी पेंडेमिक कोविड जैसा हो, उसमें हमारे नागरिकों की सुरक्षा और उनकी जीवन को बचाने की का अथक प्रयास करें। थैंक यू वेरी मच।
Thanks, Dr. Rumta, for enlightening us on the vision behind this conference. I invite Dr. George Hidalgo, President-elect, World Federation of Intensive Care Society, to share his views.
Well, first of all, I want to thank you to the organizing committee to allow me and give me the opportunity. And of course, I want to congratulate Dr. Narendra, who is leading such a great program. And I want to take an opportunity to say hi to one of my I can say mentors, Dr. Praveen. Dr. Praveen always guide me in the World Federation, and I want to recognize his leadership. And I believe after March 11 last year, when initially we have the great lockdown, and we see that the lockdown was gradually extended around the world, we never thought that by around this time, October 2021, we still basically understanding and learning more about COVID-19. COVID-19 definitely came to stay, and a program like this that we are going to have an opportunity to learn from the experience of many countries, and also from the experience of many experts in different areas, definitely is coming to contribute greatly to the knowledge that we are still gathering, and also in this process to understand a disease that came to change our life. I want basically to congratulate and wish definitely a successful World Conference. And one more time, my congratulations to the organizing committee. Thank you.
Thanks, Dr. Hidalgo. Thanks, Dr. Hidalgo, for sharing your words of wisdom. अब मैं डॉक्टर रूंगटा से अनुरोध करूंगी कि वो हमारे माननीय मुख्य अतिथि को इंट्रोड्यूस करें.
Friends, Shri Om Birla ji is an icon and he doesn't need any introduction. He is a very popular leader, a tall leader, a ground level political worker since a long time I know. He is the 17th and current Speaker of the Lok Sabha. Lok Sabha is used for parliament in Hindi. He serves as a member of parliament from Kota Bundi constituency in Rajasthan, my own state. Prior to the parliament, he was elected thrice to the Rajasthan State Assembly and had a number of assignments, which includes District President of Bharatiya Janata Yuva Morcha, the young brigade of Bharatiya Janata Party, the current ruling party of India. He was the State President of Bharatiya Janata Yuva Morcha and the National Vice President of Bharatiya Yuva Janata Morcha. He was also the Vice Chairman of National Cooperative Consumer Federation Limited and Chairman of Confed Jaipur. Besides that, I remember the huge work taken by him under his leadership in Bhuj when earthquake struck that region way back, but 20 years back, on 26th of January. I have heard and known him for a long time as a tall political leader in my own state. So it's a huge privilege for all of us, and may I request all of you to join me in welcoming Shri Om Birla ji for gracing this occasion. Please give him a rousing welcome. Shri Om Birla ji, कृपया अपना भाषण दें सर.
World Conference on COVID and Critical Care के उद्घाटन समारोह में इस सेमिनार को आयोजित करने वाले जयपुर के प्रमुख चिकित्सक डॉक्टर नरेंद्र रूंगटा जी, श्री जॉर्ज देश विदेश से जुड़े सभी चिकित्सक, पैरा मेडिकल, नर्सेज, सभी भाइयों और बहनों, आज आप सबसे मिलकर बहुत खुशी हो रही है कि सम्मेलन में डॉक्टर्स हैं, फार्मासिस्ट हैं, फिजियोथेरेपिस्ट हैं, पैरामेडिकल है, साइंटिस्ट है, हेल्थ रिसर्चर हैं। इतनी बड़ी संख्या के अंदर सभी ये पूरे विश्व में एक तरह का ऐसा सम्मेलन है जिसमें कोविड महामारी उस पूरे विश्व के डॉक्टर तथा स्कॉलर जुड़े हुए हैं। इस अवसर पर मैं आप सबको बधाई देता हूं। आज विश्व में भारत के लिए सबसे बड़ा कीर्तिमान भी है कि दुनिया के अंदर यहां चलाकर 100 करोड़ से अधिक डोज वैक्सीन के लगाकर पूरे विश्व में कीर्तिमान हासिल किया है। पूरे विश्व में कोरोना के खिलाफ इस महायुद्ध में ये एक बहुत बड़ी उपलब्धि है कि हमने इस कोवैक्सीन के माध्यम से सुरक्षा कवच दिया है। आज का ये आयोजन मेरे विचार में एक महत्वपूर्ण वैश्विक प्रयास है कि होल्डर इस आयोजन में जुड़े हैं। इसके माध्यम से इस महामारी ने जो हमें सिखाया है और भविष्य में जब भी कोई महामारी आए तो हम किस तरीके से सामूहिकता से मुकाबला कर सकते हैं। इसने ये भी सिखाया कि राष्ट्र चाहे कितना भी समर्थ हो, कितना भी कोई राष्ट्र संसाधन युक्त हो, शक्तिशाली हो, लेकिन ऐसी वैश्विक महामारी का अकेला मुकाबला नहीं किया जा सकता। और इसीलिए हमने सिखाया है पूरा विश्व एक है और इस विश्व की लिए मानवता के लिए हमको सामूहिक प्रयास करने की आवश्यकता है, क्योंकि ये महामारी विश्व के सभी देशों के अंदर इसका प्रभाव पड़ा है और इसको लेकर विश्व के कई देशों के आर्थिक और सामाजिक ढांचे भी चल रहे हैं। लेकिन अब समय आ गया है कि हमें ऐसी वैश्विक महामारी का मुकाबला करने के लिए सामूहिक प्रयास करने की आवश्यकता है। हमारे देश ने भी कोरोना की 2 वेव का सामना किया। कोरोना की पहली वेव जब विश्व में आई थी तो हमारे पास न आवश्यक इंफ्रास्ट्रक्चर था, न दवाइयां थी, न पीपी किट थे, न डॉक्टरों की सुरक्षा के कवच थे। लेकिन उसके बाद भी हमने कम समय के अंदर सबके प्रयासों से इन संसाधनों को जुटाया और विशेष रूप से हमारे डॉक्टर्स, पैरामेडिकल स्टाफ, फ्रंट लाइन वर्कर ने इस कोरोना योद्धा के रूप में जो काम किया, कम संसाधन होने के बाद भी अपनी जान की बाजी लगाकर पहली वेव का मुकाबला किया। क्योंकि इस वेव के बाद हमने विकसित देशों के हालत भी देखे थे। विकसित देशों में भी इतना मजबूत चिकित्सा इंफ्रास्ट्रक्चर होने के बाद भी वह देश भी इस महामारी से मुकाबला नहीं कर पाए थे। दूसरी वेव निश्चित रूप से भारत के लिए बहुत आक्रमण थी। बढ़ती मरीजों की संख्या, ऑक्सीजन की कमी, स्वास्थ्य ढांचे पर अत्यधिक दबाव, लेकिन उसके बाद भी दूसरी वेव ने भी हमने मुकाबला किया। ये बात सही है कि दूसरी वेव में हमारे कई साथी नहीं रहे, समाज के कई लोग हमसे पिछड़ गए, कई हमारे चिकित्सक, पैरा मेडिकल स्टाफ, फ्रंट लाइन वर्कर नहीं रहे। उन सब का हमें दुख है, पीड़ा है कि हम संपूर्ण प्रयासों के बाद भी उनको नहीं बचा पाए। लेकिन दूसरी वेव के अंदर भी जिस प्रकार से चाहे चिकित्सक हो, चाहे पैरामेडिकल स्टाफ हो, चाहे नर्सेज हो, तमाम लोगों ने दूसरी वेव में जिस सामर्थ्य के साथ काम किया, मुझे याद है उस समय परिवार के लोग भी नजदीक नहीं आते थे, लेकिन हमारे चिकित्सक और फ्रंटलाइन वर्कर मानव सेवा के लिए जुटे रहे, अपनी जान की बाजी लगाकर। और उस दूसरी वेव में कई चिकित्सक हमारे बीच में नहीं रहे, पैरामेडिकल स्टाफ नहीं रहे, सफाई कर्मी नहीं रहे, लेकिन उसके बाद भी उस कोरोना के उस महायुद्ध के अंदर जो आपका अथक प्रयास रहा, इसके लिए मैं आपको साधुवाद देता हूं। यह भारत के मानव संसाधन की ताकत थी कि हमारे संस्कार समर्पण और सेवा के संस्कार हैं। मानवीय सेवा हमारे जीवन के अंदर हमें संस्कारित रूप से मिली है और इसीलिए हमने दूसरी वेव का मुकाबला किया। लेकिन अब समय आ गया है कि पहली वेव और दूसरी वेव हमने देखी है। पहली वेव और दूसरी वेव के बाद, पहली वेव में न हमारे पास दवाइयों की एसओपी थी, न इंफ्रास्ट्रक्चर थे, न कोई गाइडलाइन थी। दूसरी वेव में कुछ हमारे पास दवाइयों की गाइडलाइन, कुछ जांच के किट, कुछ जांच के परिणाम, कुछ वैज्ञानिकों के अध्ययन जरूर थे, लेकिन ऑक्सीजन की कमी आएगी ये हमें जानकारी नहीं थी। लेकिन उसके बाद हमने इससे सबक लिया है। पूरे विश्व ने इस वैश्विक महामारी से सबक लेकर इसके मुकाबले के लिए सामूहिक प्रयास किए हैं, अनुभव साझे किए हैं। साइंटिस्टों ने अपने अपने तरीके से जो खोज की, जो रिसर्च किए, उस रिसर्च को साझा किया है। हमने हमारी टेक्नोलॉजी और बेस्ट प्रैक्टिस को आपस में साझा किया है, जिसके कारण हम कोविड की महामारी भविष्य में मुकाबला कर पाएंगे। फ्यूचर वे के मुकाबला करने के लिए हमारे पास व्यापक संसाधन है, लेकिन फिर भी हमें दो तरह की योजनाएं बनानी पड़ेगी, एक शॉर्ट टर्म, एक लॉन्ग टर्म। दो तरह की कार्यनीति बनाकर हम किस तरीके से शॉर्ट टर्म के अंदर जब महामारी हो तो उसकी आवश्यकता के अनुसार संसाधन जुटाने और लॉन्ग टर्म के अंदर हमें हमारे चिकित्सा इंफ्रास्ट्रक्चर को तैयार करना पड़ेगा। हमारे हॉस्पिटल बेड, ऑक्सीजन आदि की व्यवस्थाएं करने की आवश्यकता है। भारत में इसको लेकर व्यापक प्रयास किया है। हमने वैक्सीनेशन के साथ साथ हमारे ऑक्सीजन की व्यवस्थाएं हमने पूर्ण की है। हमने चिकित्सा इंफ्रास्ट्रक्चर के ढांचे को तैयार किया है ताकि भविष्य में कोई भी वैश्विक महामारी हो तो हम इस पर्याप्त संसाधन जुटा सकें। ऐसा देश की सरकार और राज्य सरकारों ने मिलकर प्रयास किया है। आने वाले समय के अंदर हमें एक व्यापक वैश्विक कार्य योजना भी बनाने की आवश्यकता है। ये वैश्विक कार्य योजना इस तरीके की होनी चाहिए ताकि हम हमारे अनुभवों और विचारों को एक दूसरे से साझा कर सकें। हमारे जितने भी रिसर्च हैं, हमारे क्रिटिकल केयर के लिए जो हमने प्लान बनाए हैं, देश में जो बेहतर प्लान बना है उसको हमें व्यापक योजना बनानी चाहिए ताकि हम एक बेहतर तरह की एसओपी डेवलप कर सकें, ताकि उस एसओपी के माध्यम से हम जब कभी भी महामारी हो तो उसका मुकाबला कर सकें। और इसके लिए हमें ग्लोबल सप्लाई चेन और नेशनल सप्लाई चेन दोनों को भी सशक्त करने की आवश्यकता है। आज देश के अंदर सभी क्रिटिकल केयर इक्विपमेंट के व्यापक उत्पादन की आवश्यकता है कि हम क्रिटिकल केयर के नई टेक्नोलॉजी के इक्विपमेंट का उत्पादन कर सकें, आवश्यकता अनुसार टेक्नोलॉजी का उपयोग कर सकें और आवश्यकता अनुसार जो नई टेक्नोलॉजी डेवलप हुई है उस नई टेक्नोलॉजी को भी आपस में साझा कर पाएं। इसलिए पेंडेमिक के अंदर क्रिटिकल केयर का सबसे बड़ा महत्वपूर्ण योगदान होता है और उस क्रिटिकल केयर के योगदान में हमें आज की नई इंफॉर्मेशन टेक्नोलॉजी, नई टेक्नोलॉजी का उपयोग करने की आवश्यकता है, क्योंकि दुनिया के अंदर अब कोई भी महामारी का अगर मुकाबला किया जा सकता है तो नई टेक्नोलॉजी से ही मुकाबला किया जा सकता है। मैं आप सब चिकित्सकों, वैज्ञानिकों को विशेष रूप से धन्यवाद देना चाहता हूं कि आपने दुनिया के अंदर विज्ञान के क्षेत्र में, चिकित्सा की टेक्नोलॉजी क्षेत्र में जो नया डेवलप किया है वो अपने आप में ऐतिहासिक है। जब मैं पढ़ता हूं कि नए नए आपके रिसर्च, नई नई आपके विज्ञान की टेक्नोलॉजी, तो मुझे लगता है कि आने वाले 10-20 साल बाद जिस टेक्नोलॉजी का उपयोग आप कर रहे हैं, जिस तरीके का रिसर्च कर रहे हैं, जिस तरीके का वैज्ञानिक आप अध्ययन कर रहे हैं, आने वाले समय के अंदर आपके प्रयासों से मानवता की रक्षा के लिए एक महत्वपूर्ण कदम आपके सहयोग के कारण होंगे और हम दुनिया के अंदर कोई भी महामारी के मुकाबले लड़ने के लिए सक्षम होंगे। लेकिन इसके लिए हमें विश्वव्यापी प्रयास करने की आवश्यकता है। कोरोना ने यही सिखाया है कि अब एक देश, एक राष्ट्र नहीं, पूरा विश्व कोई भी महामारी, कोई भी बीमारी के लिए एक है और हमें सामूहिक रूप से मुकाबला करने के लिए सामूहिक प्रयासों को करने की आवश्यकता है। ये हमें इस कोविड ने सिखाया है। मैं दुनिया के जब कई देशों में जाता हूं तो मैं देखता हूं कि वहां पर जिस तरीके की कोरोना के बाद रिसर्च हो रही है, किस तरीके से वहां पर कैपेसिटी बिल्डिंग किया जा रहा है, कैसे किस सिस्टम को डेवलप किया जा रहा है, भारत भी इस दिशा के अंदर अग्रिम पंक्ति पर है। भारत ने जहां पर नई टेक्नोलॉजी, नए इक्विपमेंट, नए संसाधन जुटाने का काम किया है, आत्मनिर्भर भारत के तहत हमने यहाँ अपना उत्पादन बढ़ाने का काम किया है। मानव संसाधन के रूप में हमने 1 लाख से ज्यादा फ्रंट लाइन वर्कर्स तैयार करने का काम किया है। हमने गांव में चिकित्सा इंफ्रास्ट्रक्चर को तैयार करने का काम किया है। क्रिटिकल केयर गांव तक पहुंचे, उसका महत्वपूर्ण काम किया है। और उसके साथ साथ हमने कोशिश की है कि हर गांव में हमारा मानव संसाधन पूर्ण रूप से प्रशिक्षित हो, क्योंकि मैंने देखा था इस बार कोरोना के अंदर कि गांव के अंदर हमारा इंफ्रास्ट्रक्चर इतना मजबूत नहीं था, न हमारे पास मानव संसाधन इतने प्रशिक्षित थे। एक एनएम को 8-8 गांव के अंदर कोविड के समय संभालना पड़ता था, 15 से 20-25 किलोमीटर तक। लेकिन अब आने वाले समय के अंदर सरकार इस दिशा की ओर काम कर रही है कि हर गांव के अंदर मेडिकल पैरा स्टाफ को प्रारंभिक रूप से कुछ ट्रेनिंग दी जाए और उनको प्रशिक्षित किया जाए, ताकि कभी कोई बीमारी हो तो उसका सामान्य रूप से वो इलाज करने में सक्षम हो। यही हमारी शक्ति है। और कोरोना जैसी इस महामारी के लिए विश्व को सामूहिक प्रयासों की आवश्यकता है। मैं इसके लिए आज आपकी इस कॉन्फ्रेंस के लिए आपको साधुवाद देता हूं, बधाई देता हूं कि केवल आप इलाज ही नहीं करते, आप किस तरीके से आने वाले किसी भी चुनौती के लिए चिंतित हैं। आने वाली किसी भी चुनौती का मुकाबला करने के लिए आपने कार्य योजना बनाने के लिए अभी से लगातार आप अपने विचारों, अनुभवों, रिसर्च को लगातार साझा कर रहे हैं। इससे निश्चित रूप से चर्चा, संवाद, बातचीत से निर्णय होते हैं, फैसले होते हैं, और वो फैसले और निर्णय जन कल्याण में होते हैं। यही लोकतंत्र की ताकत है। लोकतंत्र के अंदर जब हम कोई चीज को लेकर सामूहिक चर्चा करेंगे, विचार विमर्श करेंगे, विचारों का आदान प्रदान करेंगे, अपने अनुभवों को साझा करेंगे, हमारी बेस्ट प्रैक्टिसेस को साझा करेंगे, एक दूसरे का मार्गदर्शन करेंगे, तो उससे जो परिणाम आएंगे, उस परिणाम से हम समाज और मानव कल्याण का, जन कल्याण का काम कर पाएंगे। यही काम आज आप कर रहे हैं कि कोरोना समाप्त होने के बाद भी आप किस तरीके से कि आने वाले समय के अंदर कौन कौन सी चुनौतियां पूरे विश्व में हो सकती है, इसके लिए हमें कैपेसिटी, नॉलेज के साथ, रिसोर्स के साथ अपने अनुभव को साझा करने के लिए जो आपने आज कॉन्फ्रेंस की है, मैं इसके लिए आप सबको बहुत बहुत साधुवाद देता हूं, बधाई देता हूं। मुझे आशा है आने वाले समय में इस कॉन्फ्रेंस के परिणाम आएंगे। जब इस 2 दिन की कॉन्फ्रेंस के बाद जब आपके सारे विचार, अनुभव होकर साझा कर एक अंतिम प्रतिवेदन बनेगा और उस प्रतिवेदन के जो रिजल्ट होंगे, परिणाम होंगे, उसके आधार पर आप भविष्य की कार्य योजना बनाएंगे, तो निश्चित रूप से हम किसी भी चुनौती का मुकाबला करने के लिए सक्षम होंगे। मैं इस सेमिनार के लिए आयोजक नरेंद्र रूपटा जी को, उनके सभी सहयोगियों को बहुत बहुत साधुवाद देता हूं, बधाई देता हूं, और आशा करता हूं कि दुनिया के अंदर कोई भी महामारी होगी तो विश्व के सभी लोग साझा और सामूहिक प्रयास से इसमें निपटने में सक्षम होंगे। आप सभी को बहुत बहुत साधुवाद, बहुत बहुत धन्यवाद।
Thank you so much, sir, for your words of encouragement and blessing. I invite our chief guest to inaugurate the conference with auspicious and conventional lamp lighting and request all the dignitaries on dais to join. Now the time has come for the release of the update ebook on COVID and critical care by our chief guest, Honorable Shri Om Birla Ji, Speaker, Member of Parliament. And I request our editors to join in, Dr. Banambar Ray, Dr. Khushra Bhajan, Dr. Prashant Nasa, Dr. D.P. Samadar, Dr. Abhijit Raha, and Dr. Kedar Toraskar. Their untiring and relentless efforts have made this update book possible. Now we come to the release of our nursing workshop e-manual. For this, I request Dr. Deepak Govil, President, Indian Society of Critical Care Medicine, Dr. Praveen Amin, past President of ISCCM, and our editors, Dr. Sunil Kumar Garg, Dr. Gunjan Chanchalani, and myself, Dr. Deepti Mala. I am here for the release of our nursing workshop e-manual. I request Dr. Lalit Singh to deliver the vote of thanks.
Good morning, everyone. Honorable Sri Om Birla Ji, dignitaries on dais, this is my proud privilege to present the vote of thanks on behalf of organizing committee of the World Conference of COVID and Critical Care. Especially to you, Speaker Sir, for sparing your valuable time and blessing the conference. And this will motivate all of us. I also thank all the faculty members from all over the world and India. I would like to thank Dr. Narendra Rungta sir, who is the driving force for this biggest global feast on COVID. My special thanks to Dr. Deepak Govil, President, Indian Society of Critical Care Medicine, for his constant support. My colleagues, Dr. Ranveer Tyagi, Dr. Deepti Mala Agrawal, Dr. Rakesh Tyagi deserve a special mention for their selfless effort. I would like to thank the editor of the update book on COVID and critical care, Dr. Banambar Ray sir, Dr. Khushra Bhajan, Dr. Prashant Nasa, Dr. D.P. Samadar, Dr. Kedar Toraskar, and Dr. Abhijit Raha, and the contributor of the update book. Update of the nursing manual, Dr. Deepti Mala Agrawal, Dr. Sunil Garg, Dr. Gunjan Chanchalani, and contributor of the manuals. I am also thankful to the delegates, without whom the conference would not be successful. My sincere thanks to industry and all our sponsors for their support. I would also like to thank our conference partners, Meeting and More, for their support and hard work. Thanks to the press and media people. My heartfelt thanks to each and every one whose name I could not mention, but who has contributed in making this conference possible. Jai Hind.
Thanks all. With this, we move on with our next scientific session.
I would like to request Dr. Dipti ma'am, please introduce the session.
I would like to begin this session, which is the oral paper presentation for the 11:30 session. And our chairpersons for this session are Dr. Rajesh Mishra, who is the Honorary Consultant Intensivist and Internist, Ahmedabad, Epic Hospital, Kidney Health and Hospital, Naranpura, and Sanjeevani Super Speciality Hospital. Dr. Rose Chaco, Senior Consultant and Head, Critical Care and Emergency Services at Narayana Health, Bangalore. Dr. Sumit Rai, Head of Department, Critical Care Medicine and Medical Director at Holy Family Hospital, Delhi. And Dr. Deeptimala Agarwal, Senior Consultant Intensivist and Head Intensive Care Unit, Shantived Institute of Medical Sciences, Agra. I would like to request the chairpersons to kindly introduce the winners for the oral paper presentation.
Dr. Chaco, sir, can you please introduce?
Hello, hi. Good morning, everyone. So can I please ask Dr. Srinivas Reddy to present his paper at this point, please?
Hi, good morning, everyone. Today, I got a very good opportunity to present my research, a comparative study of high-flow nasal cannula oxygen therapy and non-invasive ventilation in acute respiratory failure patients, a prospective study. Patients with adult acute hypoxemic respiratory failure are encountered frequently in emergency and critical care medicine. Although invasive ventilation by endotracheal intubation is often used to manage ARF, its use is associated with many complications. Non-invasive ventilation have emerged as important non-invasive modalities to treat acute respiratory failure during the last 2 decades, whereas high-flow nasal cannula is a recent technique for the past 8 to 10 years. HFNC is primarily a flow generator. In contrast, NIV is primarily a pressure-targeted modality. To our knowledge, globally, there are very few studies done on the effect of HFNC oxygen therapy on intubation rate or mortality in patients admitted to the intensive care unit with AHRF, including COVID-19. Ours is a prospective single-center study involving patients admitted to the ICU with AHRF, comparing and determining the effects of high-flow oxygen therapy and non-invasive ventilation therapy on reducing the rate of endotracheal intubation and improving the outcomes. Our aim was to assess and compare the role of high-flow oxygen through nasal cannula with non-invasive positive pressure ventilation in prevention of intubation in acute hypoxemic respiratory failure. Our primary outcome was intubation and mechanical ventilation within 28 days. And our secondary outcome were all-cause mortality in the intensive care unit, the number of ventilator-free days at day 28, and the duration of ICU stay. Ours is a prospective study done in the Department of Critical Care Medicine, Fortis Hospital, BC Road, Bangalore. The total study sample was 86, who were assigned in a 1:1 ratio into either group NAV or group HFNC of 43 each. This study was done between January 2020 to June 2021. We included patients with 18 years of age or older with respiratory rate more than 25 breaths per minute, PF ratio less than 300 mm mercury of an oxygen flow rate of more than or equal to 10 liters per minute, PaCO2 less than 45 mm mercury, absence of clinical history of underlying chronic respiratory failure. We excluded patients with exacerbation of asthma or chronic respiratory failure, cardiogenic pulmonary edema, hemodynamic instability or use of vasopressors, GCS less than 12, contraindications to NIV. After obtaining approval and clearance from institutional scientific and ethics committees, patients with AHRF were recruited. Informed consent was taken from every patient or their next of kin. A brief personal history and medical history were recorded. Within 6 hours after the validation of inclusion criteria, patients were assigned in a 1:1 ratio to one of the two following strategies, HFNC or NIV by one of the three senior intensivists. Before the use of HFNC or NIV, the demographics, vital signs, laboratory tests, and the ABGs were collected. The baseline PF ratios was measured. Data were collected on admission at 6th hour and 24th hour and daily during hospitalization. SOFA score was calculated. Patients were followed up for 28 days. This is my statistical analysis done through statistician. And in results, there was significant difference in mean age, which was high in NIV group, and no statistical significant differences in gender, BMI, and SOFA score. Patients in NIV group showed higher incidence of diabetes. The main cause of ARF is COVID-19 pneumonia in both the groups. There were no differences in disease severity, other comorbidities, and bilateral pulmonary infiltrates between the two groups. All laboratory tests were not significantly different between the two groups. There were no differences in baseline vital signs and ABG values between HFNC and NIV groups, except the mean arterial pressure. At 6th hour, PF ratio was better in HFNC group. Mean arterial pressure was high in NIV group, while the respiratory rate and heart rate were better in HFNC group compared to NIV, even though they are not statistically significant. 93% of patients had PF ratios less than or equal to 200 mm of mercury at the time of enrollment. And in our primary outcome, the intubation rate at the day 28 was 28%, that is 12 patients in each group, which was not significant. The intervals between enrollment and intubation, as well as the reasons for intubation, did not differ significantly among the two groups. The number of ventilator-free days at day 28 was not significantly different between the both groups in overall patients and in patients with PF ratio less than or equal to 150. The crude in ICU and 28-day mortality didn't differ significantly among the two groups. The reason for cause of death also didn't differ significantly between the two groups, and most common cause of death in both groups was respiratory failure. The only significant value in our study got is the mean number of days, ICU days in HFNC group was significantly low compared to NIV group. At 6 hours after enrollment, the intensity of respiratory discomfort in the HFNC group patients was reduced and the visual analog score for dyspnea was improved as compared to the NIV. There were no significant difference among the groups in the overall incidence of serious adverse events. This flowchart shows both HFNC and NIV groups having 43 patients in each group. And in HFNC group, 16 patients were used NIV as a rescue therapy. And in NIV group, 6 patients were used HFNC as a rescue therapy due to NIV intolerance. In our study, neither NIV nor HFNC oxygen therapy decreased the rate of intubation or mortality among patients with acute hypoxemic respiratory failure. When planning the study, we assumed that the mortality rate will be lower in HFNC group on the basis of the data from previous randomized controlled landmark trial Floralis study. But our results showed no mortality benefit with HFNC. The intubation rate in NIV group in our study was however lower, that is 28%, with the rates of 46 to 54% observed in other studies that included patients with AHRF. In few observation studies, lower rates of intubation were seen among patients with hypoxemia who were receiving high flow oxygen therapy than among those receiving NIV. Our results showed no difference in the rate of intubation between HFNC and NIV groups. In our study, the number of ICU days in HFNC group was significantly low compared to NIV group, but more number of studies needed to support this. In our study, after 6 hours of enrollment, the intensity of respiratory discomfort in the HFNC group patients was reduced and VAS score for dyspnea was improved with the use of high flow oxygen as compared with the NIV, which is similar in Floralis trial. Our study have few limitations. Like this was a single center study. The use of the HFNC and NIV was mainly decided based on the expert suggestions and physicians' experience. We enrolled only 86 patients in our study. The small sample size may skew the results. Further studies with larger sample size are required to confirm our results. The cause of acute hypoxemic respiratory failure was mainly COVID-19 pneumonia in our study. Our strengths were we included a well-defined study protocol that included pre-specified criteria for intubation, complete follow-up at 28 days, and intention to treat analysis. Our trial had several strengths to suggest that results may be generalized to patients admitted for non-hypercapnic acute hypoxemic respiratory failure in other ICUs. To conclude, intubation rate, which is primary outcome, and mortality and ventilatory-free days at day 28, which were secondary outcomes, did not differ between patients who used HFNC and NIV as a first-line therapy treatment. The number of ICU days in HFNC group was significantly low, and the patient comfort was better compared to NIV group. At the end, I would like to express my special thanks of gratitude to my head and director of the department, Dr. Padma Kumar, as well as our senior consultants, Dr. Chandan, Dr. Pooja, who gave me golden opportunity to do this wonderful project on this topic. I would like to extend my special thanks to my colleagues and nursing team who supported me. Thank you for giving this golden opportunity.
Thanks, Dr. Srinivas, for that. A very good paper comparing NIV versus high-flow nasal cannula in hypoxic patients in acute hypoxemic respiratory failure due to COVID-19. So as far as I can see, as you rightly mentioned, the sample size was small, just 86 patients. And as I understand, you didn't calculate a sample size beforehand. That is, of course, one of the limitations of this study. And it would have been good to have a control group to compare between NIV, high flow, and a control group to compare these two modalities. So that's my views. I would ask my co-panelists to also express their own opinion on this paper, please.
May I request Chairperson to introduce the next speaker?
Dr. Taikonda Chandramouli, would you please present your paper that has been selected for this presentation? Thank you.
Hello everybody, I'm Dr. Chandramouli, DM Resident, Critical Care Medicine, IMSM Sam Hospital, Bhubaneswar. Tocilizumab in ARDS due to COVID-19 pneumonia. COVID-19 is associated with dysregulated immune response and the elevated interleukin-6 levels seen in the cytokine storm and associated with poor outcomes. Tocilizumab is monoclonal antibody with interleukin-6 receptor antagonistic activity. So we hypothesize that tocilizumab will decrease the cytokine storm and ensure the recovery of the patient and thereby reduces the mortality. The objectives of our study is to assess the risk factors affecting in-hospital mortality in patients who received tocilizumab 400 mg and effect of tocilizumab on the oxygen requirement. So we collected data in the hospital records from May 2021 to August 2021, a retrospective observation study with a convenient sample of 78 patients. The parameters what we have assessed were SAPS-2 score and duration of steroid received before the tocilizumab, FiO2 requirement, and the mode of oxygen delivery is being measured by means of NRBM mask, high flow oxygen cannula, and non-invasive ventilation, and also invasive mechanical ventilation. All the categorical data was measured by means of percentages, and the quantitative data was measured by means of median plus IQR. And the significance was being measured by means of non-parametric tests like Mann-Whitney test and also chi-square test. So broadly, we have a sample of 78 patients. Among them, everybody received tocilizumab. We broadly divided them into survivors and non-survivors. And both the group, that is survivors and non-survivors, are age and gender matched. By hospital protocol, we have given tocilizumab for the patients who are having high CRP, that is more than 75, and negative serum procalcitonin. So both are gender matched, and dexamethasone and methylprednisone has occupied the lion's share of the steroids, that is 52 and 48% respectively, and hydrocortisone, only one patient received hydrocortisone, that is 0.012%, which is not significant. The baseline characters like SBP, heart rate, respiratory rate, SpO2, hemoglobin, and total leukocyte counts and total platelet count were not significant between the survivors and non-survivors. But the SAPS-2 score with a total median of 43 is significantly low among the survivors, that is 38, than compared to non-survivors, which was 46. But the oxygen requirement at day 7, 14, and 28 was significantly low among the survivors compared to the non-survivors. So we have measured ARDS pattern by means of modified Kikai ratio, that is SpO2 by FiO2, which is 131 among the survivors and 115 among the non-survivors, but it's not statistically significant. If you see this bar diagram, so among the survivors at day 28, there are more patients who are on room air compared to the non-survivors. So to conclude, SAPS-2 scores were significantly high among the non-survivors, and the oxygen requirement significantly reduced after receiving tocilizumab in patients who survived. Thank you. Open for the questions.
Thanks, Dr. Taikonda Chandramouli, for that paper. You studied tocilizumab among patients with COVID-related acute respiratory failure. Well done. It is, of course, a retrospective observational study and carries with it all the limitations of a retrospective study. Of course, there is a lack of the proper control group as well, which may also have resulted in bias. So if there is any questions, would you please ask?
And Dr. Navdeep, can you start your presentation, please?
Good morning, respected faculties and dear participants of this conference. I am Dr. Navdeep Sokhal, additional professor in the Department of Neuroanesthesiology and Critical Care in AIIMS New Delhi. And at this outset, I would like to thank the organizers for giving me this opportunity. We are going to discuss a comparative study of efficacy and safety of indigenous goggles with fan versus standard or normal goggles in healthcare workers in COVID ICU. As we all know that CDC recommended PPE, N95 mask, and eye protection in the form of goggles or eye shield is necessary tool for healthcare workers managing COVID-19 patients. But we all know that fogging of goggles and spectacles is not only very disabling, but it hampers effective patient care. So we came up with an idea of indigenous goggles with fan, where the goggles were fitted with battery-powered small fan, and we thought that it could take care of the problem of fogging because it won't allow the axial dial to rest and condense on the inner surface of the goggles. So we planned this pilot randomized clinical trial, CTRI 029805, where 30 healthcare workers were enrolled, and we divided them into two groups. Group A, where healthcare workers wore standard goggles, and in Group B, they wore goggles with fan. And the other advantage we gave to Group A participants were that they were allowed to apply anti-fogging agents of their choice like soap solution, sterilium, or anti-fogging marker on their goggles before wearing it. While in group B, the no anti-fogging agents were applied, but we simply started the fan after donning the goggles. So by this time you have known that objective were to compare the efficacy and safety of goggles with fan versus standard or normal goggles, and efficacy was tested in the terms of visibility for far field and near field vision. Far field means reading vital parameters on the stationed patient monitors, and near field means reading or writing patient notes, and vision was further categorized and unacceptable when there was thick fogging or healthcare workers were not able to read properly or there was reading with difficulty. It was called unacceptable vision, and we termed it acceptable when there was either minimum fogging or there was no fogging at all and there was absolutely clear vision. And safety was measured in the terms of symptomatic or RT-PCR positive COVID infection till 15 days of participation into the study. And you will be delighted to know that results were very encouraging for the study. There was no demographic differences between the groups. None of healthcare workers, any group developed symptomatic COVID infection. Seeing the graphs, you know that in group B, none of the healthcare worker had poor or unacceptable vision. All the healthcare workers in group B were able to have acceptable vision, while at the same time, the poor vision was noted for 47% of healthcare worker for far field vision and 40% healthcare worker in near field vision. And other thing is that more than 92% of healthcare workers in group B were able to have full shift, that is 5 to 6 hours clear vision. So I would like to conclude that goggles with fan had highly significant better visibility and less fogging for longer duration and were found equally safe when compared to standard goggles in healthcare workers in COVID ICU. These are a few references for this original article. Thank you.
Thanks a lot, Dr. Navdeep, for that innovative device, fans, which are meant to reduce the fogging in goggles. I hope that perhaps we can use the device extensively among healthcare workers who take care of COVID patients in the future. Thanks a lot.
Thank you, sir.
Thanks, Dr. Jose Chaco, sir, for reviewing our abstract. Dr. Jose Chaco and Dr. Sumitre have been the chief of our abstract review committee, and organizing committee is very grateful to you. Out of the 104 abstracts received, best 3 papers have been chosen. These will be awarded the Hansraj Nayyar Award. And I'm happy to announce Dr. Srinivas Reddy is the first winner, and he will receive an amount of rupees 51,000. Round of applause for Dr. Srinivas. Dr. Chandramouli is the second winner, and he will receive a gift of rupees 21,000. And Dr. Navdeep Sokhal is the third winner, and he will receive rupees 11,000. Congratulations to all the winners, and thanks all.
Thank you. Thank you.
Thank you.
Good afternoon, ladies and gentlemen. Good afternoon, ladies and gentlemen. It is with great pleasure that I welcome you all for the afternoon session of the World Conference on COVID and Critical Care 2021. I hope you all have had a seamless experience so far and that we're able to provide the same for you as we go on forward. Without further ado, I would like to proceed with our next session, which is the brainstorming roundtable session on oxygen therapy. Our moderator for this session is Dr. Rajesh Mishra, Honorary Consultant and Intensivist and Internist, Ahmedabad, Epic Hospital, Kidney Health Hospital, Naranpura, and Sanjeevani Super Speciality Hospital. Sir, I would like you to please introduce the rest of the panel and proceed with the discussion. Thank you.
So, good afternoon, everyone. Today's panel discussion, we have planned on oxygen therapy in COVID patient, and we have a esteemed panel to join us. We have Dr. Rose Brisbane from New Zealand. We have Dr. Mikkel O'Leary from Sydney, Australia. We have Jason Puha from Singapore. We have Dr. Rahul Pandit from Kurtis, Mumbai, and we have Dr. Sunggun Park from Korea. So in next 40-45 minutes, we are going to discuss how the oxygen therapy was tailored and how it was, how oxygen resources were managed during the crisis of COVID. Can we start discussion, please?
Ross, can you introduce yourself?
Yeah, sure. I'm Ross Freeburn. I'm an intensive care specialist in Hawke's Bay in New Zealand, and I'm also involved in the basic collaboration teaching on that. Thanks.
Rahul?
I'm Dr. Rahul Pandit. I am the Director of Critical Care for Fortis Hospitals, Mumbai. And I'm also on the task force for the Supreme Court National Task Force and the Maharashtra Government Task Force for COVID-19.
Michael?
So I'm Michael O'Leary. I'm a senior specialist in intensive care at the Royal Prince Alfred Hospital in Sydney, which is one of the two ECMO retrieval centres for New South Wales.
Great. Sungan?
Hi, I'm Sunggun Park, working for Hallym University around Seoul metropolitan city in South Korea. Nice to meet you. Yeah.
Great to see you. Jason?
Yeah, I'm Jason. I'm a respiratory physician and an intensivist in Singapore, and I work in Alexandra Hospital. I co-chair the ICU National Committee in Singapore. Thanks.
Thank you. So just let me give you a little bit background about what we are going to discuss. We have been especially asked about to talk on oxygen therapy in COVID patient. As you all know that when COVID had hit us, the oxygen became one of the issue. We were short of oxygen therapy, and we have to do inventory triaging in giving oxygen therapy. We have to decide that which patient can be treated at home, which patient can be brought to the hospital. Apart from that, there are certain criteria because these patients tolerated hypoxia at even 85% and they were asymptomatic. So they were concerned that what level we should be giving oxygen. Then the issue came that how the oxygen has to be delivered. It should be high flow or it should be low. Gadgets like high flow nasal cannula picked up very fast for oxygen therapy because the primary problem were hypoxemia in these patients. So with this background, I want to start from Rahul. Rahul, can you just narrate us a little bit about how did you plan oxygen therapy in your patient, particularly when you were short of oxygen in our country?
Thank you, and good morning and good evening to all of you from whichever part of the world you are in. I think, Rajesh, that's a very pertinent question for India because April, May, and June, we had a very, very tough time as a country whole because our numbers really escalated. The first wave saw around 100,000 cases. The second wave, this is daily cases I'm talking about in the country. And the second wave, we were almost just short of 400,000 cases per day. And obviously, even if you say that only 10% of them needed hospitalization and say less than that needed oxygen and even fewer than that needed intensive care, we still had numbers in thousands to actually look for in every day. And as a country, we probably had two big problems. One was hospital beds and the second was oxygen. So there were some states like where I am in Maharashtra, we had a better planning. Some of the states had a not so solid plan in place. And the reason for that is Maharashtra, by the virtue of being an industrialized state for a long time, has got at least 6 or 7 oxygen producing plants in the state, whereas Delhi, for example, has got no oxygen producing plants. And if you look at the way the oxygen is transported from one city to the other city, the oxygen carrying tankers cannot go beyond 40 kilometers per hour speed limit. And it was taking a long time for the oxygen to be delivered from one point to the other point. That added to the shortage of oxygen. So it was very important to plan the triaging of the oxygen and the rationing of the oxygen at your own place so that we could save it. One of the first things we did was we already had oxygen committee in the place, Rajesh. We started looking at first wastage of oxygen. So team of nurses and few doctors from the admin department would actually go from ward to ward, floor to floor, make sure that all the knobs were tight and not leaking. There were no pipes which were sort of unnecessarily wasting oxygen. There were not patients who were supposed to be off oxygen but still had the flow meters on. You know, we see these kind of things very often happening. So that was one of the first things we did. So we stopped the wastage of oxygen. The next stage was to actually try and understand how much oxygen needs to be delivered. So patients who were in a monitored environment like HDU or intensive care, whether it was COVID or non-COVID, and we had very few non-COVID patients at that time, we were able to have a saturation as low as 87% to be tolerated, 87, 88% to be tolerated. That was the range, 87 to 90%. And in a non-monitored environment like wards, we kept the saturation between 92 to 94%. We actively used awake proning. I'm sure we are going to come to that. And one of the ways by doing this, we brought down the oxygen utilization per day by almost 20% in our hospital. So we were keeping a daily tab of what kind of oxygen we were using in terms of metric tons. And we were able to bring it down by around 17 to 20% on most days, just by being a little bit more vigilant about it and being a little bit more careful about it.
Okay. Michael, did you face the oxygen crisis in your country?
Well, not at all, because certainly in the.
So were you prepared, or did you plan it like that you will be having? Yeah, you were not enough. You had enough resources for it.
No, I think we were just really lucky. So Australia, I think, and New Zealand, I'm sure you'll hear from Ross, had the privilege, I think, in this pandemic of being islands that really you can only get to by air. So it was very easy, I think, at the start to limit access to the country. And I believe that's how we managed to defeat the first wave. But there wasn't an awful lot of community transmission in the first wave of COVID in Australia. And most of the cases that we got in Sydney, for example, which was the busiest city in the first wave, were mainly from overseas arrivals. And they didn't transmit it very much within the community. So the hospitals were not overwhelmed. In our hospital in the first wave, we only looked after 7 ventilated patients. And we, as I said, are one of the biggest and busiest hospitals. Now, in this, in Australia, there were sort of 3 waves, but the second wave was isolated purely within Melbourne in the middle of last year. And then the third wave is the one that we're in at the moment that's beginning to wane now in Sydney. We were much, much busier. But still nowhere near as busy as Rahul has explained in India. And of course, I mean, India is an incredibly populated country and many cities with very high population density. But even if we forget India and we think about countries in Europe, in the United Kingdom, there were significant problems with oxygen shortage in certain hospitals. But we just didn't see the caseload to put us under that strain, not even in this wave. At worst, our worst day in Sydney, when everyone was panicking in this current wave, we only had 1,700 cases in the whole city of 5 million people. So I think we've had a different experience, to be honest.
You were lucky. You were really lucky.
We were lucky.
Ross, coming to you. So what was your threshold to start oxygen therapy? And how did you plan it in patient? Ross, you are muted.
So I'm a complete fraud, like Michael. I've seen 3 COVID patients in the last 19 months. We have had 1 in ICU who required oxygen therapy for a short period of time. We've not ventilated one. So my experience with this is limited to the academic reading of the journals, which are wide and varied, and trying to understand the physiology of what's going on. We're now a little bit better prepared, perhaps, than we were a year and a half ago, but not as well prepared as we should be, and we have COVID on our doorstep. But you asked me about the threshold for oxygen therapy. I've looked at this quite closely. There is no indication really to give supplemental oxygen except in the cases of impending or actual hypoxemia. And I think that's one of the things we need to get across clearly to people, that oxygen does not make you better. It simply stops you being hypoxic. And stopping you being hypoxic is when your saturations are probably less than 90 or even below that, that's when oxygen should be used. Now, because of safety, we tend to think of 92, something like that. But I don't think there's an indication to push oxygen levels up to above 95% at any time. And probably if there's a limited supply, a limited ability to do it, and also there's a cost, I think we should be very cautious about starting oxygen on people that don't need it, and also of using higher rates of flow that are needed. That's not to say that we shouldn't use high flows of gas to try and give some sort of flow effect, some PEEP effect, and some flushing effect when you're using high flow cannula. But as far as oxygen is concerned, we should be targeting a low saturation. As I said, it doesn't make you better, and it's hard to get across to people that although this therapy is useful, it isn't a therapy that makes people better. It simply prevents them being hypoxic. So that's where we're at.
Okay. Sungan, what was your threshold for oxygen therapy? Did you start oxygen at home? Did you start oxygen in hospital? Or did you monitor? How did you plan your oxygen therapy to the patient, in COVID patient?
In Korea, usually COVID-19 patients are who are receiving oxygen therapy are usually in hospital, not home. So we have maybe more than 60 regional centers designated by government for COVID-19 patients. And there, usually patients are receiving oxygen therapy. Actually, in Korea, we kind of give a liberal strategy rather than conservative or restrictive strategy, because we are more concerning about hypoxia rather than hyperoxia. And luckily, as in Australia, we cannot see a shortage of oxygen supply. So many doctors start oxygen therapy earlier.
So what was your threshold to start oxygen? At what level of oxygen? What was your threshold to start oxygen? Threshold.
Wow. Yeah. By governments and Infectious Disease Society, we usually, our threshold is 93% SpO2.
Jason, any different experience for COVID for starting oxygen therapy?
Yeah, we use oxygen to keep the saturation somewhere between 90 to 96%. So if it falls below 90%, we would start. I would say that in Singapore, we are in the middle of our largest wave to date, primarily because we decided to open up relax the rules of all the safe distancing measures, etc., etc. And we are seeing the wave despite the fact that 82% of our population has been fully vaccinated, 86% of our population has been partly vaccinated. And it's just the effect of Delta. And so we are increasingly seeing more patients who require oxygen. And our threshold for high flow nasal cannula is when, despite, for example, patients requiring venturi mask 40 to 50%, they're still on the hypoxemic side. So we try not to go to the non-rebreather mask, and we would start high flow nasal cannula. Well, the reason why I'm bringing this up is because this actually is starting to show that it can drain the oxygen resources in the hospitals. And something that I found out myself only recently is that while our hospitals have more than enough oxygen supply, something that we need to look out for is the flow supply. I.e., you may have all the oxygen in the hospital, but if you use a lot of high flow nasal cannula, for example, you're using like between 40 to 60 liters per minute per patient, the rate limiting step is not the quantity of oxygen in the hospitals, but the pipes and the regulator that determine the flow, number one, across the whole hospital, and number two, to the specific wards. And so in Singapore, what we are doing is that the clinicians, the respiratory therapists, and the facility management guys are reviewing the specific flow rates, the regulators in the hospitals, to make sure that this will not limit us in the future should the surge of cases increase. Right now, we are cool, but it's something to think about. Thanks.
Great. So Rahul, very quickly coming to, so you have decided to give oxygen therapy. In India, you know that they had faced a problem where we really had to start not only oxygen, but in some of the patients, due to short of the bed, we have to give remdesivir and dextrona also at home to some of the patients. In a lot of patients needed in peak of the second wave, we have to give remdesivir and dexamethasone as well as at home. So what was your threshold to start oxygen therapy in your patient? And did you find that oxygen therapy at home is working better than hospital therapy?
So Rajesh, I'll be very honest with you. I probably have not treated even one patient with oxygen at home to begin with, because we never had a problem with the beds in Maharashtra. Specifically in Mumbai, we had in fact, even on the worst day, then Mumbai was the city with the highest numbers for a long time. Even on the worst day, we still had a few ICU beds and few ward beds remaining. And that was because we built up a lot of field hospitals. So home experience is not there with me. But hospital, I agree that, as I said, that we would target our oxygen therapy in an environment which would be monitored 88%. And if once we achieved 88%, we would stop increasing the oxygen. And if they were 88% with awake proning, we would just keep it without oxygen in the monitored environment. In a non-monitored environment, it would be 92 to 94%. And that's what we did. I think people did take some dexamethasone by the general practitioner before they landed up in the hospital, but it was not something which was our policy.
That was wrong. So very quickly coming before oxygen, Michael, can you just, if you enumerate, how did you monitor? Because what we faced in India, there was a problem in monitoring of accuracy of oxygen, because different kind of pulse oximetry came, and due to the skin color, and sometimes there was a problem in monitoring the accuracy. When patient used to report at home that our saturation is dropping 80%, and when the same patient come to the hospital, the saturation was 95%. So a little bit about accuracy of monitoring oxygen when somebody is monitored, because we also know that telephone triaging and telephonic consulting became rampant during COVID because of the resources limitation. But at least in India, this became rampant. So did you face any problem in accuracy of oxygen monitoring in your country?
Well, it's a slightly difficult question to answer, but the thing that comes to mind when you ask that question to me is one of the problems that we saw with COVID patients, which was that there was a lot of seesawing of saturations through the day in an individual patient. So these saturations seem to be very, very common. Frequently, they wouldn't be particularly associated with any obvious external clinical change in the patient. They may come on after an exertion, the patient gets up for some reason out of bed, or they go to the bathroom or something like that, and then there would be quite a profound desaturation. And this early on in this second wave, in Sydney, this caused a lot of difficulty for us in the intensive care unit because we would frequently get emergency calls to the emergency department or to the ward because a patient had desaturated, and then they would be brought to the intensive care unit, and within an hour they were completely normal and off oxygen, and you'd say, what was all that about? So it took a while to educate the wards that periodic desaturations were not necessarily an emergency. That if the patient was still looked reasonably well, and they were being observed, they could be observed on the ward. And in Sydney, we had this system, the special health accommodation, which basically were hotels, which were taken over to be used essentially as a sort of a step down between hospital and the home. And patients would be in these hotels, and they would have twice or three times daily visits by nurses, and they would also be able to call in on a internet video link, if they felt unwell or if they had a problem. And again, in that scenario, although oxygen wasn't delivered in those places, if patients were found to be desaturated, they would frequently be put in an ambulance and brought into the emergency department. And by the time they got to the emergency department, their saturations would be normal. And this caused a lot of difficulty for everybody because of moving these COVID positive patients around. So I think that the lesson has been that a snapshot saturation monitor doesn't necessarily tell you very much.
It's very important. Very important. It's very important to pinpoint. Jason, do you have same experience with the oxygen? Because the oxygen monitoring accuracy and the mismatch with the patient symptom and the SpO2 was very common during COVID. So do you have that kind of experience about it?
Oh, for sure. For sure. Yeah. So increasingly we intubate or we intervene, not based by the oxygen and the FiO2 requirements, but based on the clinical status, whether they are tachypnic or not. Just want to touch on this thing about monitors. So in Singapore, we nurse patients with COVID who are quite well, but they don't need hospitalization, increasingly in what we call a community isolation or community care facility. And so we bring the pulse oximeters there, and we use telemedicine to look at the, I wouldn't even say patients, the resident's pulse oximeter. And there's a threshold under which there will be triggers. And sure, there will definitely be false positives and there will be triggers as well. In fact, the government has even started giving pulse oximeters to the lay public so that when they are recovering from COVID in the home, they're actually checking their oxygen saturations as well. And the threshold for alarm is anything less than 94%. So we're still watching, right? Because any given day, there will be many people who are just generally slightly hypoxemic, walking around with a sense of 92, 93%, and what's this going to do to the false positive triggers, etc., etc. So it's very, very interesting to look at.
So Ross, question to you. How do you plan oxygen therapy? Like going from low flow to high flow? What is your threshold? What is your protocol to start oxygen therapy in COVID patient? Ross, you are muted. Ross, you are muted.
Good thing, yeah. We use a lot of high flow therapy for generally, not for COVID, but not because we haven't had COVID. But we use low flow cannula or masks up to about 4 liters to maintain saturations. There are two indications for increasing to nasal high flow cannula that really we see is one is of the oxygenation, and then we would tend to increase both the oxygen contents in the flows, but also work of breathing. Some patients present with high dead space abnormalities, and I believe in COVID that's often a problem. It's a dead space problem rather than necessarily shunt. They have to move a lot of gas to maintain normal gas exchange. And by using high flows, you can flush out their upper airway and reduce the tidal volume they require to maintain reasonable CO2 exchange. And so sometimes that's a thing that's often lost is that you can use the flows rather than increasing oxygen. You can increase the air flow if you have air on your system rather than increasing the oxygen flow. and that's often beneficial to patients. Our transition is usually, well, because we have such good access to oxygen and gas flows, that I usually turn around when the patient's a little bit hypoxic and say, put them on high flow. Oh, they already are. The nurses have already placed them on a high flow device. And we use those flows up to 60 litres, sometimes 70 litres. The humidifiers struggle above 60 litres. It's okay at 70, but you go above that, the gas is becoming dry, so it doesn't condition it well. And our indications, as I said, are both pulse oximetry, but also just work of breathing. And if it's a work of breathing problem, increasing the flows sometimes help. And sometimes we use non-invasive, but not as much as we used to. So, that's for general patients. And we've got our plan, not that we know much, but our plan is to do that for COVID patients as well. We've looked very closely at the risk of aerosol generating procedures, and the latest data suggests that coughing, talking, yelling, spluttering has far more effect on the spread of aerosol devices than anything we do with anything to do with a nebulizer, a high flow device, or non-invasive ventilator. Have a minimal effect on the spread of aerosols, in addition to what patients do normally. So that's our strategy. It's to be tested yet. We think we're going to get some COVID in 2 weeks' time. We've got our predictions are that we're about to be hit very hard, but we'll have to see.
So I'll ask the same question to Sungun. Sungun, what is your strategy of giving oxygen in Korea? How do you plan your oxygen therapy in COVID patient? You're muted. Sungun, you have to unmute yourself.
I'm sorry. There was an announcement. Yeah. Usually, as I told you, if a patient's SpO2 decrease below 93, we start nasal flow. You start supplement of oxygen by nasal flow, low flow system. And if the oxygen requirement is higher, increase, we usually increase if we usually change nasal flow to facial mask for oxygen supplement. And if the patient's requirement is over 6 liters per minute, we usually change it by high flow nasal cannula, with which we start high flow nasal cannula with 30% and 30% FiO2 and 30 liters per minute. Yeah. And then usually I think COVID patients is rapidly deteriorating. So if his progression is very rapid, we think that the patient is gonna get intubated 1 day after. Yeah. So.
Okay, Rahul, how do you monitor the oxygen therapy?
So obviously, oxygen therapy is the bedside monitoring is through using a pulse oximeter. But in the intensive care unit or high dependency unit, like patients who are deteriorating very rapidly, whose oxygen requirement is increasing, high flow nasal cannula FiO2 is increasing, ABG is mandatory. I think you need to look at the arterial blood gas. You cannot just be relying on the saturation, because
just one question here short. Do you find a mismatch of the SpO2 and ABG SpO2? That's what I was coming to.
Yeah. That's what I was coming to. That very often we were not able to have a good correlation between the saturation on the screen and the oxygenation which was seen on the ABG. And quite often I would see both scenarios. So some of the patients would consistently have a poor arterial blood gas despite having a reasonable saturation on the screen, and vice versa. And this conundrum I have not been able to completely solve and understand why it happens in a particular patient and why it doesn't happen in a particular patient. So there are 80% who would sort of behave in a reasonably normal fashion, where they would have a good correlation, but there is this subset of patients who just don't have any correlation. So that's where the ABG becomes very important to go through.
So you monitor oxygen and ABG, this. What about any other clinical monitoring, particularly when somebody is on higher support, like you are going to a high flow nasal cannula, and because once somebody is on high flow nasal cannula, then what you have to monitor, but we need to monitor that how when this patient is either improving or needs intubation. So how do you have anything to monitor?
Work of breathing obviously is a very important assessment, leaving aside the oxygenation. So they become two important parts of monitoring. You may have a reasonable oxygenation, but if the work of breathing is very, very high, if your respiratory excursions are so rapid and so big that the patient is actually going to still tire out. And I'm not even talking about PCL as a concept. I'm just talking about patient just getting fatigued. Then you need to intervene early, not just leave them because oxygen looks good. So I think there are two important aspects of assessing these patients. One is oxygenation, the other is the work of breathing. And work of breathing, you could correlate with right from the nasal flaring to the accessory muscles to just respiratory excursions and rapid respiratory rate. And obviously, patients who are obtunded or who are drowsy or becoming drowsier than what they were before, it goes without saying that you need to protect their airway.
Michael, any experience with ROX score, ROX index during high flow nasal cannula?
ROX index, no, it's not something I'm familiar with, I'm afraid.
Michael, Jason, did you use that ROX index for high flow nasal cannula monitoring? Anybody or maybe someone?
I use it all the time.
You are using ROX index?
Yeah. It gives me the reassurance.
A little bit about it.
So ROX index is SpO2 divided by FiO2, and the whole thing divided by respiratory rate. So if you have a person with a very poor SF ratio and a very high respiratory rate, that will give you a very low ROX score, and that's bad. On the other hand, if the SF ratio is good and the respiratory rate is low, that gives you a very high ROX score. That's good. And so we extrapolate it from the original study, the ROCA study, right? And I know that intermittent studies have come out for COVID-19 since then. And clinically, at least anecdotally, despite the fact that I've looked at some of the meta-analysis and review articles on this, then predictive value is not that great. At least anecdotally, when I use it, when my friends use it, it gives me the confidence not to intubate. So for example, you have a person whose SF ratio is really quite bad because the FiO2 on the high flow nasal cannula may be 70%. And the SATs are maybe like 90. But he looks comfortable, like what Dr. Rahul said, right? He's not got tachypnea, his respiratory rate is 20. And that actually still gives you a very decent ROX score because the respiratory rate is low. And based on the thresholds, I would not intubate. And we've gotten away without intubation quite a number of times. So it's not an absolute index. It's something that we use to give us an idea. And the other thing is the trend. It's not the absolute numbers of the ROX score. It's the trend. If the ROX score is starting to go down, meaning that the respiratory rate is going up or the saturations are going down, then you know that you are headed for trouble. But if it's in the other direction, so it's both absolute score as well as trend, and we use it, yes. Thanks.
Particularly during high flow nasal cannula, this has given a little bit of the confidence that how quickly we need to intubate the patient, not to continue the high flow nasal cannula.
Yeah, so both ways. To intubate or to not intubate. Yes.
Yes. But trend is very important. Sungun, yeah.
Do you see any difference in ROX index between COVID patients and non-COVID patients?
So I must be honest, I started using it a lot more with COVID, primarily because we have started using a lot more high flow since COVID. So I do not know.
Actually, the experience were very limited. Experience were very limited with high flow before COVID.
Before COVID,
probably we have to re-explore the use of ROX index in non-COVID patient as well. Because mechanism may be different in COVID and non-COVID. So we really don't know. So we cannot extrapolate the same data in non-COVID patients. That's what I believe. Rahul, you want to say something?
So we have started one study, 2 centers in Fortis to actually look at the ROX score and compare it in non-COVID and COVID patients. So let's see. It's just early days. I started my recruitment around 10-12 days ago. We've got 1 patient in non-COVID right now and 1 patient in COVID who have been recruited in our center. So let's see.
Michael, so the question is high flow versus NIV for oxygen therapy. Which one you will prefer?
Well, we have not been using a lot of NIV in COVID. There's been quite a marked change, I have to say, in our oxygen strategies between the 3 waves that we've had in Australia. So right at the beginning, I think as Ross alluded, there was a lot of concern about aerosol generation with high flow and with NIV, and there was a general feeling, certainly in my hospital, we didn't use them at all. I didn't agree with that, I must say. I was one of the people who spoke against that policy, but that was the policy that we came up with. And gradually that's changed. So we saw, I had it down here, we saw that less than 10% of patients received high flow in the first wave, and that went up to about 30% in the second wave and 70% in the third wave, whereas NIV also increased, but much less so. So again, only about 5% of ICU, this is ICU patients, sorry, not ward patients. So only 5% of ICU patients had NIV in the first wave, about 15% in the second wave, and 20% in the third wave. So there seems to be a tendency not to use non-invasive ventilation in Australia for whatever reason.
Okay. What was the trend, Dr. Ross? What was the trend for high flow versus NIV in your place? What is your protocol or what you follow? So high flow, you have to unmute yourself.
Yeah. So we tend to use high flow oxygen for hypoxemia selectively. We would not use non-invasive ventilation for hypoxic patients. The evidence that's around suggests that with non-invasive ventilation, a mask with bi-level, there's not an improvement in outcome using that compared to either early intubation or some other standard therapy. But we use high flow for hypoxic respiratory failure. Work of breathing problems, when patients are working hard with their breathing, COPD, congestive heart failure, or other causes of that, we would tend to use high flow up to 60 or 70 litres and then consider either intubation or use of non-invasive. Our use of non-invasive has gone way down from a few years ago when we were quite enthusiastic about it, since the use of high flow nasal cannula. It's the name is wrong. Non-invasive is not the correct name to call it, because it's the most invasive thing to have someone strap a mask tightly to your face and ask you to breathe through it. That's intrusive. It's very intrusive, not non-invasive. So I think we need a new name for it. Perhaps mask ventilation.
Michael wants to say something. Michael.
I want to ask Ross a question on the background of what he's just said. So what does he think about the UK recovery study, Danny Macaulay's study, that showed that the use of CPAP via face mask CPAP significantly reduced the requirement for intubation, in COVID-19 patients, whereas high flow nasal oxygen had no effect. What's your feeling on that?
I don't know why that is, but CPAP is, is not non-invasive. I think there's a difference between CPAP and non-invasive. I think there's a problem with ascribing a benefit of oxygenation characteristics to a non-invasive technique when CPAP, raising the mean airway pressure in the lung, is different. Dan Macaulay's study is good, but I just don't quite understand what the differences were between those groups and why they got a difference like that. It's an important difference, but I don't know why. I don't understand why one is better than the other. When other places you can explain the rationale between why one technique should be better than the other. I mean, with non-invasive in pre-intubation phases, every time you take the mask off, there's alveolar de-recruitment. And therefore, when you put the mask back on, you have to re-recruit those alveoli. In that time, there's damage done to the lungs. High flow tends to be better tolerated for patients, and therefore they're more compliant with its use and tend to sit with it on for longer. Therefore, you don't get that interrupted problems. Work of breathing issues, of course, are completely different, where you can take off the mask for 10 minutes, have your dinner and put it back on, as long as you don't get exhausted. It's a different, you're dealing with two different disease processes. Yeah, so I don't have an answer for you, Mike. Sorry.
Rajesh, can I say
Yeah, Jason, please.
Yeah.
Because very interesting thing, and we want to be clear about it.
Yeah, I'm very fascinated by the recovery study as well. And I just want to point out that despite the improvement in outcomes, if you look at the side effect profile, the complications, the CPAP arm in the recovery trial had actually more complications. This brings me back to an ancient study, right? I remember it was published in 2000 in JAMA, and Lauren Brochard was one of the senior authors, where they used CPAP in hypoxemic respiratory failure. And I distinctly remember that the incidence of complications, sudden cardiac events, was also higher in the CPAP arm. So I don't know, both of these studies look at hypoxemic respiratory failure. Both of them use CPAP. Both of them have a little bit more complications. The later one, the recovery, seems to have better improvement in outcomes. But I'm still watching it very closely. The other thing I wanted to say is for non-invasive ventilation, right? Sorry, as in not Ross's non-invasive ventilation, but the mask thing. The Hannibal trial. This came out of Italy. This was published in JAMA this year. And what it found was that when you randomize helmet NIV versus high-flow nasal cannula, although there were no differences in mortality, they found that the helmet NIV managed to prevent more intubations than the high flow arm, right? And this is not face mask NIV, this is helmet NIV. And so again, we need to watch this space, right? So, and yet there's a third one, which is non-COVID, which was last year's network meta-analysis by Bruno Ferrero, and this one looked at face mask NIV, helmet NIV, and high-flow nasal cannula in non-COVID hypoxemic respiratory failure. And when you look at the intubation outcomes, there was no real difference in all three. So all these three studies, the recovery study, the Hannibal study, and the network meta-analysis, all seem to say slightly different things. And because many of us are so much more comfortable with high-flow nasal cannula now, bearing in mind that non-invasive is not actually very non-invasive, that's why I think a lot of us are still using high-flow nasal cannula. But I think we just got to keep our eyes open and our ears open and to watch for further evidence. Thanks.
Okay. So, Sungun, a closing comment from you. What is your preference for the NIV versus high-flow nasal cannula? You have to unmute yourself. Sungan, you have to unmute yourself. Sorry.
As you know, the NIV for NIV patients feel uncomfortable. So the implementation of NIV requires much of manpower. So, but high-flow nasal cannula is tolerable to patients. So we much prefer high-flow nasal cannula than NIV. Although the previous study on COVID-19 patients, there are risk of viral transmission, aerosolization from high-flow nasal cannula, but despite the limit data, we can use high-flow nasal cannula with surgical mask on it. Yeah. So in Korea, many doctors use high-flow nasal cannula. Rare, the use of NIV for COVID-19 patients is very rare.
Okay. Dr. Michael, your closing comment, high-flow nasal cannula versus NIV.
Well, I'd agree with Sung-Hoon. Very similar in Australia. We as I think Ross had said, we had been increasing our use of high-flow nasal oxygen over the last 5 years or so in any case. So our experience with its use was pretty high prior. That's why I argued very strongly at the beginning that we should use it, but originally we decided that we wouldn't. I'm not a great fan of non-invasive at the best of times. So I feel that in my practice, if I had a patient, unless they were very unkeen to be intubated, and they had primarily an issue with CO2 retention that I thought might be improved with some BiPAP. I probably would not use non-invasive. I wouldn't use isolated CPAP in this situation. I would go straight from failure of high flow to intubation.
Exactly. Ross, your closing comment. You have to unmute yourself. Ross, you have to unmute yourself. Ross, you have to unmute yourself.
Much the same as Michael. There's no, our intention is to use high flow as much as we can. If we get cases, and we think we will get cases, which is the scary thing. You guys have been through it. We're still waiting for this to happen to us. And we've got a plan for high flow as much as possible. And non-invasive, I think, has lost out of favour just because of general practice. At the moment, we don't use it a lot. We wouldn't want to implement it. It's also far more nurse intensive than high flow nasal cannula. The nurse has to be far more involved, and that's putting a workload on our colleagues that we don't need. When high flow tends to be able to plug and play, you put them on, turn the flows up and down, but that's the mask doesn't come off all the time. So we think that our biggest limitation is going to be, as all of you have found, will be nursing numbers and able to look after these patients. So.
Great. Rahul?
I pretty much agree with what Michael.
Rahul, we just forgot to touch some special population. If you can just say 30 seconds about the pregnant patient and very elderly. Anything different from what we are doing? Something?
So pregnant patient, essentially try and keep oxygen saturation on the higher side than what you would. You don't want to give them too much of hypoxia. I would use the high flow nasal cannula pretty much early in them, not delay too much. Also, if they are going towards moderate or severe ARDS requiring ventilation, I would definitely push forward and get them delivered if they're closer to term. Or even if they are around 7 months pregnant, I would not hesitate to say if it saves mother's life, because proning becomes a big problem in them. And if we can actually go across and get them delivered, the FRC improves, their lungs start expanding much better than what they were before. So we've had, in fact, I've got one patient on ECMO still. We did a webinar with Rajesh a few weeks ago on obstetrics, and that time I had 2 patients. I've got one on ECMO still recovering, but that's what we've been doing. Elderly population, I think not all depends on how they were pre-morbidly. If they were reasonably healthy and if they are reasonably compliant, I would continue with the same strategy, but the oxygen levels would obviously, goalpost would change a little bit more, because again, their ability to tolerate hypoxia is a bit questionable, and confusion being something which is not very easy to understand whether it's because of hypoxia or just that they are basically sundowners and they're getting confused because they are old and they've got multiple metabolic things going on at the same time.
Okay, so gentlemen, thank you for your excellent deliberation on oxygen therapy. Just if I have to summarize very quickly, the first thing what we have to remember that oxygen, although not for everyone, for a country like us who has got such a huge population, in case of pandemic can become a scarcity, and we have to manage the oxygen properly, do a proper auditing, use our resources properly, maintain, as all of them agree that in normal population, in 92 saturation should be fine. Awake proning, though not very much established, but still it improves oxygenation, and not much of the trial. So not harm in trying, because it's a harmless procedure. So if you try awake proning and your patient can maintain, the difficulty is maintaining, because a lot of obese patients do not maintain awake proning. So if you can maintain awake proning, maintain a saturation of 92 plus, no need to give oxygen therapy. If at all you have to give oxygen therapy, you start with nasal cannula, which makes the patient more comfortable. When we shift from nasal cannula to mask or higher gadgets, patient comfort and his breathing need to be monitored properly. You should always keep in that in. But when patient exert, they can suddenly become hypoxemic. So there is a waxing and waning of oxygen. So always match your oxygen with ABG if you are in doubt. That will give you a clear picture about the patient condition. Oxygen therapy should be offered early. Do not make your patient hypoxemic. When you are putting gadgets, high flow nasal cannula is preferred if your oxygen is not being maintained with the NRBM or nasal cannula. But keep a close watch. ROX index does help in early intubation. Do not allow your patient to get exerted, becoming drowsy, or becoming too much of tachypnea, because that is still. The choice between high flow nasal cannula and IB is like most of us agree that to go for high flow nasal cannula or intubate, because if you shift from high flow nasal cannula to NIB, the NIB induced, we did not discuss this because that was a part, but NIB induced mechanical lung injury is a concern and it can sometimes cause problems. So better if your high flow is failing, go for early intubation and give the patient controlled ventilation rather than trying to put on high flow nasal cannula causing more injury. So this was in general summary. And one more thing, we have to always remember that during this oxygen therapy, a close monitoring of fluid status and nutrition and comfort to the patient is also equally important. With this, we just sign out. Thank you for all attention. Thank you, Michael. Thank you, Rahul. Sungun, thank you. Thank you, Jason, and thank you, Ross, for all your excellent deliberation. And I hope the audience will get a lot of benefit from this. Thank you, everyone.
Thank you.
Okay. Goodbye.
You. Thank you. Bye.
There is some question in the chat box.
Yeah. So do you want me to address that questions?
Yes, sir.
Where the chat box?
There are some questions from Dr. Jacob Joshi. As Dr. Joshi is online, can we have the question, Dr. Joshi?
The question is on HFNC plus NRBM. Honestly, theoretically speaking, yes, to buy out time and to give a chance that a patient gets better. But most of the time, if we have seen that we have reached to a target of around 60 liter of high flow, and if it's not working and patient is not deteriorating, rather than waiting and causing more harm, better to intubate. One can try under close monitoring because everything is trial and hit and trial in COVID patients. So one can try HFNC plus NRBM. We have also seen, but we have not seen any patient getting better or avoiding intubation. Most of these patients need intubation, and so better to intubate early. Any other questions?
Thank you, Dr. Mishra.
Thank you. Thank you. Thanks a lot.
Bye.
Bye.
Thanks, everyone. Nice. Enjoy it.
We can now move to the next session. Dr. Naman.
Good afternoon, everyone. I welcome you to the World Conference on the COVID and Critical Care. And now we begin with our debate session, for which the topic is steroid. How does it matter? Which one and how long? The chairperson for the session is Dr. Asif Ahmed, Senior Consultant and HOD Critical Care Medicine, Tata Main Hospital and Jamshedpur. Sir, I would request you to introduce us to our debaters.
Thank you, Dr. Naman, and good afternoon, ladies and gentlemen. Welcome to this World Conference on Critical Care, COVID and Critical Care. That's more to be precise on. And we have all known that whenever we have a debate, the point is that there is something related to a controversy. When the direction is not very clear, when the information is not very clear. So with this background, we are going to have this debate, which is talking about steroids. And the topic would be steroid is steroid. How does it matter? Which one and how long? And we'll be having two speakers. One will be speaking for the motion, whereas the others will be countering the first speaker. And for the pro session, we have Dr. Sameer Jog. Dr. Sameer Jog is a consultant intensivist. He's working with Dinanath Mangeshkar Hospital at Pune. And he's going to take us for the pro session for the steroid is steroid and how does it matter, which one, and how long.
Hello, I'm Dr. Sameer Jog from Mangeshkar Hospital in Pune. I'll be talking on a topic, in fact, it's a debate topic with my colleague and good friend, Dr. Rahul Pandit. Steroid is steroid. How does it matter? Which one and how long? I firmly believe that steroid has got some role in inhibiting infection, inhibiting inflammatory process, and I really do not think that individual steroid make any difference. Means the commonly used steroids are hydrocortisone, dexamethasone, and methylprednisolone or prednisolone. More or less all of them are same, especially if you want to mask inflammatory process. And we'll see, especially on the background of COVID, in pneumonia and ARDS, how steroids are useful or what we should practice in our day-to-day practice. I could find this paper almost 60 years back, the use of steroids as adjunct in infections. In pneumonia, it may be yes and maybe no, because still there is no verdict that we should use in pneumonia. In ARDS, before COVID, there is not very convincing data which we will see in a few minutes. But many people believe that COVID in non-COVID ARDS, steroids may be beneficial. And still it is a hotly debated topic in critical care fraternity, use of steroids in ARDS or in severe lung conditions. This is the famous diagram showing effects of steroid, especially in pneumonia and ARDS. We know that there are directly steroid-sensitive genomic material in our leukocytes or WBCs, which has got significant anti-inflammatory effect, and that's how steroids work. But exact pathways of how steroids work in individual diseases or individual immunological response is still not very clear. And this is an apt editorial I could find during my literature search. Steroids for sepsis and ARDS, this eternal dilemma remains even with COVID-19. Before COVID also, we were debating about usefulness of steroid in ARDS. And even during COVID and after COVID also, we are debating about use of steroid in pneumonia and ARDS. So these are the few studies which I will just quote and show quickly. All of them are published from 1980s till 2019 in the reputed journals like New England Journal of Medicine, JAMA, British Medical Journal, Critical Care Medicine, again New England Journal of Medicine. Out of which this study from Steinberg is famous HeartNet study, which is a negative study. But there are studies which are randomized control studies, which are well-designed studies, which have shown some benefit of methylprednisolone infusion in severe ARDS. For that matter, this study is a positive study. Then this is the Chinese study, which has shown some effect. And then this is study, an Egyptian study, which has shown effect of methylprednisolone in ARDS. So before COVID, it was hotly debated topic whether steroids are beneficial in ARDS or not, and how long should we use steroid, what is the appropriate dose of steroid, and which steroid should be used. But by and large, if we see, all three types of steroids, means hydrocortisone, dexamethasone, and methylprednisolone, all of them were used in pre-COVID era. Let's see this meta-analysis of all the RCTs we just quoted. And this meta-analysis had primary outcome was hospital mortality, and secondary outcomes were number of ventilator-free days and oxygenation improvement and adverse event. And the results are very impressive. About 9 studies with 1,371 participants were analyzed. The pooled analysis revealed that glucocorticoid use was associated with reduced mortality. Glucocorticoids might also significantly increase the number of ventilator-free days at day 28, and they might improve oxygenation. So this was statistical significance was seen in this meta-analysis. And the glucocorticoid used were methylprednisolone, hydrocortisone, and dexamethasone. So all types of steroid has got a similar effect in ARDS outcome, whether mortality reduction or ventilator-free days or length of ICU stay or oxygenation improvement. The outcome is little better before COVID. And this is how forest plot looks like. There is definitely favorable pointer towards use of glucocorticoids as against not use of glucocorticoids. About survival, as well as about ICU stay and about improvement in oxygenation. So the whole basis of recovery trial, which is widely quoted, or probably highest citation was received by recovery trial in the last 1.5 years in most of the journals, which showed reduction in mortality and reduction and improvement in oxygenation in patients who received dexamethasone. But even before dexamethasone was published in recovery trial, we were using methylprednisolone since March 2020. So recovery trial was published somewhere in July, but for 4 months we were using methylprednisolone with more or less similar results. But it's important to see what recovery trial showed us. It was a randomized control study in COVID-19 patients requiring oxygen support or mechanical ventilation, and the primary outcome was 28-day mortality. The investigators used 6 milligrams of dexamethasone every day. In India, we have got only 4 milligram vial available. So we commonly, which is equivalent to active drug particle of 6 milligrams. So we use commonly 4 milligram twice a day or 8 milligram once a day. The dexamethasone group had lower 28-day mortality as per the recovery study. And this is the famous table which you must have seen many times during COVID period. And the p-values were significant and dexamethasone was associated with improved outcome. There was another study called REMAP-CAP trial, which was a multi-platform study, multi-center control study. And the primary outcome was respiratory and cardiovascular organ support free days up to 21 days. And they received 137 patients with hydrocortisone, 146 had shock, and 101 control group. The trial was terminated in view of the probability of benefit with hydrocortisone did not meet the pre-specified statistical trigger for a prior conclusion of superiority. So this study was stopped in between. Then this was another study, the French study published in JAMA, but this also trial was stopped after the recovery trial was published before this. So which showed the outcome, which actually benefited, dexamethasone was shown to benefit. So the randomization was difficult in this trial because everybody was admitted in the hospital was asking for dexamethasone. So it was impossible to conduct the trial further as per the investigators. This is again a low-dose methylprednisolone study. The study population was before recovery study and published in October 2020, which showed primary endpoint of ICU admission, need for mechanical ventilation, and all-cause mortality. Patients had PF ratio below 250. Methylprednisolone 80 mg per day for at least 8 days was given. And this showed significantly less ICU admission, need for invasive mechanical ventilation, less in hospital, all-cause deaths. By 28-day, methylprednisolone group had significant reduction in mortality and increase in mechanical ventilation free days. So this study is a positive study for methylprednisolone. The recovery study was for dexamethasone. And this is again a study published in Clinical Infectious Disease, a single center study from New York, where methylprednisolone was used and the primary and secondary outcomes were similar. Again, had shown significant higher ventilator-free days in methylprednisolone group, significantly higher probability of extubation, and statistically no significant reduction in mortality. So we would say it is a partial effect of methylprednisolone, but no improvement in mortality was seen in this study. And this was the Chinese study from Wuhan itself. Use of corticosteroids, they use corticosteroid as per the physician discretion. You can see here methylprednisolone, dexamethasone, hydrocortisone, and prednisolone, all 4 were used in these studies. And the conclusion was low-dose corticosteroid treatment was associated with reduced risk of in-hospital death within 60 days in COVID-19 patients who developed ARDS. So all sorts of steroids are shown to be effective in COVID, whether it is dexamethasone or methylprednisolone or hydrocortisone or prednisolone. So probably short course of steroid which mask the significant inflammatory effect of COVID-associated so-called storm. So steroids are beneficial, which we have seen in COVID in our day-to-day practice. So dexamethasone versus methylprednisolone, high dose for COVID-19 it was pretty high dose was used. Methylprednisolone used up to 500 milligrams per day for 3 days, and prednisolone was 50 milligrams for 14 days. The DEXA group evolved to severe ARDS in higher proportion. Transfer to ICU was higher in DEXA group. Mortality after starting treatment was higher in DEXA group. Significantly less need for mechanical ventilation in methylprednisolone group. So this study actually compared dexamethasone versus methylprednisolone, recently published in PLOS ONE, which showed that dexamethasone may be associated with poor outcome as compared to methylprednisolone. So that's what I said. It is still debated topic, and that's why the debate was kept by the organizers about use of steroids in ARDS, whether it is due to COVID or without COVID. I think the effect is just the same. Again, study from Wuhan, which shows some benefit with methylprednisolone, where you can see in Kaplan-Meier curve, methylprednisolone associated with better survival as compared to the group which did not receive methylprednisolone. Again, the similar study from Wuhan. And this is an appropriate study, probably published in South African Medical Journal. The title itself is exactly the same title of our debate topic. Corticosteroids in critical COVID-19 are all corticosteroids equal. So they have used dexamethasone, hydrocortisone, and methylprednisolone comparable numbers in patients with PF ratio less than 100, that is severe ARDS patients. And dose of hydrocortisone was 100 to 200 milligrams 6-hourly for 10 days to 14 days. Dexamethasone 8 milligram once a day for 10 to 14 days, and methylprednisolone 40 milligrams twice a day for 10 to 14 days. And the survival rates were more or less similar. In hydrocortisone 38%, methylprednisolone 39%, and dexamethasone 33%. And there was no statistical significance. So this trial, or this study itself answers our question that all the steroids are more or less same. Personally, before COVID, we never used steroids, especially only for ARDS. If it is ARDS mimic, or if there is an other possible diagnosis like acute interstitial pneumonia or acute eosinophilic pneumonitis, or associated with connective tissue disorder, then only we have used steroids. Otherwise, only for ARDS, we are not using steroids in non-COVID patients. In COVID, obviously, we started using methylprednisolone since March, as I said before. And after publication of recovery study, we started using dexamethasone because it's a cheaper drug and well-proven and effective drug. So we use, today we use dexamethasone for 5 to 10 days, mostly 5 days, not more than that. But if there is absence of infection and inflammatory markers are still high, requirement of oxygen is still high, we may extend dexamethasone for 10 days. But interesting fact is, when we analyze our data before use of dexamethasone, that is with methylprednisolone, that data we have published in Indian Journal of Critical Care Medicine as well, our mortality or morbidity was just the same after using dexamethasone. So to me, my personal experience, dexamethasone and methylprednisolone are just the same in COVID. We still do not know which patient will be benefited with steroids. So this is a very important question. Whether to use steroids or not to use steroids, we really don't know, because still there is no convincing data that steroid will be beneficial in ARDS. But in COVID, it is little convincing that steroids are useful, at least in the early 5 days, it is beneficial. But in non-COVID ARDS, I'm still do not convinced that steroids are beneficial. No meta-analysis is showing there is some benefit by using steroids. And about the type of steroid, I am convinced that all steroids are just the same, whether we use methylprednisolone or prednisolone or dexamethasone or hydrocortisone. So short course of steroids may be yes for non-COVID steroids and for non-COVID ARDS, and for COVID severe lung disease, a short course of dexamethasone or methylprednisolone is justified. I think the title is correct. The steroid is the steroid. It doesn't matter whether we use dexa or hydrocort or methylprednisolone. Thank you very much.
Thank you.
At the outset,
Thank you
I would
very
like
much.
to thank the organizers for giving me this opportunity to deliver a lecture on learning lessons from COVID. Since the disease started in Wuhan in December 2019, it has been a continuous process of learning.
Yeah, thanks. I think there was a little bit of a technical problem there. So thank you, Dr. Sameer Chog, for coming up with the important points regarding the steroids, about its use, how much does it matter, which one and how long. So now it must have raised a lot of questions, a lot of queries and doubts in the minds of all, but we are just going to listen to our other speaker. We are going to have his viewpoints, Dr. Rahul Pandit's points out here regarding the same topic, and then we can take it up for a discussion subsequently once we have listened to Dr. Rahul Pandit. So may I invite Dr. Rahul Pandit to come out with his viewpoint. Dr. Rahul Pandit is a consultant intensivist, and he is working for Fortis Hospital, Mumbai. So we invite him to present his part of the particular topic. So yes, Dr. Rahul, you can go ahead, please. Can we raise the audio, please? Yeah.
Zog has already topic indeed. Steroids. How does it matter which one to use and for how long? And in this pro and con debate, my colleague and friend, Dr. Samir Zog, has already presented his point of view on the pro side. I'm going to try and put up a con side to it, and let us see if we can actually be able to disseminate the information in such a way that one is better than the other. It's important to understand that in every pro and con debate, it's not necessarily that one side wins or the other side loses. It is to strike a balance, because usually the pro and con debates which are there in medicine are on topics which may necessarily not have a very clear evidence. And hence, these debates are established. If there was a clear evidence, there would be no debate about it. Now, let's look at the steroids. Now, steroids have really infiltrated, importantly, all branches of medicine. I mean, there's not one branch of medicine where steroid is not useful. And what's important is it has been used in every possible route of administration. You name it, it's topical, it's intravenous, it's oral, it can be given intramuscular. All of these routes have been literally used, and variety of steroids have been used. You have inhaled corticosteroids, I think the list just goes on. But when we talk about steroids in intensive care, we need to understand that predominantly, if you look at the three types of steroids, one is the anabolic steroids, obviously, which we don't talk about. The other is your corticosteroids, which essentially is the replacement of the cortisol, or it's compared with the cortisol which is produced in the adrenal cortex. And then, of course, you have the immunogenic component of the steroids, which are there. And out of these three, the one which we use in intensive care is the corticosteroids, predominantly having two kinds of activities, the mineralocorticoid activity and the glucocorticoid activity. And obviously, most of the importance is given to the glucocorticoid activity. The mineralocorticoid activity is regulated by the renin-angiotensin system. So it's a different pathway, whereas the glucocorticoid activity is regulated by the ACTH, or the corticotropin hormone. The mineralocorticoid essentially has the salt retaining property, and fluorocortisone seems to be the predominant one which is used to have the mineralocorticoid effect. And the glucocorticoid effect in turn has anti-inflammatory effect, metabolic effect, immunogenic effects, and the main molecules which are used is dexamethasone, prednisolone, methylprednisolone, so on and so forth. However, I think there is a fair bit of overlap between the molecules in both the directions. And that's why this whole process is not very, very clearly demarcated and differentiated. We've got to assume some physiological facts and assumptions. Well, we all know that the cortisol is the primary hormone. When we talk about potency of the steroids, all the comparisons are done in relation to the hydrocortisone. So if the steroid is called to be more potent, it's called as hydrocortisone. It's in comparison to hydrocortisone. And less potent, again, it's comparison to hydrocortisone. Even mineralocorticoid activity is expressed relative to hydrocortisone. Okay, potency lessens the mineralocorticoid effect and essentially lessens side effects as well. Whereas when we talk about short, medium, and long-term action, it is in context to the suppression of the hypothalamic pituitary axis. How long would this particular molecule suppress it? And this is a most important aspect, I think. When we talk about which steroid to use, I think this action plays a large role in understanding which steroids we are going to use for a particular problem. This table depicts quite nicely the various effects of steroids. Again, when we talk about it, you can see that there are three types mentioned here: the short-acting, intermediate-acting, and the long-acting. And the predominant molecule being the cortisol. I think the comparison is done in relation to hydrocortisone. If you look at inflammatory potency, anti-inflammatory potency, if this was 1, and the dose would be around 20 milligrams of it, 20-25 milligrams of it, the HPA axis suppression or effect lasts for around 8 to 12 hours. And obviously it's one here because it's in relationship to the hydrocortisone itself. Whereas when you talk about prednisone or prednisolone, the action lasts much more longer, up to 36 hours. Similarly for methylpred as well. And the anti-inflammatory potency is almost 4 times or 5 times higher than the hydrocortisone. And of course, when you go to dexamethasone, the potency is almost 20 times higher. And the equivalent dose is, if hydrocortisone was 20 milligrams, it is just around 0.75 to 1 milligram. But the duration of hypothalamic pituitary axis is more than 36 hours. I think that's a very important classification which we all need to understand. We also need to understand that based on this, there are a lot of drug-drug interactions and systemic effects of steroids, which we probably don't look very deeply into, but many times can actually play a very important role in understanding and determining which steroid are you going to use for a patient. Also, again, this is where the debate is, but there is some amount of literature which points that some of the molecules have a better penetration in few of the body organs. So you've got methylprednisolone, which has got a better penetration as compared to prednisolone, and this was a paper which was published way back in almost 1999. And more recently, methylprednisolone had a better lung penetration as compared to dexamethasone. This was one of the papers which was published during COVID-19 pandemic. And you obviously have the understanding of the debate whether to use DEXA or the recovery trial evidence is obviously in favor of dexamethasone as opposed to the prednisolone, which is one of the other protocols which people have been using. Also, the CSF penetration of proteins, and we all know that the proteins the steroids can be protein bound as well. And if you have to have a CSF penetration, it all depends on how much fraction of the drug is protein bound. And if you have free unbound dexamethasone, which is probably the one which is available the most, the penetration is better. And immunomodulatory effects are also very, very difficult to differentiate. Hence, I think it's important to know that which organ are we actually trying to target so that an appropriate steroid core molecule could be used. This is the triple-blinded randomized controlled trial, which looked at methylprednisolone versus dexamethasone for hospitalized COVID-19 patients. And the finding was important. I think it's a small study of around 86 patients in Iran, and they used a dose of methylprednisolone in 2 milligrams per kilogram per day, or the recovery trial dose of dexa, and found that in hospitalized hypoxic patients, methylprednisolone demonstrated better results as compared to dexamethasone. And the whole premise of this trial was that it has got a better penetration as compared to dexamethasone. I think we need to have more studies, larger trials to actually understand whether it really makes a difference or not. Glucocorticoids in central nervous system and bacterial infections. Now, I think the most important point here is the use of steroids for Mycobacterium tuberculosis. We all know that TB meningitis, we have been using steroids for a long, long time. And there is reasonable amount of supportive data to use in this condition, and it has shown to reduce mortality in obviously moderate or severe infections. Similarly, in H. influenza, strep pneumonia, Neisseria meningitis, I think there is data. The data obviously differs between infant children and adults, but there is increasing amount of suggestion that there are a number of trials which are now showing that there is some amount of reduction in the mortality. But what's interesting is that most of the molecules which are used are dexamethasone here. This is another interesting paper which talks about critical illness related corticosteroid insufficiency by Jalal Yanan. This was a narrative review by a task force which was set up by the Society of Critical Care Medicine and the European Society of Intensive Care Medicine. And they sort of looked at the general mechanism of actions because of which there is a decrease in the cortisol levels or corticosteroid levels in critical illness. And here you can see that there could be a decrease in the cortical production either because of altered adrenal synthesis of cortisol, because of necrosis, hemorrhage, decreased availability of esterified cholesterol, or inhibition of steroidogenesis. Then there could be an alteration in the ACTH synthesis, obviously. There could be an alteration in the metabolism of the cortisol, or there could be a target tissue resistance to the cortisol.
And obviously, depending on which type of illness are you looking at, you may perhaps want to change the steroid because you may probably want to use one longer than the other. And that's where I think it makes a difference. However, let me come to this concluding slide. Does it really make a difference? I think apart from the duration of hypothalamic pituitary axis suppression, the answer is no. No clinical trial has conclusively proven it that one steroid is better over the other. I must say that. However, it does make a sense to understand why we are using the steroid and what duration of action do you intend it to have. Also, there is a strong historic bias on these steroids use, and there is a overlapping actions between these molecules. Hence, I think an answer would probably be very, very difficult to be found than to be expected. Thank you very much. I'll be happy to be taking up questions from my colleagues.
Yeah, thank you very much, Dr. Rahul, for getting up the points here. So before we go on to the conclusion or having a summary of this presentation, can I take a quick question with you? Dr. Sameer Jog is having some connectivity problems, so maybe Dr. Rahul Pandit can come to us with the queries and their answers. So Dr. Rahul, despite having gone through the literature and a lot of information, now why do we still prefer dexamethasone over methylprednisolone? Having taken the background of all the trials, but still the recommendation is that you should be going ahead with dexamethasone. And people are using dexamethasone, people are using methylprednisolone. So what should be the way forward in this?
So you need to unmute.
Dr. Rahul?
He's online, but I think network issue.
Okay. Okay, so till the time that he answers, so let me then come to the summarization of this particular debate. I know a lot of points have been put forward, but we just need to take few key points from this. The first one is that we have been using steroids for quite a long period of time, but during COVID, there were a lot of controversy initially that people were using, but the evidence was quite weak. But gradually with time, you had a lot of studies coming up. There were a lot of varied studies, in fact, which talked about different outcomes, which talked about different parameters. They had different class of patients. They had different steroids. They had different doses of steroids. So subsequently, we had the ups and downs when we saw methylprednisolone high dose being recommended, dexamethasone high dose being recommended for a long duration of time. And gradually, then it came down to a low dose and a low period of time. So what we should be taking cue from all this presentation is that the last 1 year of COVID has really taken a lot of doubts out. And as humans are quite inquisitive, more so the critical care clinicians are. Initially, we wanted some clarity about steroids, but later we wanted which steroid, how long, and how much to be given. So answers came up with the recovery trial. That was the largest randomized controlled trial, which showed that dexamethasone was better as compared to not giving steroids in terms of the outcome at a 28-day mortality. But then the meta-analysis also came up in September 2020. Now, this was published in JAMA, and this was dealing with multiple trials when they had taken up cases where they had used high-dose dexamethasone, low-dose dexamethasone. They had used methylprednisolone at high doses, and they had also used a low dose of hydrocortisone. So based on this, the recommendation that came about, again, we had a lot of variations here also. They talked about different outcome parameters. They talked about different class of patients. It was not just COVID patients, it was COVID patients with pneumonia, whether they were provided respiratory support or not, or they were just admitted in ICU. So a lot of confusing factors. And then there were the 3 or 4 types of steroids being used with different doses, different durations. So basically the net outcome was that dexamethasone or steroids are beneficial. And based on the background of having a recovery trial result, which showed that dexamethasone at low dose for 10 days is better. So I think that has given a lot of leverage and a lot of support for us. But there was another trial that was published later. That was the MET-COVID trial, which came up in May 2021. This was done on a small subset of patients in Brazil, and they had studied methylprednisolone. So, but they found that in all these COVID patients, they're not taking ARDS. So I think that's how it goes. The controversy is still on. We will be getting inputs from the trials which are coming, but no doubt the large randomized controlled trials and the meta-analysis do give a lot of insight. And we are quite clear as to that steroids should be given. It should be at a low dose for a less period of time. And also that dexamethasone is preferable over the other steroids. So Dr. Rahul, are you there?
No, sir. I think he's
okay, no problem at all.
activation.
So I think we can summarize that the controversy will still continue, but the fact that the basal factor that should remain is that steroids should be indicated and should be used for all these patients. Dexamethasone takes a preference, and there will be studies coming up in favor of any of these steroids. But what we have to always remember that the right dose of steroids, giving it at the right time, and giving it to the right patient, I think that's something which all of us will have to bear in mind. And that should be the message taken from this particular session. Thanks to both the speakers, Dr. Sameer Jog, Dr. Rahul Pandit, and thanks to the organizers. I think we can proceed to the next session. Thank you very much once again. Good day to all.
Good afternoon, everyone. Now we begin with our first thematic session of the World Conference on COVID and Critical Care. And the chairpersons for our session are Dr. Tasneem Ladda, Consultant Anesthesiologist, Zuleika Hospital, Sharjah, Dr. Anupam Sharma, Emergency Medicine Specialist, Lotus Super Specialty Hospital, Agra, Dr. Pradyuman Sharma, Fellow in Diabetes, Fellow in ICP, Jaipur, Dr. Vishwadeep Singh, Associate Professor, Department Anesthesia, SRM, Bareilly. Now I would request chairpersons to introduce our speakers.
This is Dr. Pradyuman Sharma. I am proud to introduce Dr. D.P. Samdhar. He is a Director of Medical Affairs, Ruby General Hospital, Kolkata. So may I request Dr. D.P. Samdhar. Topic is learning lessons from COVID, a continuous process, which we still understand. What we started with ritonavir and pinavir, now coming to the steroids, now we have a monoclonal antibodies. Lots of the weightage was the remdesivir, but already lost the game, and things have been changing overnight. So coming with this new understanding, let's have Dr. D.P. Samdhar, listen to him and be wise enough. Thank you, Doctor. Over to Dr. D.P. Samdhar.
At the outset, I would like to thank the organizers for giving me this opportunity to deliver a lecture on learning lessons from COVID. Since the disease started in Wuhan in December 2019, it has been a continuous process of learning. Yet, we don't know what was the source of the virus. The WHO team failed to identify it. Demand was made by 14 countries to have unfettered access to the data. The situation almost same as it was during influenza pandemic, when historian Nancy Toms had mentioned that the disease at that time was simple to understand but difficult to control. I feel that COVID-19 is difficult to understand and difficult to control. We know that it is caused by SARS-CoV-2. Mutation is common, leading to variants of concern and variants of interest. Females are more affected, males are more severely affected. Disease evolves over a week. Presentation ranges from mild to critical illness. Prolonged viral shedding, pre and asymptomatic transmissions are a matter of concern. Transmission is mostly by droplet. Aerosol and contact transmissions are also possible. Usual presentations are fever, cough, dyspnea, altered smell and taste are experienced by very many patients. Symptom to pneumonia interval is approximately 5 days. Severe hypoxemia develops by 7 to 12 days. The clinical criteria of critical illness, according to WHO, is respiratory rate more than 30 or less than 10. Presence of respiratory distress saturation less than 92%. Falsely high pulse oximetry reading is possible in dark-skinned people. Masked clinical signs symptoms with hypoxemia is possible in happy hypoxemic situation. Initial improvement followed by critical illness is seen in sepsis associated with COVID-19. Other coexisting infections can also influence the presentation. There could be non-respiratory manifestations also, like stroke, acute coronary syndrome, GI symptoms. Approximately 5% of cases need critical care support. Replication of virus inside cell causes direct tissue damage. It is followed by immune response, cytokine release, the dysregulated RAS, local and systemic hyperinflammatory reactions. Microembolization leads to dead space ventilation, oxygen support, mechanical ventilation do not help in this situation. Pulmonary and other organ involvement are common. Infrared thermometer has limited sensitivity in detecting fever. Masking has been advocated during previous pandemics also and during COVID-19. It prevents the droplet transmission, but it has been advocated, challenged, counter-challenged. Presently, in US, for vaccinated persons, it is not being recommended and social distancing is also not advocated. But social distancing more than 2 meters prevents the droplet transmission. And it has been observed that transmission risk with more than 1 meter distance is only 2.6% and less than 1 meter it is 12.9%. In hospital setup, 6 feet social distancing is essential according to CDC. Soap, water, hand hygiene is advocated over alcohol disinfection. Medical grade masks like N95, FFP2, FFP3 have been recommended for the healthcare workers. A single mask can be reused intermittently or it can be used continuous basis for 8 hours, but clear evidence to support this practice is lacking. Precautions should be taken for droplet, for airborne transmission also, frequent air exchanges, negative pressure ventilation, avoidance of aerosol generating procedures, all are helpful in preventing airborne transmission. Isolation in critically ill patient 10 to 20 days. Since symptoms onset, at least 24 hours afebrile gap without antipyretic, and negative test is not recommended for termination of isolation. Multiple vaccines have been developed. Mostly it is given through intradermal or intramuscular route. Nasal route doesn't evoke antibody response to the desired level. Live attenuated COVID-19 vaccines administered through respiratory tract are undergoing preclinical trial. Multiple platforms have been used, old and new. Newer are RNA and DNA vaccines like Pfizer and Biotech, and Moderna vaccine. The dose, the duration, the interval, the storage condition, and the efficacy all vary with the different kind of vaccines. Lymphopenia, raised lactate dehydrogenase, elevated D-dimer, prompt PT, and transaminase levels have been observed. They are not diagnosed. For reaching the diagnosis, RT-PCR has been recommended. It detects the viral RNA. The reported sensitivity is 73.3% with nasopharyngeal swab. It needs molecular lab, skilled staff and time. Therefore, rapid diagnostic tests are being evolved like LFD, LAMP, and LAMPOR. Multiplex PCR panels also have been advocated to identify other common viral pathogens coexisting with COVID. Antigen testing is the alternative. It detects the protein of the outer cells of the virus. It has got similar specificity but limited sensitivity. It is not recommended over RT-PCR by CDC. Reduced sensitivity with antigen testing has been observed in those patients where cycle threshold value is more than 30 with RT-PCR. Viral culture and serological testing, that is antibody testing, are not recommended for diagnosing infection. Antibody testing can still be done in highly suspected cases with repeated negative viral RNA tests for diagnosing MISC and MISA and for retrospective confirmation of infection. It should be done after 2 to 3 weeks of the disease initiation. In patients where respiratory symptoms are present, some lung involvement will be there, and CT is the better modality for identifying it. Management is mostly supported. It is focused on oxygenation and mechanical ventilator support. Conventional high-frequency laser oxygenation, CPAP, NIV, all can be tried depending on the need. Failure to maintain normal work of breathing and PO to FiO2 ratio of less than 300 millimeter of mercury deserve mechanical ventilator support, which could be NIV. Helmet has got its own advantage, prevents aerosol generation. Invasive ventilation should be lung protective. prone and lateral decubitors should be need-based. ECMO is the last resort. The outcome is not good. Fluid and vasopressor should be judiciously used. Medications are used, but most controversies are around the medications. Antiviral and monoclonal antibodies are recommended in the early stage to prevent viral entry and replication in human cells. Molnupiravir is the only drug which is undergoing phase 3 trial and showing promise. Remdesivir has been extensively used and had been recommended by most regulatory bodies and academic bodies, but being not recommended by WHO based on the WHO Solidarity trial. It is reserved drug under emergency use authorization in India. AO guideline 2021 moderately had recommended for cancer patients. In early phase, monoclonal antibodies can be used in if the age is more than 12 years, more than 40 kg weight, oxygen supplementation not required, and high risk of progression is there. Multiple combinations are there. Acirivimab, Devimab had been advocated for prophylaxis also. Bamlanivimab and Etesivimab had been used for the Delta variants and currently being used in the US. Moderately, severely, and critically ill patients, steroid had to be most beneficial. It reduces mortality by 1/5 in oxygenated patient and 1/3 in ventilated patient. Dexamethasone 6 mg OD is preferred. Alternatively, methylprednisolone, prednisolone, hydrocortisone can be used. Optimal dose and timing of administration still remain unanswered. The duration is 10 days or until hospitalization. Low molecular weight heparin, unfractionated heparin had been recommended by NIH as soon as possible within 24 hours of admission. Enoxaparin dose is 40 mg subcutaneous OD for 14 days or less. Higher dose is not beneficial. Ethnic variation in incidence of thromboembolism around 2.9% has been noted in Japanese population. Therefore, generalized application of Western guideline at global level had been questioned by these authors. Tocilizumab, an immunomodulator, interleukin-6 blocker, can be used to counteract the hyperinflammatory response in severely ill patient needing high oxygen flow. NIB lab evidence of progression is there, but IDSA has not recommended its routine use. Several sepsis campaign also has not advocated due to insufficient data. WHO doesn't recommend it. Single dose 8 mg per kg of body weight can be used and repeat after 12 to 24 hours based on clinical requirement can be tried. Sarilumab is the alternative to tocilizumab if it is not available. Baricitinib, another immunomodulator, Janus kinase inhibitor, similar indications can be tried. IDSA has recommended in severe cases when corticosteroid cannot be used with remdesivir in hospitalized patients. It is oral therapy is given. And Tafasitamab is another alternative for this to this drug. There are multiple miscellaneous drugs that have been used in the past. Acetaminophen said it can be used depending upon the need. Angiotensin converting enzyme inhibitor and ARB. Their role is debatable. Antimicrobials should be used judiciously. Chloroquine, hydroxychloroquine, azithromycin, doxycycline, vitamin C, D, and zinc. Their role is not well. They are not being recommended now. Organization planning was the most crucial thing, and it has shown maximum gap as far as the infection control and preventive measures are concerned. In a national survey in USA, 15,000 nurses participated, and they mentioned that there was gross lack in providing the infection control and preventive support to the patients and the workforce. They were not getting the mask, or they were reusing the mask. The situation remains the same. All over the world in developing countries, the situation was still worse. Organization and planning, therefore, is important. Infrastructure, equipment, human resource supply chain, and communication should be considered. And International Science Council, that is a monitoring body, believes that short-term priorities are more important, but long-term decisions are more crucial. Thank you so much for your patient hearing.
May I request the chairpersons to have any questions?
Very nice presentation by doctor. Now we should invite the next speaker. Dr. Raman Sharma. He is Senior Professor of Medicine in SMS Medical College, Jaipur. And his topic is pitfall in COVID management. So Dr. Sharma, please continue.
Yeah, good afternoon, everyone. And today I am going to talk about pitfalls in management of COVID-19. I am extremely thankful to the organizing committee for allowing me to be a participant as a speaker in this prestigious conference. Now, before going for management issues, we should know that what is the disease severity. It is very, very important that we assess the disease severity of COVID-19. Most of the cases fall into mild category, 14% fall into moderate to severe, whereas 5% fall in a critical category. So mostly 81% of these patients do not have many important symptoms. They have just fever, uncomplicated URI, there is no dyspnea. In moderate, there is evidence of lower respiratory disease with SpO2 falling between 90 to 93% on room air and respiratory rate going to 24 per minute. Severe patients requires oxygen support. The SpO2 goes down below 90% on room air and the respiratory rate moves to 30 per minute. In rapidly progressive type 1 respiratory failure is there. It is a critical disease. It may be associated with sepsis, septic shock, MODS, and altered mentation. And of course, we can classify according to the chest imaging or CT severity index. If it is 9/25, it is mild. If it is 15/25, it is moderate. And if it is more than 15, it is severe. This is important to classify for management issues. Now, this is a very important depiction of severity and management. You can see here management consideration. This was published in NEJM on October 29, 2020. So initial phase is the phase of viral replication followed by phase of inflammation. So we do not forget the viral replication phase, which is usually 7 to 9 days, followed by the hyperinflammatory phase, which starts after 7 days or 9 days. And this is the important target that we have to go for antiviral therapy during the viral replication phase. If we use anti-inflammatory agent like dexamethasone in this phase, this can be detrimental. So we have to monitor the symptoms, and clinical monitoring and supportive care is required in mild illness. Clinical monitoring, if the patient is hospitalized and high risk for deterioration, you can use possibly remdesivir, though it has not shown to have a mortality benefit. However, in severe illness, hospitalization, oxygen therapy, and specific therapy like remdesivir and dexamethasone are important choice. Critical care and specific therapy again is useful in critical care illness. Now, there are certain parameters which indicate a poor prognosis. The D dimer is one of the most important one. If it is more than 1000 nanogram, it indicates a poor prognosis. CRP more than 100. LDH more than 245, troponin greater than 2 times the upper normal limit, ferritin more than 200 microgram per liter, CPK more than twice the upper normal limit, AKI, which is the usual definition, that is increase in serum creatinine 1.5 times baseline or 0.3 milligram per deciliter within 48 hours increment. At the onset, if the absolute lymphocyte count is less than 800, it is a poor indicator. Now, currently there is insufficient data to recommend either for or against use of these data to guide management decisions. particularly with D-dimer. D-dimer, we have seen in our clinical practice, remains elevated for up to 3 to 4 months, and really we don't know what to do and what not to do. So marker kinetics is not yet been standardized, and we really do not follow what order kinetics these markers are there. Sometimes they remain elevated for months together. Now coming to the specific therapy, most important thing is anticoagulation, could be prophylactic or therapeutic. Antivirals like remdesivir, baricitinib, convalescent plasma or monoclonal antibodies, and then to tackle the inflammatory response, we have IL-6 pathway inhibitors, and most importantly, dexamethasone. Anticoagulation is important because it's a hypercoagulable state, and the risk of thromboembolic disease is increased in critically ill individuals. Standard prophylactic anticoagulation is associated with 50% reduction in hospital mortality and risk of intubation with 1.7% risk of bleeding, whereas full dose anticoagulation is associated with 47% mortality reduction with a 3% bleeding risk. Now, this is a beautiful diagram, prevention of venous thromboembolism, which was published by the JACC journal, and the work was done by Nadkarni et al. They have shown here the mortality benefit, 50% versus 47% reduction with prophylactic and full therapeutic anticoagulation respectively. This is the therapeutic and prophylactic anticoagulation, and this is the mortality. Now, do we really use full dose anticoagulation? The recent recommendation is that use of anticoagulation should be used in a single daily dose, that is prophylactic dose. And you have to know the high risk group like old age, D-dimer more than 2 times of the upper limit level, and improve VT scores more than 4 in order to use a full therapeutic dose of anticoagulation. So this is the improved VT score. The following parameters are there. Prior VT, 3 points. Thrombophilia gets 2 points. Current lower limb paralysis gets 2 points. Current carcinoma gets 2 points. Immobilization 4 or more than 7 days, 1. ICU admission or CAD 1, and age more than 60 years, 1. Now coming to the most important drug, which has been considered as the magic drug, but it is not so, because the trials have already shown. The ACT-1 study was very important, published in NEJM October 8, 2020. And you can see here in mild to moderate disease, the medium recovery time with remdesivir is 10 days, whereas with usual care, it is 15 days. In severe disease, it is 11 days versus 18 days with the usual care. So remdesivir was superior to placebo in shortening the time to recovery in adults who were hospitalized with COVID-19 having evidence of lower respiratory tract infection. So if the virus is residing in throat, do not use remdesivir. That is a drawback. Now, remdesivir, many trials have come. They have shown a mixed result. Evidence for use is weak. None of the studies have shown any mortality benefit. WHO, the solidarity trial, SMS Hospital was a part of this important trial, and we have concluded that there is no mortality benefit. You can see here the control and remdesivir are running neck to neck, and you can see the number of patients who died with remdesivir, 129, with control 126. However, still most centers continue to use remdesivir. Now, another important antiviral, this is basically a JAK inhibitor used for treatment of RA. In addition to the immunomodulatory effect, it is thought to have potential antiviral effects through interference with viral entry. So it may be classified as antiviral also. Important trial of 1525 hospitalized patient with COVID-19 was done, which is known as Cove Barrier trial. It has shown a combination of baricitinib with remdesivir or Dexona, a 30% reduction in mortality. Placid trial by ICMR these results indicate that there was no difference in 28-day mortality or progression to severe disease among moderately ill COVID-19 patients treated with convalescent plasma as compared with standard of care. Now, steroids, the most used drug or misused drug. COVID is a steroid-responsive disease. For hospitalized patients with severe COVID-19 who are receiving supplemental oxygen, including those who are on high-flow oxygen and non-invasive ventilation, low-dose dexamethasone is evidenced as grade 2C. So please remember, this is a low-dose dexamethasone. WHO has issued advisory not to use corticosteroids for prevention or treatment in patients not on supplemental oxygen with non-severe COVID, but we have seen patients being given dexamethasone or methylprednisolone on domiciliary basis without any hypoxemia. This is the result of recovery trial. We can see here, no oxygen received, dexamethasone, the mortality was 17%. With usual care, it was 13.2%. Oxygen alone, dexamethasone has shown benefit. With invasive mechanical ventilation, dexamethasone has shown some benefit. So it has resulted in lower 28-day mortality among those who were receiving either invasive mechanical ventilation or oxygen. This is again the graphics of the recovery trials, and we can see here invasive mechanical ventilation. There is a definite benefit, mortality benefit. No oxygen received, then dexamethasone has found to be detrimental. Now, what about the other immunomodulator, tocilizumab? This is a very important drug. This used to be very important during the initial phase. Again, there were mixed trial, and this is the article published in NEJM on April 22, 2021. It concludes that tocilizumab did not provide a clinical benefit as compared with placebo in patients with severe COVID-19 pneumonia. So even though these treatments seem to have potential benefit, it is not known if they are more effective in treating COVID patients and helping them recover than the usual standard of care. So things are still at a gray stage. And so conclude, 80 to 85% do not require pharmacotherapy. Supportive care is of prime importance. Oxygen, awake prone positioning should not be forgotten. Dexamethasone in low dose, as I already highlighted, mortality benefit, but only in oxygen requiring patients, harmful in non-oxygen requiring individuals, that is when SaO2 is more than 94%. Anticoagulation in hospitalized patient, mortality benefit is there, and it may also help in prevention of sudden death. Continuing anticoagulation for extended VTE prophylaxis after hospital discharge can be considered only for patients who are at low risk for bleeding and high risk for VTE. So D-dimer does not indicate an elevation there, does not indicate that the patient has to continue with oral anticoagulation or antiplatelet. For non-hospitalized patients, anticoagulants and antiplatelet therapy should not be initiated for the prevention of venous thromboembolism or arterial thrombosis unless the patient has other indications for the therapy. And then coming to the antivirals like remdesivir and convalescent plasma, more data are needed and to be used on case-to-case basis. Tocilizumab may be beneficial in hospitalized patients on high-flow oxygen or NIV who have evidence of clinical progression and presence of increased markers of inflammation. Baricitinib and TCZ are not to be combined because of additive potential immunosuppressive effects. So this is the message I wanted to convey, but there are certain pitfalls because we really do not confer ourselves to the guidelines which have been issued from time to time or issued in the journals. So thank you very much for your patient listening.
Thank you, Raman. What an extended, beautiful. That's very true. Nothing is 100%. Pitfalls will always remain. Pitfalls were there. Pitfalls will be there. It's a time of learning. We are learning daily because it is said that the SARS-CoV-2 is a new disease. We did start way back in March with ritonavir, followed by SCQ, ivermectin, remdesivir, paratacil, ZAC inhibitors. But coming to the final end of the says, early intervention with monoclonal antibodies identifying who is going to be severe, and later on the steroids have a big say to the road. The biggest question today we have is an internal antifibrotics. As what we have learned from Dr. Dhruv Chaudhary in the morning, there are 3 phenotypes. They behave differently. Some do progress, some do not progress, and most of the time it is reversible. So, but it is a question of time. We have to understand. In SARS-CoV-1, it was a 2003, and there was a Lancet study in 2019. There have been people who have been followed up for the last 15 years, and it was concluded where most of the patients who were on steroids, they had a fractured neck or femur, avascular necrosis of femur. But that time was a different. We had to use high doses of steroids. This time we are using just low dose of steroids. So the carry-home message is we should be very careful in starting the steroids, whom to give or not to give. Long-term management with steroids, low dose, very important. Anticoagulants, again, have a big say to say. Coming to the antifibrotics, we have still a question mark, whether they do stand or they do not. So my all congratulations, Raman, for a beautiful presentation.
Thank you very much.
Sir, I want to ask one question. In spite of all treatment, patient is not responding. What can be the reason?
It's basically viral pneumonia. So it's a viral disease and we don't really have a specific antiviral agent. So if you don't have anything, of course, the patient would, a case of bilateral pneumonia would progress into ARDS, and you know ARDS is very difficult and the mortality is very high. So critically ill patients, mortality is absolutely very much there, and no specific antiviral. We used to have oseltamivir for swine flu. If you use it early, you can reduce the mortality, but there is no such drug available. That's the problem.
Sir, any genetic association family-wise for prognosis? If one brother is died and another is infecting?
I don't think these studies have been done in genomic studies. Whatever has been done is the genome of the virus. Virus sequencing has been done, but maybe over a period of time, like some races, blacks may be more prone for certain infections and viral infections. So whether there is a difference between two brothers or brother and sister is really not yet been studied.
Dr. Raman, there's been a study that the Hispanic Americans, they had a high mortality in comparison to white Americans, number one. Number two, South Asians, we did say that we are better off, but coming out of the mortality, we had a very high mortality. Number one. Number two, where the patient who had a history, males do behave a little more badly than the females, number one. Number, the age is again a scenario, past age 65. Number three, who is a smoker, associated COPD element, alcoholics, brittle diabetics, renal failure, or people who had a heart failure patients, they generally behave bad. Most important is the strain, whether you are getting an alpha strain or delta 2 strain. The strain is a very potent to kill you. So, because what we have learned over a period of time from SARS-1 to SARS-2, that the spike protein has been more potent, 70 times more potent than the SARS-1 had it, number one. Number two, in alpha and delta, again, there's a 70 to 100% they are more potent. So it's just the question of mark whether you are a delta 1, delta 2, or which strain is infecting you. So it's a chances is yours. But anyway,
of course, these are the clinical parameters which indicate a poor prognosis. Yes, risk factors are there. So basically, genomic sequence is very important. And I think that third wave has been averted, possibly because there has been no major variation in the antigenic structure of this virus. So beyond delta or delta plus,
but still,
no variant is there.
But I do have a reservation because this probably may be hybrid virus. Each time the SARS-CoV-1 died because each time when it was mutating, it was going down and down. But SARS-2 is going up and up. Each time that the mutation is there, it is getting much stronger. But the time is done. But still, I believe the wave, corona wave is third, maybe there, though delayed, probably maybe in February, March, we can have
Dr. Pradyuman,
vaccination and the variations.
Let us assume that the virus has got fatigued, hopefully. Thank you.
Yeah, we're true enough. Thanks God. It should be there. Dr. Raman, I will give you a party if the virus is fatigued.
Sure.
Congratulations.
Thank you.
Congratulations. So this time we have Dr. Asif Ahmed. He is an MBBS DNB anesthesiology gold medalist. Wonderful. IDCCM senior consultant and holds critical care medicine, Tata Main Hospital, Jamshedpur. And he has a special mention, actively involved in critical care and academics for last 15 years. Teacher and examiner for critical care courses with multiple presentation publication, including books. Wonderful. Dr. Asif, we will be more enlightened to have you, sir. Please, Dr. Asif over there.
Greetings for the day, ladies and gentlemen. Soft skills are an integral part of our day-to-day practice and patient management. It was important during the pre-COVID period. A lot of stress was put during the COVID times, and it's going to continue in the post-COVID era also. During the presentation on soft skills, we'll be discussing as to why do we require soft skills, what are the soft skills, and when and how to use the soft skills. Soft skills are part of the quality index. They're also a component of professional competence and are required to avoid volatile situations. Institutions have now realized that there is a need of soft skills to be inculcated along with the hard skills. The goals today, as we know, are customer expectations, and customer feedback and reputation matters a lot. Regarding care of patients, it's a combination of a bedside clinical skill and treatment, along with good communication and behavior with patients and relatives. Even if we have a very good clinical skill and treatment given to the patient, but we are uncaring and unresponsive towards them, then that's what your patient will remember. Hard skills, which are our medical skills and the academic qualifications and the technical expertise that we have, are important to find a job. But if you have to talk about success in job, it is the soft skills which will have a crucial role to play in here. When a patient comes to the hospital, what they require is basically an immediate attention, good quality of care, and proper communication. Even if you have given the best of attention and the best of quality of care to these patients and relatives, but if you are not good with your communication and from proper, it goes on to improper communication, then that will lead on to volatile situations. Improper communication or poor communication can lead to disappointment, frustration, loss of faith, leading to anger, outbursts, and different ranges of violence. It doesn't stop here. It goes on to litigations and loss of reputation finally. The violence against healthcare can range from telephonic threats to intimidation to verbal abuse and going on to vandalism and arson and even murder also. And all of us have faced it, very much there in the media day in and day out. A survey that was done in 2015 showed that 75% of doctors experienced violence at work. Now, this is not something unique to our country. It's a problem all over, US, Australia, China. But what we have seen in India is a steep rise over the last 2 to 3 years, and it has taken a more aggressive and a violent form. And 70 to 80% of these incidences happen in emergencies and ICUs. Even on the financial aspect, hospitals have reported good losses because of the communication inefficiencies. Voices have been raised against these mishappenings, and action has been taken by the lawmakers, but we also have a need to play some role in there and need to be very proactive in avoiding such situations. The possible causes of these dissatisfaction are basically classed as socioeconomic, institutional, patient-related factors, and healthcare professional factors. But what we are more concerned are the patient-related factors and the healthcare professional factors. Relatives are unable to meet patients during COVID. There is complete disconnect, very contrary to how it was earlier. There are very difficult times during the COVID pandemic, and it will happen in case the third wave hits us. There are uncontrolled emotions filled with anger, despair, frustration, fear of the unknown, and a lot of misinformation going around. The conventional communication that was there earlier has gone way beyond what was expected. And in fact, a lot of places do not have a proper mode of communication also. So the result is that the trivial issues can flare up and can lead to nuisances, violence, and litigations, which is very common. Regarding the healthcare professional factors, all of us are under too much of workload and stress, no doubt about it. We have received excellent medical training, but the empathetic training is lacking. We have not been trained with communication skills adequately, and even the skills required for handling emergencies are lacking. More to add on, during the COVID times, the masked face has led on to the lost connect, where a mask is the only communication mode or the feature that we see over the face, which is there for us to communicate with others. The muffled voice without any expression, the new modes of communication, all these are big challenges which have come about. And we have always been taught to treat just a disease, but what we have to learn is to treat the patient also. The problem actually escalates from a calm phase where there is a normal behavior to a pre-assault phase where the behavior becomes threatening of the relatives, and then finally goes on to assault phase where things are out of control. So if we have to act, it is a phase when they are in the calm phase of the normal behavior, when we have to stop all these activities and prevent any mishaps that can happen by the usage of the soft skills. Therefore, the very need of the hour is soft skills, and all the more during COVID times. As to what is soft skill? Very simply, it can be defined as the ability to connect and communicate with others, respect differences, work with teams, and build relationships. The stress points out here very clearly indicate as to what soft skills are. And if you've talked about the 4 basic pillars, it talks about good and effective communication, good teamwork, adaptability as to how we get set at different situations, and finally, empathy, which is very crucial again. When do we have to apply soft skills? It is basically when you have to have good communication between healthcare personnel, that is interpersonal relationship and communication. And the other requirement is between healthcare personnel and patients' relatives. Between healthcare personnel, it's required actually to have a good working atmosphere, a strong information network, continuity of care, and avoid errors and complication. And this is what we require for a smooth sailing. On the other hand, between healthcare personnel and patients' relatives, it's again required to have a good sync and smooth sailing of the whole treatment process when patients and the relatives are concerned. It avoids any problem that can arise. It leads to good recognition, goodwill, and support of the community if everything is going well, along with the best of the treatment that you are imparting to them. Communication, we need to understand, is the basic requirement. So during COVID times, we just can't miss on that, and it has to be done, be it in phone or in person. How to apply the soft skills? So there are a lot of communication tools which we'll be quickly going through and understanding so that it can be applied in a day-to-day practice. Now, we also need to understand the soft skills that we'll be using. Some of it are inherent, which can be there in a person that is part of his personality. But even if you don't have, with acquiring of new knowledge and getting trained of soft skills, it is very much easy to adapt and practice all these skills at the workplace. When we are meeting people or we're talking to people on the telephone, we can use the very simple protocol of greeting them. I think that's one small smile would do a lot of wonders. Whenever you're communicating and talking to them, please introduce yourself. Give them a preview as to what you'd like to talk to them about and what is the probable time period you'd like to talk to them. Have a good, healthy conversation with them. That is the talking that you do. And finally, end it on a good note saying a thank you. So if you apply this doing meeting people while on the phone, I think it's really going to add a lot of value. The second tool is basically about team building and collaboration. So you have to use your inner skills and the acquired skills basically to inculcate trust, influence people around you. And the quotient of emotional intelligence comes into play where you have a mix of empathy, having difficult conversations, getting people together, and use of social skills. So that's very important. Even team building and collaboration become a part of soft skills. Conflicts is very common all around, between doctors, between nurses, it could be anywhere in the hospital. But all that we need to understand is whatever the cause of the conflict is, whether it's issue-based, ego-based, or value-based, we need to put an end to it, either by collaborating, by compromising, or accommodating. A robust handing over process is very much required between doctors, between nurses, from one shift to another, from one unit to another. And this is also part of good communication. which should be done with the usage of good soft skills, where you have to speak about the background and situation, about whatever you want to hand over, what is the current assessment, and what is the request that you want to make. So this should be coming in a structured manner, be it between doctors, be it between nurses. This is how we follow, but all the communication should be flowing smoothly. We have a lot of situations where you'll be having volatile circumstances, heated arguments going around. You enter a ward or your critical care unit and you find that there's a heated altercation going between the nurse and the patient's relatives. You can't run away from it, nor can you just get on a very rough note. Basically, you have to take ownership. You have to become part of this, since all of us are managers, along with being good clinicians. So what we have to do is we need to introduce ourselves. We need to ask them to please come out with their problems. Once you start believing them and listening to them, you'll see that anger is coming down. And once you have heard them, all that you have to do is apologize for the inconvenience caused. Sorry is the sweetest word that you can say, and finally give them a solution or resolve the problem. You will see by applying this approach, the anger that was as 100% came down to a level of almost 5 to 10%, and they in themselves will be apologetic for the actions that they have created. Always watch for the warning signals where there is increasing dissatisfaction, new queries are being raised, you have a group of visitors together, and a crowd is building up. There you need to be very careful and take additional steps to avoid any mishap. The 5 golden rules of communication should always be remembered. Be a good listener, think before you speak, ask questions, and will never react. The body language is also very important. Spoken words only account for 7% of the impact. Your tone of voice, the softness, and the modulation accounts for 38%, whereas a nonverbal communication is in terms of your appearance, your gestures, and your eye contact. So these are also important, which we need to understand. But what has happened in the current era is that our patients do not see our faces, they only see our masks. And we have to learn to smile with our eyes now. So even though it is stressful, but that's the new way of communication, which all has to run. And that is very rightly put up by Dr. Mauricio. We need to handle patients with a lot of care. For us, seeing serious patients and bad outcomes is a daily routine. But remember, for them, it's the first time, it's shocking. It's very difficult for them to accept, and there are uncontrolled emotions. So here you have to have a humanitarian touch. Where comes the role of empathy? Empathy is basically you try to put yourself in the other person's position and try to feel as to how he would have been feeling at that point of time. What is his expectation, what he would be going through. If we start doing that, we'll be understanding their problems and feelings. We'll be feeling their pain and agony, and we'll be treating them well. So very crucial aspect, very important, and all of us need to inculcate this today or at the earliest. Communication with patients' relatives should be done regularly. We should give them correct information, and any changes should be informed immediately. We have to be polite and firm always. And whenever there is a conversation, ensure that it is ending on a good note and addressing all points. Proper documentation should always be following at the time of admission and on a daily basis whenever you're communicating in the ICUs. Some more points to focus on. Please pay attention to your appearance and presentation. Conduct yourself well. Be very confident. Have good knowledge about whatever you're speaking about the condition. And be careful of your words. Be transparent with no false hopes. Remember, they might be recording all your statement. And whenever you're talking, give all your attention to them with no casual approach. Breaking bad news, be it death, be it any kind of outcome, it's an art itself. The simple spikes protocol speaks about having a proper location, setting up and understanding the situation, followed by willingness to listen and invitation to the people to talk. Have proper knowledge of whatever has happened and explain the facts properly. Explore their emotions, where the role of empathy comes, and finally summarize that we had tried, there was a problem with the patient, but we did our best. And despite all the measures and all the efforts, unfortunately, we could not. We are all there with you at this point of time. And that's all. I think that's how you should be going about with them, with the feel of emotion coming into play there. So we need to remember that if we want to stand out from the crowd, your soft skills have also to shine along with the hard skills. And it has been rightly put forward that a good physician is one who treats the patient, while a great physician is one who treats the patient who has the disease. Thank you very much.
Wonderful. The message is, it's not the text is important, it's that the body language is important. You truly said, and you put it as 38%, but I put it rather as 80%. because the behavior, the approach, and the language accent has a big say to make a role. You can break relation in a day, but you have to make years and years in the life to make relations in it. So breaking is not the point, number one. Number two, one should always try to listen to someone, because some of the time it's the message, what he or she wants to say is a different, the language may be a different. So number one. Number two, don't try to keep egos in between. You can break a family in a day, but make a family over the years. Language is important, never take egos in between, and always listen, and then never answer text to text. Always try to avoid answers exactly to the words. That's the message. Don't try to take the words, take the language, take the body language, and never answer exactly to the text. But you can be avoiding and can make examples, can make suggestions to understand things, because over a period of time, we have seen Atal Bihari Vajpayee is a very live example. Even in the parliament, no one was his foe, because he has never reacted to anyone's statement. He has always given some kavita, poem, stanzas, examples, and making a people to understand through examples is more approachable, not by taking as a person. That's probably rightly said. I admire you. Your presentation is beautiful. Really, this time, doctors should always learn the art of practicing, because you can be a gold medalist, but art of practicing is different, and you can avoid big fights just by using a single sentence. Thank you very much.
Thank you, Dr. Sharma. I think very rightly you have put on the message, but it's very much to be noted that experienced doctors, doctors who have been practicing quite some time, they are quite proficient with the patient's needs and the soft skills. But I think the new generation, people are coming up fresh. It is very important for them because they are at the forefront now. They're managing a lot of cases and they're all over. So it's important qualifications like this. So it's the need of the hour, and all of us should be very much interested.
Truly said, because ABC is the management of the practice. Number one, A is availability, B is behavior, and C is a competence. So behavior comes before the competence. You can be average people, but you can be very popular with the people. So competence comes later on. Behavior is the number one. Truly said, I respect you, I admire you.
Yes. Just a concluding remark, Dr. Sharma, here, what I have to say is that it should come from the top. In fact, the leadership of the hospital, the management, they should be very much into this. And that should run down to every sector, every corner, not just the doctors, it should be going on to the paramedical and every staff of the hospital. I think that's very important. Thank you.
Very important, because everyone follows a leader. How my boss behaves, that's my body. If you have been trained in a good unit, you will always behave, because my whole life has gone what my Dr. S.R. Mehta and Dr. JP has taught me, behavior. Very important. So we generally follow our leaders. That's very sad. Thank you, sir.
Thank you very much.
So this time we have a Dr. Sandeep Kantor, who is a consultant critical care, Royal Hospital, Muscat, Oman. He has more than 20 international publications, spoken chapters, and faculty international and national conferences. And the topic this time will be weaning failure in COVID. Very important, when to wean, when not to wean. Weaning a $1 million question, because we answer to the residents, to the relatives that we are going to wean, but many times we have failed to wean. Very important, a $1 million question to be answered by Dr. Sandeep Kantor.
Good morning, everybody. First of all, I would like to thank the organizers for giving me a chance to speak on such an important topic, that is weaning failure in mechanically ventilated severe COVID patients. The problem is huge, because large population of patients with severe COVID-19, when they are down with acute respiratory failure, they're in the ICU, and about 80% of them will need mechanical ventilation. Mortality in these patients ranges anywhere between 30 to 90%. Such large variability, mortality rates may be due to the fact that these patients remain on mechanical ventilation for a long period of time, especially because they have a great complexity due to multiple organ involvement, such as lung, heart, kidneys, and nervous systems. All these clinical features can contribute to inability to liberate from, for these patients to be liberated from mechanical ventilation. It is therefore very, very relevant for us to identify the risk factors which are associated with longer duration mechanical ventilation. Now, when we talk of weaning process itself can account for about 40% of time on mechanical ventilation, about 5% of critically ill patients who cannot be easily weaned, therefore may require long-term and chronic ventilator use. This can lead to increased length of stay in the hospital, increased economic burden to the healthcare system. These rates may even be higher for COVID-19 due to patient demographics that includes high number of elderly and patients with pre-existing comorbidities. SOFA score, PF ratios, static compliance, acute kidney injury requiring renal replacement therapy, late pulmonary infections, and cardiovascular complications are all independent risk factors for prolonged mechanical ventilation in this subgroup of patients. Risk factors may be classified into three main categories, which are demographics, the baseline severity, physiology, and complications during the ICU stay. Demographical variables include increasing age, which was significantly associated with higher duration of mechanical ventilation, and ICU mortality. SOFA scores at ICU admissions is inversely associated with an increased hazard ratio for liberation from mechanical ventilation at 28 days, and it is directly associated with increased risk of death in these patients. Now, when we look at the conventional ARDS phenotypes, COVID-19 patients, they show a lot of similarities with heterogeneity in respiratory mechanics, aeration loss rate related to the degree of hypoxemia. The debate is still ongoing whether COVID-19 patients special form of ARDS, but recent papers focusing on COVID-19 ARDS pathophysiology reported values of oxygenation, that is PF ratio, and compliance much like those of classical ARDS. When we take a look at the static compliance, the static compliance less than 40 ml per centimeters of water is independently associated with prolonged mechanical ventilation and mortality. So what are the factors responsible for difficult weaning? It can be classified into a respiratory system, which will include poor lung compliance, poor chest wall compliance, increased resistive loads. Neuromuscular problems can be classified into decreased central respiratory drive, decreased airway reflexes, which could be due to increased amount of sedation and neuromuscular paralysis. Neuromuscular weakness also plays an important role, with basically leading to critical illness, polyneuropathy and myopathy, and sometimes myasthenia. Then there are other factors like neuropsychiatric disturbances like delirium, anxiety, and sleep disturbances, metabolic problems like hypokalemia, hypophosphatemia, and hypomagnesemia, and heart failure. So this cartoon depicts the evident and the hidden problems associated with weaning failure. So it is at this point in time, let us look at some of the problems which are specific to COVID-19. So delirium, it can greatly impact the critical illness. It is an independent predictor of mortality, the length of mechanical ventilation, and other long-term complications. It has been exceedingly recognized as a challenging problem in severe COVID, and its potential mechanism includes the direct effect of virus infiltration, hypoxemia, sepsis, or subsequent host immunological response. In addition, persistent invasive mechanical ventilation, unusual high doses of sedatives in these patients, long-term use of steroids, the environmental factors caused by the isolation from the family, and unfamiliar settings of healthcare workers in PPE with limited support contribute to the aggravation of neuropsychiatric complications. Ventilator asynchrony has been recognized as a challenging problem in severe COVID patients, and it can occur in all the modes. It has been reported that asynchrony index greater than 10%, that is number of asynchronies among the total respiratory cycles multiplied by 100, is associated with an increased mortality and more days on mechanical ventilation. High asynchrony index and high ineffective trigger index may also be the early predictors of weaning failure in mechanically ventilated COVID patients. Critical illness, polyneuropathy, and myopathy is a very challenging problem, and especially it has been found that in the early stages of COVID-19 patients, they have significantly higher risk of developing this complication. Patients with COVID-19, they also have higher levels of neurofilament light chain, NFL, and glial fibrillary acidic protein in CIM group. This challenging problem is responsible for high incidence of weaning failure in severe COVID illness, especially in elderly population and those with comorbidities. We also see a lot of endocrinologies and electrical disturbances. which is probably due to kidneys and GI tract involvement, resulting in severe fluid and electrolyte disturbances as complication of kidney and GI injuries. Most commonly, we see hyponatremia, hypernatremia, hypokalemia, hypocalcemia, hypokalemia, hypophosphatemia, and other changes in fluid body volume as the most common fluid and electrolyte disturbances. Multiple endocrinopathies are also seen, which will complicate the weaning process. So we need robust strategies for the optimal management of electrolyte and endocrinopathies in COVID-19 patients. Another major risk group patients in COVID-19 was obese patients with cardiac dysfunction. Obesity is associated with severe COVID and invasive mechanical ventilation, and it is also a risk for hypertension and cardiovascular disorder. There are multiple mechanisms involved, which will include hypoxemia, cytokine storm, microvascular thrombi, coronary plaque instability, systemic and vascular vessel inflammation, myocarditis, sepsis-related cardiomyopathy, and stress-induced cardiomyopathy, and arrhythmias. So weaning failure in this population may be due to heart failure, respiratory muscle weakness, and sepsis. As during the weaning process, the shift from mechanical ventilation to spontaneous breathing induces a negative intrathoracic pressure that can further aggravate cardiac insult in these patients. Respiratory efforts in these patients should be carefully monitored and controlled to minimize the risk of spontaneous risk of lung injury with careful titration of sedation, selecting the appropriate weaning mode. Malnutrition is another problem because the effect of inadequate nutritional intake can persist as metabolic and nutritional effects on the disease, and it can lead to hypermetabolism, weight loss, taste changes, and reduced appetite. Therefore, this nutritional substitution requires ongoing work to optimize the nutritional status across the clinical course to help mitigate these effects and subsequent help in weaning process from the ventilator. We should have a robust physiotherapy strategies because implementation of physiotherapy physiotherapies in these patients affected with COVID-19 admitted to ICU prevents the complication and contributes to stabilization of patients in critical periods, facilitating their weaning from mechanical ventilation and further recovery. So how to establish a successful weaning protocol? So we must define the weaning failure. Weaning failure is defined as a failure to pass spontaneous breathing trial or need for reintubation within 48 hours following extubation. It is important to predict the success of weaning to reduce the rate of reintubation because it is associated with 7 to 11 times increase in hospital mortality. Although 10 to 15% of reintubation rates are normal in well-run ICUs. Classification of weaning by duration is divided into 3 categories. That is simple, that is ventilator is discontinued after the first assessment. Difficult weaning is ventilator discontinued from 2 to 7 days after the initial assessment, and prolonged weaning when the ventilator discontinuation occurs after 7 days of initial assessment. So how do you approach the successful weaning? It is gradual and a 2-step process. Weaning parameters should be assessed, which is called wean screen, and weaning trials should be performed. Screening for ventilators should be performed daily on routine basis. The wean screen should be performed daily, which includes stabilization of the lung disease. Low FI patient should be on low FiO2, that is within 0.5, and PEEP should be between 5 to 8 centimeters water. Hemodynamically, patient should be stable without vasopressor, very little vasopressor, and patient should be able to initiate spontaneous breaths, or they must have a good neuromuscular function. How do we optimize the respiratory muscle power? You should always ensure adequate nutrition, avoid neuromuscular blocking drugs, decrease steroid use, and other contributors to critical illness weakness. Encourage spontaneous breathing trial to avoid spontaneous breathing, but try to avoid the exhaustion. Normalize the electrolytes, normalize the FRC. Make sure physiotherapy is being given at to these patients. How do we decrease the respiratory work? You sit up these patients. Don't make them in supine position. Don't make them remain in supine position. Sit up these patients. Decrease the respiratory demands by decreasing the CO2 production. Treat the pyrexia. Treat the agitation. Avoid overfeeding and minimize the dead space. Correct the acid-base disturbances. Decrease the resistance and increase the compliance by treating the lung disease and decreasing the abdominal distension. Optimize the ventilatory drive by decreasing or stopping the sedation. Consider the causes from brain to the neuromuscular junction. Increase the oxygenation and carrying capacity to try and correct the anemia, correct the acid-base disturbances. Avoid and address the cardiac dysfunction and address the sputum clearance. Indices that will predict the successful ventilator discontinuation will include the respiratory rate less than 30 breaths per minute, tidal volume of more than 5 ml per kg or more than 325 ml, and STC of more than 15 ml per kg. It will predict the success. Minute volume should remain less than 15 liters per minute, and because patients are unlikely to wean if it is greater than 15 liters per minute. Look at the maximum inspiratory pressures, which should be less than 30 centimeters of water. Then you can look at some indices like rapid shallow breathing index, P 0.1 over P Imax index, crop index, then integrated weaning index and core index. Besides these, because all the above indices will focus only on lung functions. But there are other domains to look at, that is general medical condition, that is the disease resolution, nutrition and anemia and conditioning, ability to protect the airway post extubation, which is different from weaning assessment. Recently, or rather more and more evidence has been published now, which tells us that early tracheostomy in these patients, led to early ventilator liberation and decreased sedation requirements. This group of authors, they found that their results were very good after tracheostomy in this population, and with short time to liberation from ventilation and high rate of decantation prior to the hospital discharge. FDA has recently approved 3 different technologies, which will basically act to the electrical stimulation of diaphragm or other breathing pump muscles, which will help to rebuild the strength and facilitate weaning from mechanical ventilation. Successful use of these devices will reduce the time on ventilator, ICU length of stay, hospital length of stay, secondary pneumonia, and rates of extubation failure and overall morbidity and mortality. So, but these none of these devices have so far been employed clinically. We may see their use in the near future. With this, I will probably like to end my lecture, and if there are any questions, I'll be happy to take them. Thank you for listening.
Unmute, ma'am, please. Ma'am, please unmute.
Yeah. It was a wonderful talk, I must say, and a lot of points covered over here. So basically, nutrition and all other factors that were mentioned are very important in weaning of the patient.
Yes, I think nutrition is something which we should be worried about right from the beginning. When these people come, they're already, they're having less voluntary intake, they are dehydrated. So we have to look at the nutrition in a little more aggressive. We should give nutrition a little more aggressive approach than we do for the other patients.
Yeah, because in COVID patients, mostly, I think that one factor what I've observed